We had a cadaver demonstration on porcine cadaver in the lab today morning for transforaminal. So today I think we have dedicated our day for transforaminal endoscopy. So we will be starting with our talks shortly. We had a cadaver demonstration on porcine cadaver. Let us check. Do we have Dr. Anup Datta here? For you are ready with your talk? Today I think we have dedicated our day for transforaminal endoscopy. So we will be starting with our talks shortly. We had a Anup will be speaking on OT setup for transforaminal. Do we have Dr. Anup Datta here? For you are ready with your talk? Today I think we have dedicated our day for transforaminal endoscopy. So we will be starting with our talks shortly. Anup will be speaking on OT setup for transforaminal. Do we have Dr. Anup Datta here? You are ready with your talk? Today I think we have dedicated our day for transforaminal endoscopy. So we will be starting with our talks shortly. Anup will be speaking on OT setup for transforaminal. Do we have Dr. Anup Datta here? You are ready?
The problem with students and delegates who attend is that they don't understand the technique itself. So therefore what we did this time and what we tomorrow will be rescheduling it a little later and adjusting the times to make it more comfortable. Showcase, I will show you one technique here. You learn the problem with students, whether you're a faculty, whether you're a delegate, that they don't understand the technique. It helps to learn the technique. And then therefore what we did this time and so the morning tomorrow will be rescheduling a little later and adjusting then after 9:30 the regular more comfortable. Showcase, I will show you one morning keeping in mind the fact that you learn the problem with if you don't know what is whether you're at the point you don't understand it helps to learn the technique. And then therefore what we did if you don't know how the director is going, if you don't know how the guide wire is going to go in. And then after I think it makes a very sorry figure for us that we are not able to come one morning teacher in mind. So that is why we have changed the paradigm this time. What we have tried to do is we have tried to introduce lectures that teach you how to do it. Therefore what we did if you don't know how the director will start from the basics, the morning talks on all basic. I think it makes a very sorry we'll start figure for us that we are not okay. Thank you. I hope I don't need to repeat this tomorrow. So that is why we have changed the paradigm this time. What we have tried to do is we have tried to introduce lectures that teach you how to do it. Therefore what we did if you don't know how the director will start from the basics, the morning talks on all basic. I think it makes a very sorry we'll start figure for us that we are not okay. Thank you. I hope I don't need to repeat this tomorrow. So that is why we have changed the paradigm this time. What we have tried to do is we have tried to introduce lectures that teach you how to do it. Therefore what we did if you don't know how the director will start from the basics, the morning talks on all basic. I think it makes a very sorry we'll start figure for us that we are not okay. Thank you. I hope I don't need to repeat this tomorrow. So that is why we have changed the paradigm this time. What we have tried to do is we have tried to introduce lectures that teach you how to do it. Therefore what we did if you don't know how the director will start from the basics, the morning talks on all basic. I think it makes a very sorry we'll start figure for us that we are not okay. Thank you. I hope I don't need to repeat this tomorrow. So that is why we have changed the paradigm this time. What we have tried to do is we have tried to introduce lectures that teach you how to do it. Therefore what we did if you don't know how the director will start from the basics, the morning talks on all basic. I think it makes a very sorry we'll start figure for us that we are not okay. Thank you. I hope I don't need to repeat this tomorrow. So that is why we have changed the paradigm this time. What we have tried to do is we have tried to introduce lectures that teach you how to do it. Therefore what we did if you don't know how the director will start from the basics, the morning talks on all basic. I think it makes a very sorry we'll start figure for us that we are not okay. Thank you. I hope I don't need to repeat this tomorrow. So that is why we have changed the paradigm this time. What we have tried to do is we have tried to introduce lectures that teach you how to do it. Therefore what we did if you don't know how the director will start from the basics, the morning talks on all basic. I think it makes a very sorry we'll start figure for us that we are not okay. Thank you. I hope I don't need to repeat this tomorrow. So that is why we have changed the paradigm this time. What we have tried to do is we have tried to introduce lectures that teach you how to do it. Therefore what we did if you don't know how the director will start from the basics, the morning talks on all basic. I think it makes a very sorry we'll start figure for us that we are not okay. Thank you. I hope I don't need to repeat this tomorrow. So that is why we have changed the paradigm this time. What we have tried to do is we have tried to introduce lectures that teach you how to do it. Therefore what we did if you don't know how the director will start from the basics, the morning talks on all basic. I think it makes a very sorry all will start together for us. We are on day morning, so I hope I don't need to repeat this. That is why we have changed the paradigm. What we try to do is we try to all will start together for us. We are on day morning, so I hope I don't need to repeat this. That is why we have changed the paradigm. What we try to do is we try all will start together for us. We are on day morning, so I hope I don't need to repeat this. That is why we have changed the paradigm. What we try to do is we all will start together for us. We are on day morning, so I hope I don't need to repeat this. That is why we have changed the paradigm. What we try to do is all will start together for us. We are on day morning, so I hope I don't need to repeat this. That is why we have changed the paradigm. What we try to do is all will start together for us. We are on day morning, so I hope I don't need to repeat this. That is why we have changed the paradigm. What we try to do all will start together for us. We are on day morning, so I hope I don't need to repeat this. That is why we have changed the paradigm. What we try to
So our penetration of this radioablator is very less, so collateral damage is very less in case of radioablator. There are some advanced equipment like navigation system, the electromagnetic or optical for precise placement of the needle and instrument without much radiation exposure. This is also an advanced instrument, tip control bar, tip control articulating nucleus resector. There are some miscellaneous equipments which helps us for better performance. It's like bolster, and irrigation is must. There are two types of irrigation. One is pump driven and other is gravity assisted. In case of pump driven, it should not exceed 20 centimeter of water, and we should always check whether patient is developing any headache. If patient have complaints of headache, then we should check the pressure. In gravity assisted flow, bottle should be 1.2 to 1.5 meter above the patient back. And spinal drape, camera cover, floor suction are miscellaneous equipment. In conclusion, the OT should be spacious, well designed with best ergonomics, best visibility, flexibility of fluoroscopy, CR monitor, best camera and video monitor, and camera and video monitor height should be at the level of surgeon's eye. The OT should be dust and spore free, well ventilated. And thank you.
Thank you. Thank you very much, Anup. So we will not take the questions at this point of time because we are running short. So we will proceed with the next talk. Now I invite Dr. Rishikesh Saudekar. Is he here? Dr. Rishikesh? Okay. Next is Dr. Kiran. Dr. Kiran Jaiswal. Are you ready with your talk? Yeah. So just one small comment about the instruments and the OT setup. Now what happens is in the beginning of the practice when we are just starting, we are in double minds whether we will be able to do this technique. So we are not ready to invest a lot of money. So what we try to do is we try to buy some substandard equipment, low resolution endoscopes, low resolution cameras. But actually it is the reverse. When you are not thorough with your technique, you should be perfect with your instruments. You should have the best instruments and best setup in your hand, particularly when you are starting any new technique. Because otherwise, if you fail, you get disheartened, you get bad results, and then the technique goes into disrepute. So my advice to all the beginners would be to invest in your setup, invest in your instruments, particularly when you are a beginner. Once you are a master, you can do about with any kinds of instruments you have in your hands. So that's my one advice to all the beginners. So Kiran, we are waiting for you. Narendra, are you prepared with your talk? Yes, yes. Yes, Sean. Yes. So usually for spine endoscopy, we use specialized drapes which has got pouches which can collect the irrigation fluid, and in advanced setups, we can also recycle that fluid and bring it back to save on the irrigation fluid which is wasted, because particularly in some surgeries like fusion surgeries in UBE, we may end up spending around 40 liters of irrigation fluid in one surgery. So even that is possible, but not in every setup. So what we do is we use some drapes, specialized drapes, which are hydrophobic and which has got collection pouches which can be attached to your suction, and so you keep the entire field dry, and even the surgeon is dry throughout the surgery. So that is one thing which we can use. Thank you, Sean, for pointing out that. But I particularly am not fond of irrigation pumps in any of the endoscopic spinal surgeries, any technique, whether it is monoportal interlaminar, whether it is cervical surgery, whether it is transforaminal, thoracic. Usually the gravity is sufficient to give you enough pressure. It is more safer system, and it should not happen that inadvertently the pressure increases and there is some injury to the patient. There have been reports where due to severe increase in the irrigation pressure, patients have got seizures on table, patients have got optic atrophy, patients have lost sight, they have got blindness. So we don't want all those complications. So I think irrigation with gravity is sufficient for all the cases of spine endoscopy. But then that is particular surgeon's choice. Some people want completely bloodless fluid and they use irrigation pumps. I'm not against it, but in my particular practice, I prefer to use irrigation with gravity rather than artificial pumps. Sir? Yes, for a transforaminal surgery, first thing is you should have the best scope, best camera, best screen, the light source, and usually the light source, camera and all these things are there in all the good equipped theaters because they are used even for laparoscopy and arthroscopic surgeries. Particularly for this system, you should have specific spinal needle, the guide wire, then the specific dilator and cannula of the similar make from which you are purchasing the scope, because they need to adjust to each other. And then you need a simple grasping forceps. I am particularly fan of one particular design which is called as Blakesley design. So it is like a beaked forceps with an eye in between, so you can actually see what you are grasping. So you need a basic grasping forceps, you need an annular cutter, you need a RF probe, and then you need some burrs, some drills. So these are some basic equipments which you need to start off your practice. So usually the hand instruments you can purchase, you can mix and match. These systems you can mix and match. The only prerequisite is all these instruments should pass through the central channel of your endoscope. So the dimensions should match. If you have an endoscope which is 3.5 millimeters of central channel and your hand instruments of 4 millimeters, then they are useless. So that is only the thing which you need to match. Dilator cannula are system specific, so you need to buy exactly the same make, otherwise they won't be useful for you. Radio frequency probes, you can mix and match, you can use any other company for any endoscope. But yes, it is a prerequisite. You should have a good RF probe with you, particularly in the beginning of your practice, because if there is a bleeding, then it completely obliterates your view and you are unable to see the spinal nerve. So it is very difficult. So you should have a good RF system with you at the start of your practice. Yes, sir. You're pointing out something else? Yeah. Plasma probe is a newer system where they say that it is similar to radio frequency, but what it does is it creates an electron plasma around the tip, and that is what is used to ablate the tissues. So it has lesser collateral damage, and particularly in difficult situation where there are crevices, particularly in interlaminar approach, you come across some bleeding in the lateral recess. So it is very difficult to point out where exactly the bleeding is coming from. Same is the case when venous sinusoids from the bone open, when you are doing a drilling or you take a big chunk of hard bone from the lamina, the venous sinusoids in the bone, they open and you cannot coagulate them very easily. There where these plasma systems are very useful because they create a small plasma globe around the tip, and that can easily coagulate all these venous sinusoids and give you a good bloodless fluid. But there is also a problem with these plasma systems. They are very sensitive. When you are using it close to the nerve, I found out that even at the lowest electrical adjustment, you get twitching. You are afraid because it irritates the nerves. So that doesn't happen with your regular RF probes. So RF systems, they come from 2.1 megahertz to 4 megahertz to now even 6 megahertz. So these are very safe. So depending on your choice, you can use RF or plasma, whatever you need in your own setup. तुला मी हे देऊ का पेन ड्राइव देऊ का Okay, do we have Dr. Rahul Aluwalia? Yeah. Kiran, please come. Otherwise, I will start your presentation. Yes, sir. Thank you so much, sir, for that very nice question to fill in the time gap. Yes, we can use all types of burrs. The few requirements is that burr in transforaminal surgery should pass through your endoscope. It should have be sufficient length. The diameter should be at least 3 millimeters or more, because the smaller burrs, they don't work well in lumbar spine because the bone density and the dimensions are big. So if you are using a 2 millimeter burr for your surgery in lumbar spine, you had it. So it should be at least 3.5 millimeters diameter of head. Then you can use a cutting burr, steel burr, or a diamond burr. Diamond burr has an advantage that whenever you are drilling the bone, you get a very smooth edge and it creates a thin paste of bone with the irrigation fluid mixed with it, and it gives you a very good bloodless fluid. So it actually packs the venous sinusoids and you get good hemostasis when you are using a diamond burr. So yes, but then there are some instances where the bone is very sclerotic. You're ready? Okay, so let's proceed with the Kiran's talk.
Am I audible? Yes. I'm Kiran Jaiswal, endoscopic spine surgeon. Here, my Topic of the day is trajectory and especially alpha S1. So this is our spine model. We can see three-dimensional spatiometry, and in the morning we just marked into the transforaminal how we can demarcate the trajectory lines. The basic of it here, you should understand the foraminal anatomy, the margins, because your bones are the best friend into the transforaminal endoscopy or any of the endoscopic spine surgery. Your landing point is your bone. You should understand where you have to land. Here in transforaminal, you have to land at the bony lateralis zone, the lower one-third of the teardrop of the foramen, because it's not working on the this wide field. That's why. So you should land your end point here from this area, lower one-third. Your needle should enter into the annulus, because here you are targeting the fragment. It's not kind of, this is target specific surgery. Here you cannot perform entire decompression. Here this is for the soft tissue or foraminal or lateralis zone target specific surgery. You can use whatever the tool available with you, including power system, including like RF plasma, or even manual burrs, manual refines you can use to assess the site, to assess the fragment, to widen the foramen for the foraminoplasty, to decompress the lateralis zone. So your trajectory is important. You should know where you have to land into transforaminal. It's very easy, the simplest form of the surgery you can perform. This is the only surgery you can perform under local anesthesia. You need not to have to go for the general anesthesia, spinal or epidural anesthesia. You can just infiltrate the tract and proceed accordingly. Sometimes, if the annulus is very painful and inflamed, we have to infiltrate the annulus, because this is the portion, this is the point, is the maximum painful point. Once you negotiate it, there is no pain. Patient is also relieved, you are also relieved. This is kind of a rewarding surgery. You can have nice sleep at night. Patient also have night sleep, at very good sleep at night after surgery. The complications are least minimal. If you target specifically, you could decompress specifically. You can walk out of the, even your hospital, patient also can walk out after 2 hours from hospital. So this is daycare surgery. For that, trajectory is important. So you understand the foramen, anatomy of the foramen, the structures which are coming out of the foramen. This is the important thing, right? Like, what happened? Sorry. Okay. So the structures that are coming out of the foramen, you should understand from where the nerve root and DRG coming out, from where the vascular vessels, your foraminal vessels are there. You should understand the foraminal ligaments, and the most important portion is you should not bang your needle or your introducing needle over the upper half. You should not land your introducing needle over here, only the lower half. This is the safest zone, that is known as Cambridge triangle. All right. So the Cambridge triangle, in upcoming talk, the many more things will come up. The dimension of the Cambridge triangle, how much like diameter, dimensions are there. But you can accommodate your cannula freely, nicely, without damaging any of the nerve root from this safe triangle of the Cambridge. For that, like skin marking of alpha S1, So first, make the Ferguson. So your end plate should be parallel. Either you tilt your C-arm, image intensifier, or tilt your table. It's a Ferguson. So your both end plate should be parallel. If it is alpha S1, so alpha and S1 end plate. If it is L4 phi, but end plate should be parallel. And take a midline. In the morning we took spinous process line. Sometimes it is scoliosis. You have to identify which segment, which zone you are proceeding and make it. So upper and lower spinous process. And then make the spine line, midline. See, many of the time your midline should be like zigzag. If it is little bit degenerative scoliosis, it's not always into the straight line. So midline of your targeted zone, L4 phi or alpha S1. Second thing, disc line. Third thing, disc inclination line. Right. And with that, you can mark the depth also. In the disc inclination line, you can see your disc is in the Ferguson line, the stream in the line of the Ferguson line or disc line, or whether it's inclined. Most of the time in alpha S1, you have to go supra iliac or transiliac. Your entry should be not, it will not be into the disc line, same line. So you have to select the trajectory. I'll show it. So many of the time what happen? This is suprailiac entry. If it is foraminal work, then it's okay. Otherwise, you cannot proceed for that. This is your disc line. So for that, you have to select transiliac route. But while selecting transiliac, you should not damage the joint, SI joint. Otherwise, it may cause pain for longer time. So for alpha S1, there are two entries. Suprailiac entries and transiliac. It is too high when it is encroaching the upper L4-5 or L4-5 disc till L4-5 disc. It's too high. Always select this, or second, you switch over. Here you have to decide interlaminar versus transforaminal. With the same scope, you can proceed with the interlaminar because this window, interlaminar window is very wide. So you don't have to do much bony work. And you can enter, you can remove the fragment distracting or remove distracting the dura, removing that fragment. Wherever it is central also you can remove, foraminal also you can remove. Right? Extra foraminal work here you can do with this inclination, otherwise transiliac for transforaminal. In interlaminar, you cannot do under local, either pure epidural, pure spinal, or general anesthesia. If your patient is fit, you can do under general anesthesia or even regional. But transiliac you can do under local. Infiltrate the tract, infiltrate the bone, infiltrate the cortex, punch or like puncture it, proceed, land it, and again infiltrate the tract, and then dock on the annulus or fragment wherever your target point you decided. The same way this is into the lateral. So this is your disc inclination line also. See, here it comes. So same way you have to define the trajectory, you have to tilt the table, tilt the C-arm. So here, see, this is little higher, not that much higher. So you can see this inclination line is this, right? Here is your iliac crest, disc line and this. Then you have to go suprailiac. Just measure the depth, mark it, and introduce from this cross section area, disc inclination and disc line. Where it intersects, from where you can introduce your indle and proceed into the foramen. In lower L45, alpha S1, your landing point of the needle should be medial pedicular line, but as you go up 3, 2, 1, it should be middle or even lateral. So middle pedicular line. So you should not introduce further medially to pierce the annulus. Unless your disease is too high, you have decided that I want to pierce from the medial pedicular line. Because sometimes after long experience, you can decide whether huge herniation, central, bilateral, paracentral. So you can assess with your armamentarium, everything you have, you can assess this fragment under local. So this is alpha S1 transiliac approach. But see, this joint should not be violated. Otherwise, this pain will persist for long. So AP in lateral, right? You have to restrict your entry to the foramen, right? How? See, it's a kind of a very far lateral entry. Very far lateral in alpha S1. You have to enter from very far lateral. It's not about kind of 45 degree entry, or because here you won't have any other route. Once you puncture this, from this you have to assess. So around 8 millimeter of the cannula, you can ream around like 9 or 10, so that you can little bit mobilize your sleeve. Sorry. So that was for the alpha S1. For L45, as I said, it's into the disc line. Sometimes in L45, you can find iliac crest, but you are just touching. It's kind of alpha for alpha S1 suprailiac. Here you are just flushing to the iliac bone. So again, you have to define whether how much fragment, how much deep you want to go. In central, paracentral fragment you want to. Here in L45, you can assess central fragment also. You can even try to decompress the contralateral paracentral zone also with the curved instruments and bendable RF now available. That is different companies they are making. So you can use plasma, decompress. So you can decompress soft tissue decompression into central by paracentral in L45, right? In lateral, that is what, it's the same. The disc line and disc inclination line is same for L45. For alpha S1, it was different. So this is the difference between upper L45 and lower alpha S1 trajectory. Once you fail, or rather 2, 4, 5 millimeter trajectory is different, your end point will differ. It's just about millimeter of the difference into the trajectory. Then you have to do a lot of work to assess that central fragment or paracentral fragment, because this is purely based on your pre-planning, defined trajectory and introduction of your needle. The same needle you can enter in the annulus from the lateral pedicular line also. See, if I want to assess this here central fragment, I have to enter into the annulus from the medial pedicular line. But if I want to assess this fragment into the foraminal and lateral recess zone, then I have to enter into the middle pedicular line. There is nothing to do much more here. If I want to decompress here only, if I want to decompress into the central zone, my trajectory and entry point of the needle into the annulus is here. For the central or foraminal and lateral recess zone, it is into the middle pedicular line. But as you go up, your dural sac will come into the foraminal zone. So you can puncture the dura if you go in upper level into the medial pedicular line. See, these are the few basic things if you keep in mind, you won't have any complications related with the dural injury. As such documentations are there, there is no or least dural injury chances into the transforaminal, but initially you can injure the dura, you can paralyze the patient. If your plan is not proper, your trajectory is not proper, or already compromised canal you have introduced, there 8 to 9 mm, 8 mm sleeve inside. So already compromised canal, and you are compromising it further for the next 20 minutes. See why I am telling this? These are the basic 3, 4, 5 points. If you take care of it, this is the beautiful surgery on this world. For any age of the patient. My 99 years of grandma can also, your 16 years child can also have without hesitations, because there are a lot of hesitation into the spine surgery into the younger. Why should I cut the bone? Why should I cut? See, in younger patients, there is always soft tissue. There is no bony canal stenosis. It's always soft tissue canal stenosis at the age of 30 or 40. You can give this option because there is zero bony work. You don't have to do much more bony work. So this is all about needle entry point, which I said. So it's not about the like 8 millimeter, 8 centimeter or 10 centimeter. It's about the pre-planning of the MRI and X-ray. You can club it before introducing your needle. You can find out, right? The most common complication here you encounter is into the left side, it's almost sigmoid colon and retroperitoneal structure. That's why you should be shallow rather than the deeper. Your entry point should be like whatever the entry point into the skin you decided. Don't go try to touch the bone. It's always into the steeper and then deeper and then deeper. Always it's better to be steeper than the deeper needle entry. Otherwise you directly, see, there are 4 or 5 suits you require, but it is safer, and infiltrate the tract. Your patient will be comfortable throughout the surgery. So what I said and what we discussed on the X-ray, this is the things. And this is what you can assess. These pathologies you can assess. So see, this is going to help you, as I said, from skin to the annulus. Skin entry and annulus entry point is the main thing you define. This is kind of a tailor-made surgery. You are the boss, you have to decide where I have to target. But once you misfire, then you feel that or encounter with the fail surgery. There is nothing like fail surgery into the endoscopic spine, into the transforaminal, because it's target specific. If your pain generator is not this disc or this annulus or this facet, then your patient will come with a persistent pain. You have to identify the source of pain generator and then decide. So these are the steps. Then transforaminal endoscopy. Done. Thank you.
Yes, thank you, Kiran. Can we have the next speaker, Dr. Narendra? Till Dr. Narendra sets up his talk, I will just make a small point. Kiran just now showed you the trans-iliac approach. One should be taking into account the position of superior gluteal artery and neurovascular bundle, which is exactly 5 centimeters from the line joining the posterior superior iliac spine to your greater trochanter. If you draw, this is the basic surface marking, the anatomy. If you draw a line from posterior superior iliac spine to greater trochanter, just 5 centimeters away from the posterior superior iliac spine, there is superior gluteal artery, which is the main branch of the internal iliac. And in case you puncture that, you will have catastrophic bleeding on table. So you should be aware of this particular structure?
That will be covered into complications of the spine, endoscopic spine surgery.
Okay.
Thank you.
So Kiran in his talk made a particular point that this is a very targeted surgery. So few salient points which I could make out from his presentation is we are entering the Cambin's triangle between the two routes, that is the exiting route and the traversing route. So these surgeries are always done under local anesthesia where patient is aware so that in case you poke the nerve, patient would able to respond and tell you, and so there is no injury to the nerve or there is no catastrophe during these surgeries. Yes, there are few centers, particularly in Germany, where the patients are afraid of local anesthesia and they do all their surgeries under general anesthesia, but then it is risky. And in that case, you follow certain protocols, like whenever you are putting your needle, it should point into the lower part of the intervertebral foramen towards the lower end plate of your disc, targeted disc. Why? Because then you stay away from your traversing route. So this is one important point. Yes, Narendra, please go on.
A very good morning to one and all. Uh, Actually, I'm nostalgic. This is reminding me of the first days of. I was the first batch student for Dr. Malcolm sir and Dr. Kavi sir. They are both my teachers. It is making me more, nostalgic to speak in front of them. But I'll take this opportunity, and I feel honored that I can give them. I can talk about this. Before starting a talk, we were so lucky. We four students, Dr. Adam, me, Dr. Shantanu Malik, and Dr. Ramesh, that Malcolm sir and Kavi sir had taught us, putting his hands over us and letting us feel the facet first and getting introduced into the facet. That was the first fear we had. And after that, when we went home, we conquered that fear and had performed a number of numerous transfemoral surgeries. So I'll start, and a Guru Vandana to both my teachers. Transfemoral surgery endoscopy, it is not, it's a precise art. It is not something called as debulking. It is precisely targeted fragmentectomy. Where you land determines your ability to remove the fragment and treat the pathoanatomy. Basic targeting has been determined by the boundaries of Cambin's triangle. Cambin's triangle, as described by sir, is a holy grail. You cannot deviate or you cannot make it unsafe. You always have to land in between the boundaries of the two end plates and the nerve root. So my talk would be now from line, our post to line marking, from skin to the disc in a simple case. So for the sake of convenience, I've divided it into various steps. The skin marking, as nicely explained by the previous speaker, mark the midline, identify and mark the disc, marking of the depth of the disc. Now we'll be starting the next step, that is insertion of the needle, insertion of the guide wire, dilator over the guide wire, and placement of the cannula. So inserting the needle. Needle insertion is the key to all surgery. You do it half an hour, 1 hour, no problem. But if you land at a wrong place, all things are in vain. It has to be exact and precise. Proper use of needle is the cornerstone of any successful endoscopic spine surgery. So the principles are, there are two gauges available. One is 20 centimeter and 18 gauge needle is the mostly used needle. And it has graduated marking of 1 centimeter over it. It has a triple marking at every 5 centimeter, and it is with a lever lock, which is always faces the bevel. Now we'll be talking about the principles of needle insertion. The needle will always go towards the tip, not towards upwards. This is the basis we have to understand. Without understanding this, we cannot master our skill. Second is, for every 10 centimeter of the travel, the tissue resistance puts it 1 centimeter, deflects it 1 centimeter ahead. So needle will always deviate away from the surface of the bevel end. Good endoscopic spine surgeon can make a needle thanks to his tunes. So if you want to go ventrally, just make the bevel topsy-turvy. If you want to go it cranially, make the bevel towards the caudal side. If you want to go towards the cranial side, just make the bevel to the caudal side. The second principle is, the AP view will always give you the direction. The lateral view will always give you the depth. So when you cross over, the first give way would be of a thoracolumbar fascia. The moment you cross the thoracolumbar fascia, your needle will become more light and will further deflect. And the next resistance would be felt at the intertransverse ligament. We have to be aware at this point, because mostly there the pain starts. So the ideal way is, you inject 1% of xylocaine, dilute it from 2% to 1%, because that is very precise for your sensory modulation. We'll avoid the motor modulations. The moment you put in your xylocaine, it also avoids the vasovagal that can be induced as a complication. And the third resistance would be felt at the annulus. Our aim, as rightly said by the previous speaker, is to reach the posterolateral corner of the disc. You have to correlate that with the medial pedicular line in the lower lumbar zone. Rough markers for an average Indian we are speaking. This is not a very precise one, but this should be one thing which should be keeping in your mind. At roughly 9 centimeter, you should be landing in the lateral pedicular line, hitting the facet. At 9.5 centimeter, you are in the mid pedicular line, just in the facetal zone, within the foramen. And at 10 centimeter, you are at the medial pedicular line. And in lateral, you must be collating at the posterior annulus. At 12 centimeter, we are at the middle interspinous line. And in ideally, you should be in the posterior 1/4 in the lateral view. Now the guide wire. The guide wire is around 0.9 mm and it's around 41 centimeters long. It is a malleable steel wire through which you pass through the endoscopy spine surgery needle. Guide wire is the pillar of which all subsequent instruments will pass. After passing the guide wire, gradually remove the needle with a twisting movement, keeping thumb on the guide wire. That thumb pressure should be so adequate, not piercing, but should be bare enough to avoid plunging into the disc. Ensure guide wire with gentle pressure, avoiding accidental breach of the disc. Always make sure that the tip of the guide wire is straight, because if it is beveled, then you would be having a trouble. The dilator is used to dilate the path atraumatically, reaching the foramen and the spinal disc. It is around 22 centimeter long, has 2 working channels in its central and the eccentric one. The eccentric one is mostly used to give the lignocaine, I want to say the anesthesia. Proximal bit of is around 1.5 mm, and that is having a high density so that it can help you to radiologically locate where your tip is and where you are actually landing. The dilator can be used to get more horizontal by using your facet as a fulcrum. If you find that facets are hypertrophied and you are not able to go more horizontal, or you're going more deep, what we can do is, once we cross the facet, we can just remove the guide wire and we can just make the dilator become more horizontal and enter in. So dilator can be used to become more horizontal using facet as a fulcrum. The sleeve is around 17 centimeter in length. It is graduated again by centimeters. Sleeve is mounted on dilator always. The tip is called the tang. Opening is bevel out, and we should be thankful to Dr. Young sir, because of that invention we can now visualize the intradiscal as well as the epidural part. That is in, out and inside. While always putting your sleeve, we should be taking care that we should follow the, if we are going on a left side, you have to put your hand like this. So this index finger is the traversing root and the thumb is the exiting root. This joint or V is called the axilla. You always have to see that a tang is away from the axilla. On the left side, on the right side, you make it a topsy-turvy. That is, right side thumb is the exiting root and the this index is your traversing root. After this, you'll be reaching the disc. So I'll be handing it to the next speaker. Thank you.
Okay. Thank you, Narendra. I think we are done with this session. We will take a small break of 10-15 minutes, have some refreshments and come back in the hall for the next session.
Hello, we are starting with Dr. Neeraj Jain's talk. This is our special session for orthopedic and neurosurgeons to learn how to manage pain. So I request all orthopedic and neurosurgeons to move into the auditorium. This is specially for you all. It's a special session only for orthopedic and neurosurgeons because the pain people are already masters of this, and this has been devised specially for you all. Please, I request all of you all to come into the auditorium in a minute or two. We are starting with the talk. We are already running late. Can I please request all delegates to move in now? This is a special session, and this is very important for faculty as well as for delegates. We have to learn to manage our basic pain problems, our basic blocks, basic techniques. So this session is going to give you an orientation on how to handle pain, how to overcome certain problems in the immediate post-operative period and things like that. So Dr. Neeraj Jain, may I please request you to start with the program.
Dear friends, good morning all.
Dr. Siddharth Verma, can you please take the chair above, please? Sir, please start, sir.
It's very, very satisfying to meet friends again. And this time we have included pain capsule. This time we included pain capsule as a special feature. And I think we have to do justice to the patient because patient primary problem many times is the pain. If you don't address the pain, the job is half done. So it's always good that we include pain as one of the lead topic in these conferences because ultimately patient is going to say thank you to you at the end of the day. After a very good surgery, sometimes still there's an issue. So I think probably we have to resolve that. So today we're going to talk about, and thanks to the World Congress team for inviting me to give a talk and share my experiences. I have 3 talks, by the way. One was the transfemoral epidural, one was the interlaminar epidural root block, and another was the ganglion impart block for coccydynia. And we know how big is the problem with coccydynia, tailbone pain after this COVID menace, and people sitting work from home, and especially with people who have a lot of tech job, a lot of sitting job. So we'll discuss that again, and then small capsules. There are 3 of them, by the way. 3 talks have been pulled together. So I'll try to do justice, and I'll be a little fast track, it. So please bear with me. So this is about interlaminar epidural. Now this is something which is a real rescue. Be it pre-operative, patient comes to you primarily, or be it the post-operative, or patient has been done a good job, and still patient is suffering. So we see how best we do it. But there are ways to do it, learn it, there are techniques to do it. There are complications, so we have to minimize the complication, maximize the results. That's what we really intend. And we know the technical problem, where the problem lies. And we really have to address the problem. If the problem is in the posterior canal, then we come interlaminar. If the problem is in the disco-reticular conflict, we try to come in the lateral recess or femoral block or the transfemoral root block. And that's where the whole problem lies. And there are chemical mediators. We had to inflammatory mediators. We had to dilute them, quieten them, and kind of take away. And sometimes even the corrective measures are taken physically. Now, the injections have taken lead over the other major interventions, and that's a patient wish. And many times now, good surgeons, they also wish so, okay, give a due trial. If it works, fine. Otherwise, surgery is always on. So that's how we think about it. And this is, we couple with the many procedures. We are doing so many interventions. And this is something we always couple with these interventions to get the maximum result out of a given patient. And if I did a good job with the disc procedure, if I didn't do this root block or the epidural injection, sometimes the inflammation still is a menace, it still is a problem. And we know the DRG stimulation, DRG irritation, which stays after for a few weeks after a good job done. And this is even with the cervical. We do all this interventions, cervical disc interventions, percutaneous. We got to give a root block. Now this is going away. I'll tell you why. And then interlaminar epidural, which Dr. Siddharth will talk. Now it is said again and again, there have been millions of epidural injections given. There is a reason for that. Otherwise, it would have not stayed for last 30, 40 years, the epidural steroids. it has shown better result than other measures or more operative measures, because many times it said many of these patients you can manage conservatively. You give an epidural, there's some waiting period, and patients spontaneously recovers. Those are the ones who don't respond well with epidurals. They need a surgery. They need higher intervention. Good, go ahead. And that's what said transvaal epidural is better than the interlaminar epidural in the lumbar region. When it comes to cervical region, this transvaal epidural was good, but because of due complications, serious complication, it is taken off the shelf. Now it's only interlaminar epidural which works. Yes, steroids is the choice. When you're giving an oral steroid, you go high doses, and then steroid has got its own menace, own issues. That's where you put in a targeted, specific, low volume, concentrated steroid, depot steroid at the target, and that's where it works. There are a few ways you do it. You do it in a caudal route. You do it a caudal route here, which will be talked by Dr. Siddharth, and this is the caudal neuroplasty. It's another very good procedure. When you talk neuroplasty, it's way above just an epidural. And we are mechanically lysing the adhesions and putting drugs in there. Then we have interlaminar epidural. Then we have a transfemoral epidural, which is going in from here. So we'll discuss few of the technical things. We cannot discuss too far. Always don't be a blind man. Always guide the blocks, be it fluoro, be it CM, be it ultrasound or CT scans. Because you may come with the surprises. This is a surprise. I'm going an interlaminar epidural right there, and you look at these two spots there, and you're getting into the facet joint. So these surprises, they sprung sometime, and you want to avoid these complications. Yes, the straightforward, we could do in the lateral position. We do in prone, in our OTs under fluoro guidance. But here, in our preoperative other rooms, wards and all, it's just like another LP or epidural we do in an operative setting. That's epidural lateral position, and that's in the sitting position. Again, a good way of doing it, because you have to keep patient more stable, but only vasovagal is something you have to be careful of. But that really is good. Now, you must have a total kit with you right in the beginning, because once you start the procedure, everything should be with you, and the kits are all available. They are very, very helpful, very helping with the catheters and all. And this is typical. We just have a very good grip, because this is something which every new person who is going to do an epidural should learn, that you should have a total control, a millimeter control on your needle tip, not in the hub side, the needle tip side, and that's where the whole thing lies. And that's the insertion. You have the insertion, which is the midline insertion, and you have the paramedian insertion. You can land in right in the midline here. That's the epidural space. Or we want to do a transvaal epidural, we just do a land at the root area, DRG block we call it, or lateralis block, we can land in here. There's another technique, which is paramedian, is coming from here and landing again in there. That's another way, because then you don't go through the calcified interspinous ligaments and other ligaments, number one. And number one is less traumatic to the ligament. Sometimes patients have a pain because of continued injury which was there in the interlaminar ligament, which is not healed yet. Well, what are the different drugs? Very simple. We do the local anesthetic and steroids. But the other supplements people should know. And that's more for anesthesia reasons. We have narcotics, fentanyl, other things, which can be added in the pain scenario also, and especially in the acute pain scenario. And then we have other drugs which are adjuvants like epinephrine, just for prolonged effect if need be. What are the commonest steroids? Depot steroid is something which you're looking for normally. But when you come into cervical, normally avoid depot. We want to go for non-particular material, because if it gets into the vessel, there have been instances, there have been data filled with the, literature filled with these data, where people have injected into the vessels, even in transvaal epidural root blocks, and there was a block and there was a cord ischemia, infarct. And hyaluronidase is another good molecule. Please learn, know it, because this is something which is going to lyse the adhesions. And when you're going to do mechanical lysis, you must add this before you do a mechanical lysis. Although it can be added in a routine procedure also in epidural, it's a precursor you can add before or with the steroid injections. The insertion route, I told you, is interlaminar. There are few points which is there. It increases the chances to reach the adjacent level. I told you when there's a canal issue, interlaminar. And must know when you have there are advantages and disadvantages that. Your volume can spread to some few levels. That's the advantage. But again, it's more of a non-specific kind of thing. When there's a disadvantage to that is that there is a potential of dural puncture. That's the biggest disadvantage if you're not careful about it. But even if you have punctured the dura, please don't inject your steroid and LA there. Avoid it. Come out. Change your track. Go one level above or below. In our experiences, we change the bevel, we change the direction, and we can still manage at the same level, but normally should be avoided if you have a steroid there because it can cause a harm. And that's how it looks like. With a good spread of drug, it can go few segments, but I would be more happy to see the roots all the side, both the sides going like this. But now there is something, a bigger point. Lately what I go is, I go on the side of symptom. Suppose the patient is symptomatic on the left side, I rather try to reach left side, because then you have a more concentrated drug at the issue level, and it's not going waste on the non-symptomatic level. So that's very, very vital point. I'll show you one more improvisation is lateral interlaminar epidural. We go to the side, suppose the lesion was here or at this spot, disco-radical conflict. I rather go to the side instead of going transfronally. I go from there and do my drug deposition. Now most of the drug is concentrated onto the side of the lesion or L5S1 disco-radicular conflict. You can see all the roots. And it's not wasted to the other side, which may happen otherwise. Now this is another very good add-on phenomena. The add-on is, instead of going root block, we go from the interlaminar spot and across, like you go over the top. You've been talking about the endoscopy, over the top interlaminar, and we're going over the top onto the other side and looking at the root. Very typical simile I'm giving you, because you understand that straight. And we're going in there. Now this is one patient who had a synovial cyst. Going over the top and rupturing the synovial cyst with a thick epidural needle right in there, and you can see the synovial or the facet joint arthrogram. You rupture the cyst, and if need be, you can go for surgical correction. But it really helps in such patients. There is ample evidence, because I told you there have been millions of epidurals been given, and ample evidence of level 1 and level 2 for the epidurals, be it caudal epidural, transversal epidural, interlaminar epidural. I told you transversal epidural was the best if you have a disco-radicular conflict. If it is a non-specific pain, interlaminar is the best. If you have absolutely no indication MRI-wise, then you can get caudal epidural, but I would rather avoid. But after all, it's a steroid. What are the key issues? What is the frequency? How many to be given? How often to be given and how quick to be given? What is the total numbers I told you? And one injection for diagnostic and therapeutic. Do we do separate injections, or we give straight one injection combined? And series of 3 regardless of the effect, whether the patient is showing effect or not. In principle, I'll give you quick leads on this, that we give one injection, wait for 2 weeks minimum and go for the next if need be. But if patient doesn't show a response, go for the second. If patient doesn't show a response, don't go for third one after the steroid. The total dose of steroid has to be limited. And to be repeated at, the protocol is 3, 6 and 12 months in 1 year, and then every year. I went to USA, there was a doctor, and he said, I'm getting an epidural every year, I'm fine for last 10 years. So these things are known because they don't have a very, very specific thing, they have some non-specific issues. And what is the limit? It's 3 milligram per kg, one injection shot. And what is the total is 210 per year and 420 for lifetime steroid. So please keep in mind, I've seen people giving steroid shots every other week, and then for what length, then you have all those syndromes coming to do with steroid. And then you have to use hyaluronic acid. Yes, one should use hyaluronic acid if there are adhesions and all. And what is the eye-size recommendation? I told you just like that, how many injections and what apart. And dose, normally, if it is first injection, I gave 80. When I start repeating, or I know I have to repeat more often, I just start with the 40. This is something I was trying to say. Be very, very careful. You're giving an epidural and suddenly you start seeing the shadow. When you have a straight shadow with the water sign there, that means you've gone intrathecal. Now this time you don't do injection. Just what you do, another thing is, tilt the table, turn the table up and down, headwards and footwards, and see if this is moving upwards, it's just an epidural. If it is moving upwards and comes back into the same place, when you tilt the table back, and then that means it is spinal. So that way you have to be careful. It is epidural spinal. Sometimes you get epidural and spinal both, I told you. This is what it looks like, typical myelogram. When the drug is concentrated in the middle, it's spinal. When this drug is concentrated all over or spread all over, then it's epidural, just like that. Another very, very dreaded complication. It happens 1 in 1,000 epidurals, may happen. It's not always. That's a subdural dissection. It's like dissecting aneurysm. Subdural dissection, if it happens in any patient, there is instant paraplegia. That patient doesn't really, thereafter, because you cut away all the vascular supply if you have a subdural injection. That is something one have to be careful. When you have any doubts, pause, obtain further images, take AP oblique, anything. Ask your friends to put more contrast, inject in lidocaine dose, to find out. Small dose of lidocaine or aliquots to know its spinal epidural. and switch to non-particle steroid, and then you can cancel the procedure. Observe the patient, do it another day. There are n number of complications known, although they are less often in experienced hands. But please, who people who are going to start, they should know there are n number of complications to with needle and to with the drugs. Drugs is okay, you can't really do much about it, but that's really something you have to be careful about. And then we're doing needle things, because there have been claims, and those claims are passed in millions of dollars in USA. We are a little lucky in India, we get in thousands and now few lakhs. Now there have been few instances of in millions also. So one has to be careful with these procedures. They look easy, but please, they have got their own share of complications. I keep saying angiography is easy with a cardiologist and interventional cardiologist. For us, it's a no-no. So same thing, there's an Iron Man with a big problem. I'm getting into the second capsule of my talk, and that's the femoral block or the root block. And that's where you come on and you have done a very good job. Still patient is in trouble because he's got a root block here. You go and give a root block there, or neuroplasty. Means another very renowned procedure, RAX procedure, and it has shown its good effect in its own time. Now we gone a little ahead of that, and the spring-loaded catheter through a specific needle. You put in there, and there's a procedure. Please listen few lines. Normally talk less and show more, but here is after placing catheter, confirm with the 3 to 5 ml dye. We use about 1500 units of hyaluronic acid, hyaluronidase, in 10 ml of saline. And we can give in aliquots, or we can go in one go just to lyse adhesions. This is called a volume. It is already said. It's not only the steroid works. It's the volume which also helps these patients. So please, they have done with saline only, and they found a good result even with that. And then you have the LA plus steroid. You give one shot, and then they are giving 10% hypertonic saline slowly, because LA hypertonic saline is very, very painful. So LA really precursor is given, so just to not to have the pain of that. Just like alcohol, we put anywhere, it causes a problem. So here we don't put alcohol, obviously. Hypertonic saline takes away all the edema, and it has got so many other things, quercetin C fibers and 8 alpha delta fibers, 8 delta fibers. And then fix the catheter, and then repeat the shot, maybe for next 1 or 2 days. Now they already gone with a single shot. It used to be the initial thing for 3 days thing. Now it is becoming 1 day phenomena. And again, some issues with the headache, because then you have more volume and more days and catheter related things. And obviously, if you have a bigger volume, then there are macular hemorrhages. We have seen even epiduroscopy, when you have a higher volume, patients only can say he's got some eye symptoms. So please be very careful, or neck symptoms. Stop and decompress the zone, otherwise they will have a problem. Epiduroscopy, yes, it's another very good tool, because that's the start point was epidural. Now we gone epiduroscopy and epiduroscopic surgery also with the lasers, other things. I have devised my own technique, which I do share if I get a chance, that I do a epidural balloon neuroforaminoplasty. And it was very nice to hear that there's 2 days conference in Korea, which is only on spinal ballooning. Please, I did it in 2012 and all. Now they have started talking about it, spinal ballooning, and that's how I do it. I do it transfronally, I do caudally, I do it different settings. You just see this, and it's very, very helpful. I'm doing epidural ballooning. We go up and down in those zones where we have to decompress and other things. And I use it in conjunction with vertiplasty good often number of times. I'll be giving my talk on last day vertiplasty that I really make use of this technique, because it's a safety balloon there. And we do it through the endoscope, and we do it through the disfx, and we do it through the S1 foramina coupling with other things. The root issue DRG stimulator is already there in the market, and is really proving its worth. But know it that there are lesser means we can do it in India, and that's a root block. I'm going to talk about S1, because L5-S1 is a very common problem. So S1 root block is very, very vital. So know it is so important. It's just a radiculopathy. You want to start before surgery or post-surgery also. We keep getting these patients who have been procedured, surgery, and still have some root problem. It's okay. It's known. It will take some time for surgery to show its full effect. Till then, you can give 1 or 2 shots of S1 root block, and it does good job. Now, equipments, needles, and everything is known, because that is going to be more theoretical thing. Yes, complications are there. And just to narrate few of them, damage to the nerve, if we really go and pit the nerve and are not very careful, or intraneural injection to be avoided by all means, intravascular injections, and then you have a spinal cord infarct, other things, and we avoid those things. Now, understand this picture. Now, this is known. Now, when we give injection here, it's a subpedicular injection. Please understand. And we give an injection in this area as a Camus triangle injection. So, and that's how we find the Scotty dog view of it. And we understand. We give injection here, it's a Camus triangle injection, typical like endoscopy. We may give injection 6 o'clock, pedicle 6 o'clock. And that's the injection for the subpedicle injection. That's the point lies here. I'll go again. If you give injection here, it'll take care of the exiting root and the root above. If it is injection is given in a Cambridge triangle, it'll take care of the exiting and the root below, which is the more scientific thing to do, because your disc will give either issue with the exiting or the traversing one. So that takes better care of that. Just for a sake of fun, I sometimes do a DRG work, and that's where I do my pulse RF of the DRG and do my drug. You can see the cobra head right there, this root and pre. Now this is preganglionic, ganglionic and postganglionic. The next picture will tell you. You give injection preganglionic, ganglionic and postganglionic. So people have got their own reasons to give which injection really helps more. And that's how, again, another view of that, pre, per and postganglionic. And that's where we are trying to go in here. This is avoided by all means now, because we have already discovered there's a vessel artery, small arteries coming and going through this area. And there is a reasons that people have done all those mistakes there. And that's what you do. There are two things now. If you're doing it just a postganglionic, you can just put your drop it here. If you're doing preganglionic or you want to do a lateral recess block, you better go in here, which is more scientific, frankly speaking. Depending on, say, paracentral or foraminal disc, depending on which disc is involved, accordingly you do the block there. And these are the typical areas. You go in for L5S1, and this is for L4-5. You just go in here and you can see there's no root, it's not visible, but after you put in dye, then you can see the root, you understand where exactly are you going through. And that's another very good advantage and add-on thing is, I do a facet RF. Same needle, I proceed further on, I reach onto the root area. I add on. I got a 5-in-1 procedures. People who are in pain, they come to my workshop, they understand. I go intradiscal, do my intradiscal work, and discography and RF and other things, and put in ozone or PRP, and just come out, do my lateral recess block right there, just outside the disc, outside the annulus, come out, and then I put my needle here at the RF and do my RF at the facet 1, because you have to combine these things for the maximal effect. And this is the foraminal anatomy. Everybody knows when you talk about this, that you're going discal, you're going out, this is the root, and this is your track, we're going in and going out, and that's really justifies. You look at this area. You can go intradiscal work, come out, do a lateral recess work, and come out, do a facet work there, and that's done deal. This is the content. A very good slide from Professor Dattar, Dr. Dattar. And that's where you have, it's not just a simple thing. Some vessels, veins, but the most important point here is that in this area, which is called the safe triangle, is really an unsafe triangle. Because 98% times your vessels are lying above the root, and only 2% time there are vessels which are lying below the root or subneurally, right? And that's where you just see, when you do an injection there, you're pretty safe. You're away from the vessels and all, and there is almost no complications, vascular complication I'm talking this time, when you're working in there. And again, it is addressing both the roots I told you, the exiting and the traversing one, which you really desire. Another one, the subneural, we got it above, supraneural or retroneural. You take care of only one root. When you do inside the Chemist triangle, you take care of the two roots there, and that's more scientific, which I told you. Now this picture is to show you, let me go next. These are known, there are vessels which are small arteries which are known to go inside. We can see only subsection angiography, is not visible in routine your fluoro. And the people have put particulate steroid in there, which we very often used to do it, and that can cause a spinal infarct, and it is not recoverable. It doesn't recover, please. People have done those things and pay for permanent paralysis. And this is when you do neuroplasty, mechanical neuroplasty, put in 190 days, and then you put in your catheters through this, open up the nerves, very good effective technique. But sometime when you're getting into the Chemist triangle, sometime you may see a intradiscal flow, because obviously the disc sometimes is bulged out. We can combo lumbar epidural, we can just see the lateral lazy, and we can combine lumbar epidural with the root block. Suppose you're putting in a drug here, you're not seeing the root well. Come on from the side, see the root view. Another way, we are doing a caudal, which Dr. Siddharth, we're just seeing the caudal, we're seeing a very good flow. We keep putting n number of volume, 10 ml, 20 ml. You're not seeing a drop on the other side. Obviously, there is a plica which is there, which is not allowing, or compartmentalization is there. Then you come from the other side and put your drug on the other side. Although normally I tend to go and cross to the other side, but sometimes we avoid it. This is a cervical root block. Again, it's gone out of fashion, but I still do it because I love that response which it gives. and ultrasound is coming in a very big way. It is very, very helpful because you can see the vessel, you can see the drug flow, and this is very doable kind of thing, and you avoid radiations. When you combine these things, must take the whole patient into account, not just one thing in your mind. If there's a facet orthopathy, take care of the facets. Well, we have to give a healing touch to our patients. They are looking for a response. They come to us, think as if we are God sent. So please do your needful, do help these patients. And this is what, and I keep saying teaching best way learning, and that's what this all forum is all about. And thanks to my friends who are doing such a good job. I must compliment them for the great job. It takes a lot of toll. It is not easy. And we have to understand what goes in. So let's keep igniting more minds, knowing, spreading knowledge, awareness, and we have this conference and practical sessions also for that. Thank you, my friends, for your patient listening. This capsule was for epidural and root block and foraminal block, which is the bread and butter for pain specialists. You people are learning out of us now, and it's good that you learn it because patients come to you and you can really do good job for them, or at least have a pain specialist by your side and you can work together for a maximum response to the patient. It's not that you people fail and then it comes to pain specialists. I would wish under one roof everything is done, and that's the best bet, because that's the best thing, because here for one life and we want to give best to the patients. My next talk, which is going to be in combination, which is the third talk, by the way. I've given 2 talks, and that is I'll just break here. I'll go to the next talk, please. Here. And that's the ganglion impart block. Oh, it's a very small talk, by the way. About 5 minutes or so. And please. Here, PPT, my friends. Go ahead. Okay, ganglion impart. Why I need to talk is, one is it is important in subset of patients. People who have tailbone pain, coccydynia, sitting job with bad postures, especially bad posture, when they too much of a leaning back, or the boss chair or slouchy, couchy people, very, very common, and people who really work for hours together without changing the position, it is known they start having a tail pain. We say, okay, physio, medicine and all, but they keep coming back again. So there are ways and means we can give them a lasting relief. I'm saying lasting is, I remember a friend of mine who's pathologist, my class fellow, and he used to have it 15 years back. I said, Neeraj, you're treating everybody, my pain you are not treated. I said, what is your problem? He said, I've got a tailbone pain. I said, come over one day. If you have taken all medications, it's not helping you. He's a doctor by himself. I said, come over. I did a one shot, and it's been years now. He's happy, and he keeps saying thank you to me again and again. Now, this is what it is, the lifestyle issue, and it's coming calmer. And must have been, since ages, he must have had a coccydynia at that time also, because lying on the hard surface, especially metros and hard chairs, or the old time benches in the schools and all, they all are known to cause this kind of tailbone pain. It aggravates further on. So he keeps saying, and this causes chronic pain, and which is a menace. Menace because we have to you could tackle it in time before it really chronifies, because then it is more nasty and more difficult to treat. Yes, we have got a WHO letter of pain management. We should know, all of us should know, because there are some inherent complications with the medicines. We have to be careful on this. And I'll going to tell you about impart block quickly about this, and even the coccygeal block or coccydynia block. And yes, interventional pain has proven itself over a period of time, and let's do it in a pain way, because there's no surgery per se mostly. Although I remember I had a lady in the UK. She is the wife of the head of the St. Thomas Guy's Hospital urologist, and if a friend of ours, and wife was suffering. I went to their home, and she was with the heating pad on and TENS on, means all time. And this is what it is. Surgery sometimes is not the answer. This is the location of the coccydynia, and it just is localized. It's a single ganglion. Normally this is like this. Normally we have a bilateral ganglion, twin ganglions all over the body, except celiac plexus, which is one single ganglion, or the ganglion impar, which is a fused ganglion at the tip with the 2 chains fused, and that's where it is lying. It is helpful in malignancies. Impar is for perineal pain, the CA, vagina, vulvodynia, all those things, vaginismus and other things, and plus perineal pain, anodynia, very, very helpful tool. And that's where it is sympathetic mediated pain, malignancy of the pelvis and perineum, and chronic pain syndrome. I am telling about the tailbone also now. Yeah, I found it to be very, very helpful. It was not initially indicated, but I found a very good response. So I keep telling. Now you can do it in few ways. One is lying prone. I'll just show you that. Lying prone, go under the tip of the coccyx and just go and land there, and that's where the whole thing lies. But I'm not very happy with this procedure. We got to get newer ways. I'll tell you what. And we just go with the bed needle in there, put in dye there, and it used to look like this. But it was risky. It was done initially. Now we don't have to do it. We have got a fluoro. We got a new tool, new technique, and that is the we could do in the lateral view in the prone position, or some people do in other positions also. And that's where you see the sacrococcygeal coccygeal junction. And that spot, you put a needle in there through one of the two joints or both the joints, depending on how much is the requirement and how much is the pain. I just go in there. As soon as the anterior, like LOR, loss of resistance, don't go further in. Please understand. I'll tell you why. Because there is a rectal bubble there. So you're going from here or going from here, please be careful. You don't go further in, because they're just like an epidural and spinal, you know, the lines of that. And that's a rectal bubble, and you go in there, put your dye in there, you do a semi-lunar appearance of the dye. That's what you really want. But you don't want dye to go too far high. You have to be careful on that. And that's dye, nice, good look, very rosy look, but look at the rectal bubble. I always tell, when you do this procedure, ask the patient to empty the rectum, please. Otherwise, you may perforate the rectum. If you perforate the rectum, your needle is going to go back through the disc, sacrococcygeal disc, and it can be a very bad discitis. That probably happened in that patient of UK. And she was done a surgery, removed disc also, and then still was suffering. And that's where you have to be careful. Then if it really keep coming back. One last thing is, when I do my drug inside, when I come out in the coccydynia pain, I just put my drug steroid over the coccygeal area and even at the tip of the coccyx, please, field block. Good, a very good response. Means rarely failed. In almost never failed kind of scenario, because it's a very good response. Might have to repeat one shot, and that's the coccygeal nerve. If patients is been done 2 procedures, still coming back like a facial pain or SI pain, we do a facial coccygeal nerve radiofrequency ablation. That's where it is taking the signal away. You block the coccygeal nerve. There are shown share of complications. We don't have to worry if you're doing good job. Again, my friends, thank you. Thank you again. Thanks. Thanks for your time.
Thank you, sir. If there are any questions, we can take them now.
Any questions, please? I'll be more than happy to answer things. Because it's a huge domain, and there can be at least 100 questions. You can always ask me now or always ask outside.
Of course,
you know,
he's available here for the duration
of the diet, because normally it's a lengthy talk, but I try to concise it to as much and give a message, you know. But yes, it is doable, effective, and if you can take up this call that you do this pain procedure, but do it in righteous way and without any complication that's required, or always take a pain specialist with you. They are master at it. So I think in combo you can give response. It's always good. It's always good to be together. Team always wins. Yeah, please go ahead.
So please speak on mic. Please speak on mic, sir. Excuse me.
Good question.
So can you repeat his question? Can you repeat his, Neil sir, can you repeat his question?
Yeah, he said, what is the experience with PRP?
Yeah.
Yeah. Yeah, good. PRP is coming in a big way. Let me tell you, PRP is used epidurally, PRP is used facet-wise, PRP is used intradiscally, and SI. So PRP is everywhere now. Where used to be steroids are going off the shelf, PRP is coming in. That's number one. PRP people have done, I do all my intradiscal procedure. When I finish my procedure, anything I'm doing, if I'm not putting steroid inside the disc, I do PRP. Let me explain very clearly. Because if there's an alert here, PRP is going to help these patients, so don't leave them alone, because we don't do. You people do it intradiscal steroid. We don't do it because discitis is an issue, very big issue, menas. We don't take chance with the discitis. So that's where we do PRP. Even in my endoscopic discectomy, all discectomies, I put in a fibrin plug at the end. I've got few improvisation which is going to talk, another hour session. That's a transdiscal ultrasound of the spine to perfect the endoscopic discectomy. That's a very different newer thing concept. But I always combo with the fibrin plug, because you are doing annular tear is there. You try to do RF for the denervation part. But what about the healing part? You have to do something with the healing. So PRP is coming in a big way. People have done even the PRP. They have done a good study now. Their study is going on. Epidural, caudal epidural PRP. Bigger volume, 15 ml. Like caudal is a bigger volume job. So do bigger volume PRP, and they found to be good response. Steroid is going off the shelf because they already seen is a volume which works good number of times.
So
and
I
even
think,
saline is
sir, we
working.
can take this discussion over
Yeah,
this thing. This can go on and on.
Yeah,
So,
that's right.
but
Anything-
yes, PRP is good. So we'll take these questions later on. I'm sorry, we're now short of time. So we just
Anything relevant,
I
please
think-
ask. Otherwise, we'll take up later.
Yeah, I think you open a huge debates about using of PRP, because
Yes.
if we show all the literature and the evidence, they don't support any use of PRP in the spine.
So
the level
is
of
something which
evidence
is coming.
So I will just
because
recommend
tell
one
you,
thing,
it's
which will
saline
put-
vis-a-vis PRP. So we are doing a volume.
only
effect, number
I
one.
think one paper from Egypt, the level of evidence is level 3. They use it in the discal space, but as I know, there are no high level use of.
I'm current on this, by the way.
Okay.
There are very good studies in the US and other places for regenerative medicine, regenerative therapies to do with the disc problems, and they've shown their own positive results in good subset of patients. We're not talking about big disc, huge
So
disc, and all.
what type of PRP is it a pro-inflammatory or anti-inflammatory?
so it depends
No,
on the
no,
indication.
high leukocyte or low leukocyte?
So I'm sorry to intervene. It depends on the indication. Let me summarize it in one line. So if you are using it in private practice, don't do anything which doesn't have evidence. If you are doing it as an experimental way, it is actually classified experimental therapy, and in that case, you are free to use it as a part of a study. So do register those patients in a study, and you do whatever is best in the best interest of the patient. But as sir has mentioned, now some literature is available, and as regards your question, sir, I'll just clarify. There are specific indications for leukocyte rich and poor PRP, which is a topic for another day. So I'm just going on with the next talk for now.
No, he's
please.
saying because your
You're right.
discus, intradiscal is avascular area.
Yes.
You can manage to put any kind of PRP, pro-inflammatory or anti-inflammatory, because if it's a lot of vessels, then there is a big problem and pain and all. It's a totally vascular area, so you can use the leukocyte poor or leukocyte rich, but always we prefer leukocyte poor.
Poor always.
Yeah.
Sir, another burning issue.
Sir, I'm sorry.
So I think probably
We'll all-
I'll come in there and we can talk it.
Sir. Maybe next time we can have one section on PRP also instead of the pain. Yes.
PRP is fine.
Yes. So I think we go with the next talk. So meanwhile, I'm changing the laptop. You can have a discussion on mic also. No problem. So you can take the mic, no problem. मुझे लेजर दे देना. एक सेकंड.
Must introduce Dr. Siddharth, Professor Siddharth. He is doing a great job. He is from Bombay. He is doing a great job in education and training and teaching people and passing the skills on. Young man, but with a great heart and great future. So I compliment him for his hard work which he's doing. He does a lot of training sessions also. And well, we look upon what the future masters have to say.
Thank you so much for the kind words, sir. I'll just put on my presentation. So actually, I also have 3 talks and 3 small presentations. I'll not take much of your time. I'll focus more on the technique part and just give you a glimpse of the kind of the evidences which we have. So I will cover the cervical epidural, the the caudal epidural, and the lumbar sympathetic. So these are the procedures which are now classified as a minimally invasive pain and spine interventions in the 2019 update by the Indian Society for Study of Pain. And they are no longer, we don't use them as an anesthesia procedure. This is for the treatment of the symptoms of the patient, which can be a radiculopathy or something different depending on the procedure involved. So I'll be focusing on the techniques, indications, and future, and I'll try to finish in time. So this is the simplest procedure, but as sir mentioned, there can be grave dangers with this as well. So if you go with the step-by-step approach, which I'm going to tell you about, it is going to be very easy for you. Most of you will be doing it, and some of you will probably want to do it. It's a very rewarding procedure. So the first step which we do for any procedure here is these are all done under local anesthesia, of course, and we see the true AP picture and mark our entry points. I'll teach you about entry points, but the key thing here is try to make this procedure pain-free for the patient. So the most important part is to raise this skin wheel, which you will see here. I'll just put in this laser pointer in my slide. So I think you can see this skin wheel. So this kind of a skin wheel should be raised to make the procedure pain-free for this patient. And for this C-arm setting, which is the most important setting for this patient, you must take a true AP view to the spine. So that means that your spinous process and the pedicle should be equidistant. So, and also the vertebra which you are targeting should be squared. Herein we have squared the top edge of the first thoracic vertebra. So you can easily identify this by the rib attachment. And that's the reason for this is I am going to hit the upper, my first target is the upper margin of the lamina of the T1 vertebra, and then that's my safety zone, so that I don't unintentionally go beyond. And this is very important. So your patient's position is also important, which I have shown here. So the arms can be in front or behind as well. That really doesn't matter if you are using the technique which I use. So I use a contralateral oblique technique where you don't need to take a full lateral view. If you take a full lateral view, you will get obstruction from the shoulder, and you may not be able to see it nicely unless your C-arm technician is very trained enough, and then you may need to do a lot of manipulation, pulling, pushing hands and all that. Patient gets quite uncomfortable. And the technique which I am showing here is for the single shot injection. If you are doing catheter threading, then you need to come from one level down. So, but that's I'm not discussing in, just to keep things simple here. So, if you turn contralateral oblique, and this angle has been studied in great details. So I'll just summarize the papers which tell you what angle it should be. So actually this angle should be 53 degrees plus minus 4 or 5 degrees. But then when actually you are placing the patient prone, depending on the slight tilt which the patient may have, this angle can vary slightly more. Okay. So on the contralateral oblique picture, you will see something like this. So these are the laminas in the cross section, and this is your needle coming in, which you should target in. And as you go further inside, you just cross this line, which is the internal line joining the all these internal portions of this lamina. And as you cross this line, you must do either an LOR with the air or saline, or some people do it with a hanging drop. So depending on your preference, I personally do it with air still. And it is very difficult to get the LOR. So focus more on the radiological correctness, and then also on the LOR. So if you get both, then it's the best. When in doubt, please inject the dye. If the needle is out, the dye will flow like this from here along. It will trace the needle, and we use this Omnipec dye, which is commonly used for all our procedures. And once you are getting the LOR with the saline, which is always better to avoid any air injection, you will get a picture which is like this. If so, this confirms the epidural spread. You can take the AP view now, and you can see that the epidural spread is there. If it is intrathecal, it will come like a thick line, and of course you will also have a CSF flow back. But it's not very difficult if you just practice it and go very stepwise. At this moment, you can inject your drug. So the drug used here is a non-particulate steroid. Try avoiding the particulate steroid. If you are, some people still use particulate steroid, but especially in the transforaminal, it is contraindicated. Here you are still kind of a 50-50 zone. You can use it, and I think some people still use a particulate steroid here. If you are threading a catheter, you can go up to the target level, and then you can actually reach the target level from the same C7T1 space. Okay, so there are a lot of new developments which are coming up with the advent of ultrasound. Now we have cervical abdominal space visualization to minimize the radiation. This is one of the future techniques. So maybe we'll see quite a hybrid kind of techniques being used in the future. Also, you have a contralateral oblique view, which has almost everywhere replaced the true lateral view. Most of people are doing contralateral oblique. So if you are entering from the right side, like in this patient, you are doing the right side. So you move your C-arm to the other side. That's the left side. That's why it is known as contralateral oblique. And then there is a lot of prediction of cervical abdominal space depth from the skin using cervical X-ray, which you can do. So there are lots and lots of work being done in this small field as well. Why this is important is because it is quite a rewarding procedure, and in many situations this can be having immediate relief or immediate results for your patient, especially from fresh or new cervical radiculopathy. So I think this is my reference. I have taken some of the pictures from this popular YouTube channel. And now I'll just discuss about our upcoming workshop in the last. I'll just go on to the next presentation, which is about the caudal epidural. These are simple technique with images which I thought will help the beginners, and of course we can discuss any questions also in the end. So for the caudal epidural, again I'm going to focus on the same things. Dr. Jain has made my job easier. He's already taught you the anatomy for this. Our target is entering through the sacral hiatus. The main indications are when there is a multi-level pathology and we want our drug, which in this case will be a steroid, to reach everywhere, or when we want to do a neuroplasty, or when we want to do a balloon technique, or when we want to do epiduroscopy, which is not very commonly done now, but still I think it will see resurgence in the recent years. Now, if you see, your target is to go in between these two pieces of bones. I'll just use my laser pointer to highlight. So this is the portion which you want to target, and the key is to remain in the midline in the AP view. The commonest mistake which a beginner will make is they will not be in the midline in the beginning, and that can lead to issues. So you start always in the midline, and then you can turn lateral, making sure that needle is always in the midline in the AP view. Okay. So this is a Nysora, you can say, infographic, and here they have mentioned the blind technique which was used earlier. So I will recommend that please don't use the blind technique anymore. All of you have C-arms in your theaters or in your control, and you can use that. Or those of you who are using ultrasound also, you can do it radiation-free entry. And once you inject the dye, you can just confirm it with one C-arm shoot, which is known as the hybrid technique. So many of us, or rather most of us, are using that technique as of now. So this is the simple things which you require for this procedure. Just marker, local, the entry needle, which can be 2He, as sir mentioned that it can be, for if you are a beginner, please use 2He. And also it will decrease your chances of intravascular spread, and that is also very important. Then you use the drug to confirm or test, and then you also use the final mixture, which whatever you want to give inside. Okay. So the key here is in the to identify the portion, the correct portion. So this is the downward margin. If you go below this, you will actually end up somewhere else, and this is the upward margin. If you go in between this margin, anywhere is correct. You hit the bone and you straighten your needle. So how you start is just give the local anesthesia, then mark your trajectory and see under the C-arm, and make the needle parallel. Once you hit the bone, make it parallel, and then again push it inside, check under the C-arm whether your needle has entered, and then once you have entered, give the dye, see an AP picture. This is known as the Christmas tree or the fir tree appearance. then you can give the drug whatever you want and push it up to the desired level. If you are entering a catheter wanting to go to the upper space, that also is possible. And there are a lot of advances in this also. First, I already mentioned, now people are using combined ultrasound, and all my papers are within the last 2 years, so 22 to 24. So combined ultrasound and fluoroscopy versus fluoroscopy guided, and they found good results with reduction of radiation, and in fact the time was also reduced for this procedure. So another update is about the evaluation of its effectiveness as an adjuvant to ganglion impar therapy. So people have found that if you combine it with the coccydynia procedure, the patient satisfaction rate is quite higher. So many of us will agree that the L5 symptoms can also present like pain in the coccyx. So I think there's no, we already know this, but it has not been published, and so literature was not supporting, but there is some evidence now that you can combine that to give better results. In addition, it is being widely used, pure ultrasound guided. People have started now using pure ultrasound guided caudal epidural also. As the proficiency of you handling ultrasound will increase, the complications will kind of fall down, and literature will come more and more in support. So if you are doing it for the first time, do it with somebody who is already an expert, or do it as a part of the study, and then it will be much better for you. Also, it is I think being used for fibrosis which happens after the surgeries. So if that was actually the biggest indication until recently. So if the patient is having fibrosis, you can actually guide your catheter to the level of the fibrosis in the subpedicular zone. There is a typical zone, there is a separate catheter for this, and then you can actually use it very nicely and give your drug there, and use drugs like hyaluronidase, as Dr. Jain mentioned, to give good results to the patient. So I've used some of the pictures from this channel. Other than that, I have already mentioned the references. So with this, I come to the last presentation, which is the lumbar sympathetic, and I'll just present this. So lumbar sympathetic is a very underused procedure. It is very unpopular also, especially among surgeon people from general surgery or CVTS. They prefer to amputate the limb rather than try this procedure. Still, after so much of awareness, which is already there, and literature also supports its use. So this should be the first procedure to try if you are having a lower limb vascular disease which is not amenable to immediate intervention radiology treatment, like if there's a stenosis and you want to just stent it or something like that. If that technique is not suggested, or that procedure is not suggested, then this should be the first procedure rather than going in for amputation and later on using it for just the stump pain or something like that. So the basic anatomy is that you are going to target the lumbar sympathetic chain, which is I'll give you a mnemonic, LUM. So L2, 3, 4 are the levels, and L2 ka you have to go from the lower, L3 ka upper, and L4 ka you have to go from the middle of the body. This is the mnemonic, just to remember, so that you don't mess it up when you're doing the procedure. So these are the final images, and the key why I have shown you this first is that you have been told by Dr. Bhagwat in the morning that both AP and lateral pictures are very important. So when you are at this, your needle tip is at this end point, your lateral picture should show your needle tip at the edge of the vertebra. Then probably your dia flow will also be good, and your results will also be good. Okay. So this is the normal Scotty dog appearance which we all are familiar with. In lumbar sympathetic, you do it slightly more oblique, and you want to enter from here. This is your target. You can enter from slightly, just a minute, let me make a laser pointer visible. So you can enter from slightly laterally also, but don't go medial to this. If you go medial to this, you will never be able to reach your target. So once you go lateral, you can always go and kind of hit this body, then just change the bevel direction and glide along the bone and go inside very nicely. So in your lateral picture, it should look like this. You have to reach the end point, which is the margin of the anterior vertebral margin of the L2 vertebra. So now you can see this is the lower margin. So for L3 you will use the upper margin, and for the L4 you will use the middle margin. So mnemonic is L, that is the lower margin, U is the upper margin, and M, that is the middle margin for this. So this way you can remember it clearly. And you need to continue to advance till the tip is just anterior to the body, and then give your dye. If you want to save time, you can use multiple needles and then inject the dye after negative aspiration. So note on the AP how the needle move more medial once it is in the final position. The common mistake which people do is that in the AP their needle is somewhere here. So actually you have not reached the correct point. So you should try to take your needle out, come either from more lateral trajectory, or maybe modify your needle tip by means of your bent or bevel, and reach the correct level. So this is how it will look in the lateral view after you have given the dye, and as mentioned, this is your final picture as well. So like every other procedure, there's a lot of future directions in this. So now they are doing the effect duration of lumbar sympathetic ganglion neurolysis with the patient with CRPS. So common indications for this procedure are CRPS or lower limb vascular complications, or even diabetic neuropathy. And in some cases the indications are being extended as one of the paper shows. So this one is the effect of lumbar sympathetic blockade on the pain scores and collateral perfusion status. So the principle is that it will lead to sympatholysis, and as a result the vessels will dilate, thereby increasing the flow to the tissues, which is the problem with the peripheral arterial disease. So this should be the first procedure to be tried by common sense, but unfortunately because not many people are trained, so maybe you can make this procedure more popular and grab these patients. So efficacy of lumbar sympathetic ganglion block is also now being studied in the perioperative period. So they have found that in the perioperative period, if you give this, it is going to have good results for the patients. And this is already a published paper which is published in quite some time. So I think this is it from my side. This is the reference. I have taken some pictures from here. And with these words, thank you very much. Do attend our sessions. I run the Mumbai Pain School, and I welcome you all to attend any of these programs where we teach all these procedures in future as well. Thank you very much. I hope I covered everything.
Yeah, great job, I must say. In a simplified way, but still it's nicely covered. A few points. One is when you talk about this sympathetic block, it is done mostly for vascular thing, but sometimes there is a sympathetic mediated pain, which CRPS and other things are there, and that really is taken care with this. I want Dr. Siddharth, could you just tell friends about the rami complicantis block, which is more for use for them for the discogenic pain. So, how do they go ahead with the rami complicantis? So they understand that there's something which is good for the discogenic pain is rami. Although we're talking about lumbar sympathetic, that is for this distal or peripheral pain. But we're talking about the discogenic pain because anterior discal is a sympathetic pain. So that's where the sympathetic block comes, and rami complicantis is another very good tool there. So you can tell them about it.
So I think, sir, you already covered
one of the slides, you can tell where the rami is there. If you have slide with you, please do tell them.
Just a minute.
Just one of those slides. Just in a sympathetic way, not just rami, just in a sympathetic where the rami lies. Okay, you got to start it again. Okay.
Yes, sir, I just started.
In any case, another thing which Dr. Siddharth was talking is when you do LOR technique in cervical epidural, when you do in lumbar, you do air, it's okay. But when you do in the cervical, you do air and saline mix, 3 and 3 ml. So first saline goes, but the 3 ml of the air which is in the syringe will give you LOR or the bounce back kind of thing. Because if it is pure saline, it doesn't have any bounce back. So that kind of mix is there. So the saline goes in, air doesn't. If air goes in the cervical epidural or it's intrathecal, that's where your worry is. So that is taken care. So 3 ml of saline which goes first, and the air is at the back of the 3 ml saline is the air which gives you bounce back. So both things are taken care of. And incidentally, the laminar line which was there, that's called a modified J line. for people who want to know more, but which we really know more often with the routine lateral interlaminar epidural.
So I'm just putting up this picture for MI communicantis, and
Another helping point is when you do the caudal epidural, sometimes we bend the needle, to the advantage, about a centimeter from the tip, so they can negotiate the curve, the sacral curve better. So that really helps you to negotiate that curve. Actually, I thought it's just there.
no, sir, I don't have it.
It's okay. Go ahead.
But
Any questions from anybody? In any case, please do ask.
So this is the.
Acha. Oh, okay.
Yeah. We just put it for you.
Okay. So we keep your questions ready and do ask. When you go back home, you don't have any queries in your mind.
So this is for
please
the
do
MI
ask.
communicantis, if sir has mentioned. So you can see that this is just coming up from the sympathetic chain, and this
I
is
raised this point, it's
going
relevant
to
for them.
target the supply for the disc, and some of your resistant cases can be helped with this. And I think these are the radiological images where you need to be. So it is just slightly posterior. So you drop short of going fully ahead, and to target this particular nerve, you can do it an exclusive, or selective procedure also.
Yeah. So just halfway through. You don't go at that anterior to the vertebrae. Just halfway through. Thank you. Thank you, Dr. Siddharth.
Thank you, sir.
Thank you so much, Siddharth and Dr. Neeraj Jain. So now I think we will go to the next session. If there are any, I know this is a very interesting topic for we surgeons. So if there are any queries or questions, we can take them informally maybe later. So because we are short of time, so we will go to the next session. So I invite Dr. Ghazwan from Iraq and Dr. Abhijit Pawar from Mumbai to chair this session. Also, do we have the next speaker, Dr. Seth? Yeah, please come.
Dr. Sharvin, welcome. So the next talk is navigated transcambine lumbar interbody fusion with tubular retractor system, technical review and preliminary results. So interesting talk. Eight minutes for this talk. Thank you.
Good morning, all respected faculty and colleagues. I'm going to be talking about navigated transcambine lumbar interbody fusion using the tubular retractor system, our technical review and preliminary results. So the Cambine's triangle, we all know the anatomy of it. It's the right angle triangle on the dorsolateral aspect of the disc space, which was first described by Cambine in 1972 for a transforaminal discectomy. And now we are able to do lumbar interbody fusions through it, which is also called the oblique lateral lumbar interbody fusion. And the advantage is it is a facet sparing fusion, so facetectomy is avoided, which also avoids epidural scarring, bleeding. Neural retraction is also avoided, and indirect decompression can be achieved. So the transcambine fusion can be done with three techniques. One is a full endoscopic technique, which is routinely employed. A percutaneous technique is with no utilization of scopes or tubes, but only under the IITV guidance. And third is a tubular technique, which we'll be talking about. So the aim of our study was to evaluate the technical aspects of transcambin lumbar interbody fusion, or KLIF abbreviated, and to evaluate our early results. It was a prospective study, and inclusion criteria was patients who had a low back pain with neurogenic claudication. There was no rest pain. The patient had a free SLR and no neurological deficit or bowel bladder involvement. Radiological inclusion was spinal canal stenosis of grades A and B with or without foraminal stenosis, spinal instability, and a minimum follow-up of 3 months. The evaluation was done on relevant X-ray and MRI scans in the pre-operative and the post-operative phase, and clinical scoring was on the McNabb's grading and VAS score for leg pain and back pain. So routine prone position with horizontal bolster and everything was done. After draping, we inserted the navigation frame. Percutaneous pedicle screws were inserted on the contralateral side of the cage insertion, and ipsilateral guide wire placement was also done, followed by docking of the tubular system. So for the docking of the tubular system, so the first is we mark the midline in the true AP view at the spinous process, and then we get an oblique view where we can see the Scotty dog, and the docking of the Jamshedi needle is done at the junction of the superior articular process and the transverse process junction, and from there we walk superiorly and into the posterolateral aspect of the disc space where we can feel the soft disc and enter the needle inside and confirm the position once again in the AP view. Once we can see that the Jamshedi needle has reached the midline, we just cross beyond the midline and confirm it with a lateral view to see the position of the needle again. Both the AP and lateral views are taken for confirmation, so we know exactly the adequate depth of our angle of insertion of the cage. Once the needle is inserted, we pass the guide wire, and all the rest of the procedures are done with the help of docking of the tubular system. So there are gradual sequential shavers which are used, and we can see the gradual increase in the shaver size, which is confirmed in both AP and the lateral views. The step from marking of the midline to the end plate preparation in the discectomy, we can see a lot of IITV shoots are taken and required for exact docking of the needle as well as the tubular system. So navigation here helps us in planning our trajectory of incision. So through the projection of the needle, we can exactly plan where to put our skin incision for the cage insertion. Then rest of the steps are same, but without radiations, we land straight on the junction of the superior articular process and the pedicle. Then entry in the posterolateral part of the disc space, and then the needle is entered inside the disc. The shaving and end plate preparation is done in the routine manner as we do with an endoscope or the tubular system, and with the bone graft substitute is inserted followed by the cage insertion. Again, the cage insertion is also aided through navigation by use of a third party instrument or registration, and we can exactly place the cage in a proper location, and this is the final post operative image. So in our study, we had 26 patients and 32 segments with an average age of 57 years. There were no complications, implant related or neurological. However, in the first 8 cases, we had 4 patients with transient radicular pain because of, especially in the exiting nerve root region, which resolved over 2 to 3 weeks with the use of analgesics. In the next 9 patients, it was about 2 patients, and the final 9 patients, we did not have any such complaints. 88.5% of our patients had excellent results. We can also see significant reduction in the VAS of back pain and leg pain in the immediate post-op as well as at the 3 months region. The full endoscopic technique is routinely done, but it has a cost and availability of equipment issues, instruments and setup, and it also has a steep learning curve. Whereas the tubular retractor systems are readily available, there is familiarity of instruments. Microscopes or loops can be used for magnification and illumination, and it is an extensile approach. Because of the obliquity of insertion, we can put in a cage with larger footprint as compared to our routine T-lifts. So how it differs from our endoscopic transfemoral fusion is the wire insertion, we use oblique views instead of the traditional EP and lateral views that we use. So there is sharing this article about the Cambin's triangle classification and how there are 3 types of approach they have described. So we are using type 1C or 2 approach, which is landing directly on the facet and then going towards the disc. And if required, we burr off some part of the superior articular process to widen the entry for the cage. An advantage of navigation is it increases the accuracy. There is reduced radiation and it helps prevent exiting nerve root injury. So I'll share a few cases about the same. There is a case of L5S1 lytic listhesis. We have put the contralateral screws on one side, ipsilateral side guide wires and the cage placement. And this is the patient with 1 year follow-up, absolutely fine, no complaints. Similarly, a case with L4-5 stenosis with instability, and this is immediate post-operative image with 1 year follow-up. And we also did a 1 year follow-up MRI scan to show the regression of the ligamentum flavum as compared to the pre-operative images. And here is a case of a multi-level stenosis. We have done multi-level fixation with 2 levels of transcambin fusion, and the patient has a 3-month follow-up and doing absolutely fine. Again, a case of last mobile segment instability. Here we can see that there is not much space, but we have put screws and distracted, so which has increased the space here. And then the cage is inserted to give the final picture. There's some technical challenges that there are transitional anomalies which can be due to lead to difficult docking and narrow space. Sometimes L5S1 has a steep angle of approach and iliac crest may obstruct access. Reduced disc height can lead to increased chances of ENR injury. So here is one case, there is a steep angle of approach. You can see the right side foramen here is narrowed. And what happened was it led to the cage being on one side instead of midline. The patient, however, did not have any complaints post-operatively, but we can see on the X-ray that it is on one side. So to conclude, our preliminary results indicate that KLIF with tubular retractor system is an effective method of lumbar interbody fusion. Thank you.
Thank you. I think we will ask for one question and proceed with the next. Also, I have another.
So good technique. Only issue is what kind of graft do you use for fusion? Where do you get the graft from?
No, we use artificial bone graft, sir.
Like what?
The company name, it's a calcium triphosphate graft. Fracklink is the name of the company that we use.
So you think without any local bone graft, it will fuse only with Fracklink?
It is much like Olif's oblique lumbar interbody fusions also, we don't utilize any autologous graft.
Yeah. Other thing is, it's more or less you go through the Wiltse approach, transcambin. So with the footprint of your cage, so I think the exiting route is at risk. So you are talking about
so it is more lateral to the Wiltse, but it is not as lateral as the routine transfemoral endoscopy. How lateral?
Right, I got it. Yeah. But I'm more worried about the exiting route because it's right there, where you're putting the large footprint. The footprint of the cage is pretty large.
Yes. So our cage, I've not kept it here. The cage design we have is these are tapered at the apex. Yeah. So it just slides if at all there isn't the exiting route is in the way.
Good. It is interestingly that because if we review the literature, one of the pitfall of this approach endoscopically is the exiting nerve root irritation or injury, which is up to 1/3 of cases, which is almost temporary. And now you came with the technique, which is almost blind, and your preliminary result is less nerve root irritation. Again, preserving the facet with let's say protecting the root with the large cage footprint. It's not uneasy, at least for me, to be done blindly, right? Because the space is limited, and again the navigation system. I don't think that's how can you protect the nerve with the use of navigation. At the end, it's a blind procedure.
Yes,
blind procedure. Let's say, I mean, I'm not against the tubular, but blind procedure at least in the beginning, not in the preceding the surgery.
Yes, sir. Before putting the cage inside, we do use the microscope to see that the root is not in the way of our end plate preparation. Because the shavers and the shavers here we used were the expandable kind, as well as the ones that are made which go over the guide wire once the guide wire is inserted into the disc space. So it is, we don't go and find and explore for the nerve root, but we make sure that it is not in the way. We demarcate the facet and then we just.
And again, it's almost the same indication of the olive.
Yes, sir. It is the same indication of the
because you are not able to do direct decompression.
Yes, sir. We are not doing that.
Yeah, the inferior to the olive, in the olive that you can do much more indirect decompression.
Yes.
When compared with this stage. Okay, thank you.
Thank you.
Next talk will be the radiofrequency ablation in the chronic pain. Dr. Buana Ahuja. Yep. Patient selection and the preoperative evaluation in the endoscopic spine surgery. Key consideration for the beginner. Dr. Sapkota? That's good.
Good afternoon, teachers, professors, and dear colleagues. I am Dr. Suresh Sapkoda from Nepal. I'm currently working at Dhangadi. It's a peripheral city in western part of Nepal. And I have come up with a basic presentation on key considerations for patient selection and preoperative evaluation in endoscopic spine surgery, especially the UBE. Basically, it's a very basic topic targeted for beginners, just like me, and some residents. We'll be briefly discussing about indications and contraindications, patient selection, imaging, challenges for an aspirant endoscopic surgeon, and some pearls and pitfalls. So the basic philosophy of endoscopic spine surgery is we are taking the viewpoint from outside the patient's body to close inside the body, close to the surgical and pathological process. It gives us excellent illumination, high definition video imaging, and magnification. This also is combined with bloodless surgical field, excellent visualization of the nerve and dural structures, and the dural and the nerve roots are also being already retracted, showing the underlying pathology. So advantages of UBE is it's a very being an endoscopic surgery and minimal invasive. It's similar to microsurgical in many aspects. It has some familiar instruments to be used. It's much cleaner and safer, and it provides us a wider visualization of the whole spinal canal, including the ipsi and contralateral foramen, smaller incision, and minimal soft tissue and bone damage that comes up with the minimal invasiveness of endoscopic surgery. The indications are similar to microscopic surgeries. all sort of disc herniations, central, paramedian, foraminal, extraforaminal disc can be dealt with. Lumbar spinal stenosis, the whole range of lateralices, central canal stenosis, ossification or of hypertrophy or of ligamentum flavum. Foraminal stenosis can be dealt with effectively with UBE. Spondylolisthesis if it is less than grade 2. Other indications like pyogenic discitis, epidural abscesses, this can be effectively handled with endoscopic surgery. Revision surgeries like recurrent disc herniations, case displacement, bone cement, leakage into the canal or foramen, implant removal are also other indications. And some of the contraindications, high-grade spondylolisthesis, tumors, especially the intradural and intramedullary tumors, and some advancement has also been in this aspect of surgery. Stenosis caused by uncontrolled infection is also considered in one of the contraindications. Relative contraindications are a few of them. Canal stenosis by high-grade listhesis, postoperative fibrosis leading to canal stenosis in which the risk of nerve injury is higher. These are sort of the list of complications that might occur during endoscopic surgery. We all are aware of this. It could be divided into immediate, early and delayed complications, which includes nerve root injuries, perforation of the peritoneal sac or the abdominal contents, especially with the transforaminal instruments, missed fragments, exploration at the wrong level, though it is pretty much lesser than microscopic or tubular surgeries, instrument breakage, swash hematoma, epidural hematoma formation, pseudomeningocele formation or infections can also rarely happen. Delayed complications like recurrent disc herniations and possible instability are also innate with endoscopic surgeries. So after knowing all these indications and contraindications, so what are the problems that a beginner faces? Limited access to the quality UB training opportunity in the vicinity is one big problem. Still, we are struggling in the other part of the world. We are still struggling with generating new centers which can offer training courses, cadaver courses, and hands-on courses. We need to travel abroad or to a farther place. Learning curve of the UB is relatively steeper, and in initial cases we might be having a long time for a surgery, and a busy surgeon or a practitioner who has already a lot of cases to operate and is already doing microsurgical practice and open surgical practice. It will be undertaking a case, a simple case which would take a lot of time in the operation theater. It could be a challenge in the beginning, but after completing few cases, the initial learning curves becomes progresses, accelerates easily, and the operating time also decreases rapidly. So the first few 5 or 10 cases would be difficult, and afterwards we can, once the hands-eye coordination and the confidence develops, then it becomes pretty much easier. Initially, we might be having high stress levels, long surgical time during the first few cases, and there is also some peer pressure and suboptimal support from the administration and all those things. So the bridging the gap, conferences and cadaver workshops, hands-on courses, and having a short fellowship or mentorship program is very useful. Careful patient selection is other important aspect, and the utmost important thing is dedication, focus, and patience in first few cases. So a beginner should be very cautious about cautious and conservative in selecting the cases. first few cases should be straightforward cases with isolated single label pathology without any significant instability. Try to avoid complex cases as multi-level stenosis or spinal deformities. Proper patient positioning and equipment handling is very important. Always we got to have a plan B, whether to complete the case struggling or convert it into open or microscopic surgery. And initially we tend to have overestimate our own capabilities and underestimate the complexity of certain cases. So in these cases, at this time, we can seek advice from experienced colleagues, and also having a mentor is important. So start with easy cases like paracentral soft L5S1 or L45 discs, especially left side for right-handed person or right side for left-handed, and migrated discs, simple decompressions, and we can progress to more challenging scenarios like large discs, large facet cysts, dural adhesions, or common other complex indications. We got to be careful about dural adhesions, which are common. Dural or nerve sleeve injuries should be expected. Calcified discs are also potentially difficult to remove, which often need power instruments to be used. So these are the cases that we need to be patient and reserve for our later journey. And patient education is utmost important. We need to give realistic scenario to the patient, and the possibility of need to convert the case into open surgery or microscopic surgery should be discussed with the patient beforehand. So to conclude with, understanding the pathophysiology of neurogenic pain and neurogenic claudication is the utmost important. We need to select our patients according to the clinical scenario, be conservative with initial management, and then proceed with surgery. Select the simple cases and gradually build up our own practice. And thank you so much.
Because of lack of time, we'll move on to the next talk. High lumbar disc herniations management by UBE technique, Dr. Nilesh Zope.
Good afternoon, everyone. Myself, Dr. Nilesh Zope. Thank you for World UV Forum and Dr. Malcolm for providing me this opportunity. Today I am going to present management of high lumbar disc herniation by UV. Epidemiology, incidence 5 to 20 cases per 1,000. Most common, third and fifth decade of life, majority of herniations are migrated. Symptoms, groin and anterior thigh pain, commonly misdiagnosed as case of hip joint pathology. Conventional treatment, laminectomy, discectomy. There is possibility of risk of past fracture and conversion to TLIP procedure. Here the green area showing the actual bony decompression during open surgery, and the red area showing the location where majority discs are hidden. So during open surgery, it is sometimes difficult to remove the high lumbar disc herniation. Here the UB diagrammatic representation, green area showing the actual bony decompression during UB procedure, and the pink area showing the visual field which I can see through UB scope, and my working area is almost somewhat same as a pink area during UB procedure. We have 5 case data. First is L2 L3 disc extrusion migration, second L2 L3 disc herniation, third L2 L3 right side foraminal disc, fourth L1 L2 disc herniation, and this is the 5th case. Here's short procedure video of this case. Sorry, I can't play video now. Subtitle written here. This is the red area laminectomy defect. Outcome, satisfactory decompression, no intraoperative, immediate and postoperative complication, fast recovery, no need of fixation. One patient needed second surgery, fourth patient L1 L2 disc herniation. Limitation, sometimes it's difficult to remove herniation when the herniation is paracentral, foraminal, and large herniation narrow lamina. But we have solution for this also. We can use para-UB or transforaminal endoscopic discectomy. This is the patient which we need to reoperate. This patient presented with back pain 4 weeks after initial surgery. His blood parameter was normal, CRP was also normal, but MRI was showing signs of low-grade infection. And patient had 2 episodes of fever with chills, therefore we operated this patient. Here is the video. This is the first case video of L1, L2 para-UB discectomy. He was weighing 137 kg. Trial CM examination was done. This para UV procedure. We may not label it as a complication, but this is the same patient which we have to convert in TLIP after 4 weeks. Conclusion: need larger sample to draw statistically significant conclusion. Thank you.
Thank you for your presentations, but any question from the audience? I have one question.
Yes,
That's,
please.
do you need to remove the facets in some time that's the space is too narrow?
Yes, that we should anticipate previously. Better to do CT scan, because when you go inside and tend to cut lot of facet, that time you realize that still you are unable to reach the disc. But in that situation, you can convert to para UV through the same incision. That time you can save the facet and can remove the disc.
Yeah, because as you mentioned, in some time that's when there is a big central disc,
Yes.
which is almost at the level of the coda equina.
Yes, yes.
Yeah, you have to.
Better not to keep any fear about para UV procedure. If you are in doubt, don't go for UV, go for para UV. That is safe for caudals and for facet also.
Thank you. So next talk will be Dr. Gupta is here. Okay. The dilemma of choosing between the PLD and the LED. So let's see how can you solve this dilemma.
Good morning, everyone. This topic stands relevant for those who are practicing both the form of monoportal endoscopies, that is interlaminar and the transforaminal endoscopy. So many a times you land up in a situation where you think that I can do the surgery, I'm in transforaminally, or I can get away with an interlaminar approach. So there are ways to target like you can take it end on or from the sides as in transforaminal or this way. But the end result should be relief to the patient and without any complication or taking care of the safety profile of the patient. I know there are many stalwarts in this hall who have gained expertise over the years to perform these surgeries without any issues. I mean, handling all the situations very comfortably through their technique. But that comes after years of experience, and then you would not be landed in such dilemmas then. So take this discussion as part of suggestions rather than standard recommendations. So what we consider while choosing which option should we take? Symptoms. If somebody is having unilateral symptoms, then it's better to go for a transforaminal approach, target the symptom causing pathology and get away with this thing. And if somebody is having bilateral issues, then it's better to go for interlaminer because it's better to put one incision and address both the sides in one go rather than going for 2 incisions for transforaminal approach. Then distribution of the pain. If somebody is having more than one level of issues, then it's better to address it. If it's unilateral, you can get away with a transforaminal approach, but it's bilateral, then it's better that you go for an interlaminer approach. Then the location of the pathology does matter. Which level is affected? Like, the interlaminer space, it broadens as you go down in the lumbar region. So for L5-S1, it's preferred that we go for interlaminer approach for any disc-related issues rather than a transforaminal because there are some anatomical restrictions in that. But as you go up in the L1, L2, L2, 3, these levels, if you can get away with a transforaminal approach and you address the pathology transforaminally, it's better because the foramens are broader and there would be lesser neural handling and resection because you need to get access to the disc after having done a good amount of bony resection. So depending on the herniation site, like where for central herniation, it's better to go for interlaminer approach. For foraminal or extraforaminal disc, you can perform a transforaminal approach. And for calcified disc or severely migrated extruded disc, it's better we go for interlaminer approach. So annular tears or something, I mean, we can go for transforaminal approach because we can land up just subannularly and you can address that pathology very well through transforaminal approach. Dorsal pathologies like ligamental hypertrophy as in spinal canal stenosis and all is better to go for interlaminer approach where you can address both the sides and clear off the compression. Instabilities you saw, I mean, in the previous talks as well, you can do fix the problem interlaminer approach or through transforaminal as well. So there are other patient considerations too in clinical practice that you need to consider. Age of the patient. In the extremes of age, like the patient is too old or the patient is too young, they try to avoid surgical interventions. So whatever minimal footprint you could put on the spine and relieve the patient out of his problem, that would be recommended. Comorbidities, there are many a times you land up with patients who have too many comorbidities where the risk of anesthesia and the surgery is too high. There you have to do a minimally invasive thing so that to give him relief. Also, in cases where previous surgery has been done, especially in open spine surgery, it's better to opt for a virgin path through transforaminal approach to address if it can be. If you cannot handle it through transforaminal, then that is the last resort. You have to, redo the interlaminer thing. Then patient's expectations. It's very important. You have to match patient's expectations with whatever you want your surgical outcome be. So you do not want a very elderly patient to run for a marathon. So if something which could relieve his pain doing with the minimalistic approach is advisable. Lastly, it's operator's ease. What I am comfortable with. If I am comfortable doing transforaminal endoscopies more than the interlaminar approach, then it's better that we go for that. There are some case scenarios like in this L45, though it was advisable to go for a transforaminal route, as I said, but since the disc herniation was such that there was inferiorly migrated disc and it was a big, huge chunk, I preferred to go for an interlaminar approach. So it was a 55-year-old male patient who had back pain radiating to right limb, and we did an interlaminar approach in this patient. Now it's a routine canal stenosis with severe stenosis at L4-5, 70-year-old lady with neurogenic claudication, and we did the routine interlaminar decompression. But in contrast to that, this is another canal stenosis patient where a transforaminal, the patient had selectively right-sided pain only. And we did a transforaminal epidural steroid, which didn't help much. The case was that the patient was a known case of COPD. He was in the ICU, had CAD, hypertension, all those things. And he was recently discharged from the from the ICU, unable to sit or walk or stand. And it was very much required as per the medical need. So we did a transforaminal endoscopy at L3-4 and 4-5, and the patient got relief of the symptom for the time being, and it was just 1 year back, and after that the patient had to undergo a interlaminar decompression just for the neurogenic claudication. When he started walking, he got the pain on the other side as well. Then this herniation, a very small one, inferiorly migrated at the left side. We preferred doing it transforaminally because the patient was an 84-year-old guy who was a known case of hypertension with very low ejection fraction. So transforaminal endoscopy was done. In this case, it was a redo surgery. Patient had undergone, L4-5, L5-S1 open spine surgery earlier, and he was just 35-year-old. He had symptoms on the left side with L5 dermatomal pattern. We did a diagnostic block from the left side, and after having done that, confirming the symptom, the source of the pain, we went for the left-sided transforaminal endoscopy, and with the conclusive results. Then this is a case of huge disc herniation at L4-5 down migrated. We did, though it was, I could have gone get away with the interlaminar approach, but we chose for the transforaminal approach because the patient was 24-year-old. He had cauda symptoms, but he was not ready to undergo a spine surgery, come what may. So we come across such patients as well. So we try, counseled him that we will go for the transforaminal approach. If not relieved, then he will have to go interlaminar decompression. So anyways, we could manage to remove the fragment and the patient was fine. So in a nutshell, for L5-S1, we perform interlaminar, we prefer interlaminar. For foraminal things, we can get away with transforaminal approach at L5-S1. L1 to L4-5 is preferred, that if we could manage transforaminally, then it'll cause less of neural handling and bone cutting because it'll be going through a natural orifice. Foraminal stenosis is better to be addressed transforaminally. Then central or lateral recess or calcified disc or something, it's better to go for interlaminar approach. Unilateral symptoms, yeah, if it is confirmed, then we can do a transforaminal approach, which is better. Bilateral symptoms, interlaminar, and instability, 1 or 2 level, you can do either way, as the stalwarts say. I mean, you can address and fix the things either way. So that is from me, and I hope you gain expertise over the time and you get rid of these dilemmas, which path is to be opted. Thank you.
Yep. Thank you for your nice presentation. And I think many points highlighted. Any question from the audience? I only have one concern about the central disk. As we all know, that most suggest to do transforaminal approach in the central disk because of manipulations of the nerve roots. So you recommend to do interlaminar approach in the central
So
disk?
it depends if you can get a flatter approach to the central part, like at the level of L4-5 or maybe 3-4, you can get up to the midline. So there you can retrieve the fragment and address the pathology. But many a times the bulge is such, I mean, you cannot justify doing it transforaminally. There you need to, go, at least you would be decompressing the level from dorsal aspect.
Yeah, I think that's for central disc. Let's summarize it. If you are planning to do it, whether interlaminar or transforaminal, you need much more experience, not as a beginner cases.
Exactly.
Because if you go to interlaminar, I think that's you will end up with almost, if it's not nerve injury but paresthesia, and if you go transforaminally, you will be not an easy. It will be not an easy way to get it and reach the central disk space.
So that's what I highlighted in the initial slide only, that with experts,
Yep.
if they have mastered their technique, they can deal with any of the situation their way. So
Thank you.
Thank you.
Who is the chairperson? Now we'll start the next session. I would like to invite the chairperson for the next session. Okay, same. Okay. So let's start the next talk. Transdiscal ultrasound way of spine for perfect spine endoscopic discectomy. Dr. Neeraj Jain. Interesting talk. Yeah, you had a talk right now. Yes, correct. So this is session 4.
They are not mentioned session 4. Yeah. Session 4, yeah.
Dr. Neeraj Jain, Dr. Ajay Krishnan, Dr. Ajay Krishnan. Dr. Ajay is not there. And Dr. Abhijit sir, so be ready with your. Dr. Neeraj sir, 10 minutes for you. We are running short of time. Yeah, thank you very much, sir. You are already very fast, sir. Thank you, sir.
Ajay is not there. So.
The next talk of, yes, your Dr. Abhijit, then Dr. Anand Kavi, sir. He's gone outside.
Hello. Yeah. Dear friends, we could talk something very, very novel today. And this is in relevance to all your work. So I thought I'll just share with you. It's so novel. This first time in the world and I shared in New York World Congress too. So probably we're going way up, way next, and that's advancing the innovative interventions. And the idea is, I presented in New York, I told you, there's no conflict of interest. So we're going to talk about transdiscal. I think, let me see the topic, if you please allow me for a second. This is transdiscal, fine, it's okay. Come in here. Quick. इसको slide show पे कर दे जल्दी से. Quick. So because we keep saying the recurrent days, residual days, and all these patients will keep coming 10 to 15% time for a repeat surgery, and that's where something we have a very new technique whereby we can avoid all these things, and I haven't had a failure yet after starting these techniques. So I'm just sharing with you. Yeah. So we got to help these people in, and that is, well, we have to turn this agony into happinesses as far as we can. These are some jumlas you can say, but still they are true to life. Endoscopy is proving itself, it's coming very big now, and we all surgeons around, we understand how big is this. This is like interventional cardiology is taken a bigger lead than the surgeons. So that's what it is going to be, the MIS or the spine surgery, what you're doing, endoscopic one is the one. Now this is a very nice slide just to show you. We talked in the morning, interlaminar and contralateral over the top and going transversely inside out and outside in. It's a very good view of that. But there are reasons where we are concerned. Our view is 30 degree. We are not able to see something which is inside the canal. And we understand the optical range. We can't really always convert it to like outside in approach or inside out approach always. And that's what it is. You see a big disc in there. If you're lucky, you can go in one piece, one time. And that's what you really want. One go, everything is out and it's overdone. It's finished. The whole thing is finished. Or another one which is a very big fragment lying in the canal. You can't see it optically. You depend on that you pull this and the whole fragment will come out. That's what it is. But that's not always the case. This was the fragment you can see it's lying inside the canal. We could get in one go. You can go interlaminar and you can just take it out in one go sometime. And you can see the size of the fragments is good. But there are times that you're not that lucky. Another such patient, large central disc with some cortic-vena syndrome, and you can imagine this cord is getting compressed, is already had a symptom, and we could go transfronally and extract it all out because there was a neural tissue lying over the cord, over the disc, and that's where we go transfronally. But yes, today only Dr. Kiran was showing this very good slide. I just pulled this slide in there. When you're doing this procedure and there's a large fragment lying inside the canal, your optical range is 30 degree. You can see up to the annulus. You can see at the most the defect in there. But sometimes you can't see beyond. And that's where sometimes the big problem is. You're trying to take the fragment out, it gets broken, it floats into the canal or lies back in the canal, and then you have to convert, or you go outside in then. So there are a few things which can be done. I've devised one technique, and that's the ballooning. Just like a CBD stone, we just remove this balloon, the fragment towards your orifice, surgical area, and take it out, fish it out. It's called fishing it out. Or you can do a scope through scope, like bendable scope is there. You can put a bendable scope through scope and go and see through the rent. If you have a rent in front of you, you can see this. This slide is very, very recent. This is just 3-4 days back. And this is a surgeon, this is a doctor, by the way, in Canada, and he's been operated there. And this is, you can see there's a large surgical rent in there, and he still has got those two big fragments there. He's in very big pain, and he's going to come to India for the procedure. I'm going to take lead from you people what is best for him now. But these things are known. It's a day in, day out thing. And this is like another such patient. We do a spinal cord stimulators and all. This patient has been operated at least 12 times, 6 times open, 6 times interventions. Still they keep coming. Or some people who have a synovial cyst, we want to operate, you go interlaminar, fine. If you're going like here or punching it, you can't really see something. These are few things which can be done with this new novel technique. I'm going to just quickly come to that point now. Yes, we've been doing epiduroscopy, but that's, and along with the conjunction with the endoscopic discectomy and all, and that does help really show there's a new residual fragment and all. Yes, MRI OTs are good. If you have MRI suites, you can do this work in there. But that's not always possible and it's too costly. But ultrasound machines are everywhere in all OTs, So you can make use of this new technology, which I'm going to share with you. And it's a revelation, by the way. And you're doing ultrasound guided DNCs and ultrasound guided biopsies and whatnot, day in, day out, and you know how beautiful this tool is. This is the ultrasound probe I'm going to talk, which goes through the scope. And you're seeing this is scope, and this probe goes through. This has got a side view there, and you can really see the things out beyond optical range. Now that's the whole point I'm trying to bring. You can see, just like we do biopsies and all, everything in there, and I'm going to show you the procedure now. When you're done with, finish with the endoscopic work, you can do it before also if you want. Done with the, just to comparison, endoscopic work, everything is done. There's the annular rent there which is there, and you're not very sure if everything is taken out, is there no residual fragment. Now you put in your scope in there, and I'll show you that image now. Put your scope in there, and through the scope you see these images. You start seeing the end plate like this. You start seeing the spinal canal. Now the whole idea is you're seeing a decompressed spinal canal along with the roots floating in there. It's like a starry appearance there, and there's no compression, round canal. That's what you look for. This is the end plate. This is the spinal canal in there, and you have pulsations, you have vessels, and that means you've done your job. You decompress the canal. I'll show you a few patients now after this. And this is, you see the end plate, you see the canal, and you have the endoscopic view also. So you can have endoscopic view, ultrasound view, optical as well as the ultrasound view. That's what you look for. Ultrasound sees 360-degree all around, and it goes up to 3-4 centimeter all. So that's what your spinal canal is all about. This is the view I'm saying. Through the scope, I put this ultrasound thing probe. I'm trying to see the end plate. I can rotate it around, lower end plate, upper end plate, through the posteriorly into the disc, and I just see the dorsal part of it. And you just see the next slide is that I recently, just a few days back only, I did a patient who has got this symptom, young girl, about 38, and there's a fragment lying in there. I'm doing a work in there. Now, why I'm showing this slide is, you look at this annular rent, which I'm going to see there, what I'm going to see beyond, and this is it. And when I'm finished with my procedure, I put my ultrasound probe in, and that's what you're going to see in there. You're going to see the canal. This was the close initially, pre-procedure. And that is the post-procedure, see a decompressed spinal canal. You're not seeing any CSF in there, and you see decompressed spinal canal. Next slide, I'll just show you after this, and that is a video, by the way, quick video for you. And that is what you're seeing. You're seeing the ultrasound view and other views also. And this is, quickly, I'll just see if I can show you. Yeah, here. If I can show you this. There's a video in here. Yeah, fine. So you can just quickly, I'll come to the portion where it's relevant for you. इसमें forward कर सकते हैं? No, not on the same video. But anyway, I want to show you something which will come in 40 seconds, so bear with me. So you're seeing it, you're seeing the scope view, you're seeing the ultrasound view, and you see arm view. The three views you're seeing, and very quickly you see the annular rent. Incidentally, I wanted to show you because this video is not timed there. I'll show you the ultrasound view of it. And you're going to see now, very soon now, you're going to see quickly, you're going to see there's a rent which is showing. Now you can see the rent which is showing. Yeah, can you see this? All of you, please. Can you see the annular rent there? And that's the spinal canal, annular rent. It is going through this is the annular rent. Once I see the annular rent, next thing I do is, I just go in there and close this annular rent. You've done a good discompression work. This annular rent is there. You're seeing through the ultrasound. There's nothing left inside the canal. Next best thing you do is, you close this annular rent. Because you don't want to leave something for a recurrence or coming back again, because there can be larger annular rent with a larger disc. Look at this big kind of thing in there. So what you do is, we don't want that. We know about post-surgical scenarios. Many times people have gone 3 surgeries. Endo work, microdiscectomy, open surgical work done, and still in the list in there. So that's what we want to avoid. And we know about the menace of recurrent disc herniations. And they're already putting AI in job to calculate which patients can go for recurrence and all. This is what I've devised. I take a absorbable mesh in there, cut a piece to the size so I can go across the disc, put in there, and then fix with the tacker there, and just fix the inside. And you can have a view, good view of the endoscopic view of this. And you put across, go tuck the other side first, and come out and tuck at the SAP on this side, and the whole rent is taken care of. I was showing you an ultrasound, that rent. And that is a tacker in function, you know, that's what he's putting. Just like a inguinal hernia mesh plasty. And this is the patient walking very next hour, walking in the post-operative room, and back, to life as soon as possible. You can make use in the other scenarios. Now it's expanding indication with the synovial cyst and all. You can make use of this. Yes, you got to do your bit, your way, and best possible way, so that people can get rid of the problems and they have a lasting relief and almost no recurrence in my case. Yes, one thing to add, I always add a PRP plug at the end of the procedure. When I've done this mesh plasty, and at the end of the procedure, the rent is there, I put in my PRP fibrin plug, and that will take care of the any kind of recurrence, or it'll give a healing to the patient. Thank you, my friends. Thanks for your time. Thank you.
Thank you. Thank you, sir. So nice, wonderful innovation.
Innovation is like marriages of concepts, you know. You know things and how you can apply where, and that is what is made use of in this very concept.
Yeah, can I ask you one question, sir?
Sure, why
you
not?
asked it's an absorbable mesh.
That's right.
So if it's absorbable, how does it prevent recurrence? I mean, if it gets absorbed in.
So absorbable in over 3 months, and 3 months is good time for annular healing, and it always invites fibrosis. When doing all this mesh plasty, what is the next thing is ventral mesh hernia, ventral repair. It causes fibrosis over the mesh, and you're depending on that fibrosis which is coming along with this.
So what material is it made up of, that mesh?
You ask for absorbable mesh, it's all available.
Acha, okay.
It's all available. Ask for absorbable mesh. And even to the point, I'm putting absorbable tackers. I'm not putting those metal tackers which can get misplaced and get into the zone where you don't want, and that pain impinging onto the root or dura or cord for that matter.
Interesting.
That's why I'm using these things. Please, sir.
How you sterilize that? How? How? Because I am worried about the infection. Even rigid endoscopes in Europe, they advise autoclave, no plasma, no ETO. So if you are using a fiber optic, how you sterilize? Because you are putting inside the disc space. Those are the 5 minutes you are going inside with a relatively less sterilized part of the instrument.
I agree that there is a concern there, but by the way, these all instruments can be put in those new Sidex, which takes 5 minutes and sterilize it. And then I just clean the ports also. All ports I wash with the same thing. I don't leave the port there. I take a syringe, sterile, and then wash through the ports, and thereafter I take a clean. And then it's in a running flow. And at the end of the procedure, I do put antibiotic inside the disc, intradiscal antibiotic.
You need a fiber optic. You have an endoscope, a rigid endoscope with a nice view. You are
going through where you have a non-optical view. Endoscope is only for then why you use the endoscope everywhere in the body?
You can use a 70 degree then. You have 0 degree, 30 degree, 45 degree, 70 degree, 120 degree. You can have.
That's another point.
Thank you very much, sir.
Thank you. Thank you,
See,
friend.
maintenance
Thank
of
you.
the endoscopic instruments and sterilization is a bigger issue, and that can be taken care of. And subsequent sessions will going to take care of, or rather find it out what are the maintenance and sterilization method for the endoscopic instruments. Dr. Abhijit sir is there here for minimally invasive TLIF, a workhorse for lumbar interbody fusion. Dr. Abhijit Pawar.
First of all, I'll thank Dr. Malcolm, sir, for arranging an excellent conference. It's an amazing job he has done with inviting so many faculties and his large-scale cadaveric workshop and excellent talks throughout all three days. Thank you, sir, for inviting me. So I'm going to talk about minimal invasive TLIF, a workhorse which has stood the test of time and interbody fusion. So what is a workhorse? It's something which is markedly useful, durable, and dependable. So when a patient with listhesis and stenosis comes to you with claudication, he wants a procedure which is gives a guaranteed recovery, guaranteed decompression, and guaranteed fusion. So that's what I call this minimal invasive TLIF. It's still the dependable horse, which always gives good results. So there's a short video here where this minimal invasive TLIF done under navigation guidance. So initially the tracker is placed, then the OARM shoot is taken, followed by a placement of guide wires and screws under 3D navigation, so that avoids radiation to the surgeon. So when you're doing 1 or 2 level TLIFs or 3 level TLIFs, you can avoid radiation exposure to the surgeon, which is a concern nowadays. For a single level patient, it's not necessary to use an OARM in my opinion, because it adds cost to the procedure. For multiple level fusions, it definitely avoids radiation, and the accuracy of the screws is good, and especially in patients with degenerative scoliosis. Once the screws are guide wires are placed, then you can place the dilators, ciliary dilators, followed by the matrix tube or the quadrant system. Now, most of these patients with degenerative listhesis and stenosis have a very high central stenosis, ligamentum flavum thickening, fascial cyst, and they will very severe claudication. So I still firmly believe that decompressing them under microscope gives a excellent visibility, excellent all-round decompression. You get a good bone graft for fusion. You can see the nerve roots, all the exiting nerve roots on the contralateral nerve roots. You can remove the flavum on both sides. So you go to sleep well, that okay, I have done a good job. You have good graft left with you, which goes in the disc spaces, and not just the frackling, which sometimes I'm worried that does this really fuse. Because at the end of the day, we want a patient who fuses and whose alignment is correct, lordosis is restored, and he fuses in the next 3 months. And because we don't want to have a revision surgery, and these patients who are mostly elderly, about 65 years of age, or maybe even in 70 plus years of age. So the risk, so this is the procedure. We'll go to the next slide. So this is a patient with recurrent stenosis and instability, a 74-year-old obese patient. L4-5 decompression done 2 years back. You see there is a listhesis at L4-5, significant stenosis in the MRI and instability. So a tough case to deal with any other technique in my opinion. So you place a quadrant, and MIS can easily be done with a good local graft. And since she had a decompression done 2 years back, this time we ensure a good placement of screws, a good amount of graft, a large cage, and restoration of local lordosis, as well as good fusion in 3 months. So there is enough literature to show that a minimal invasive TLIF has a comparable results with other techniques. There's another patient with 2-level listhesis, and the young patient can be comfortably done with a minimal invasive approach with the TLIF. L5S1 can be challenging with the OLIF or other approaches like a transcambin approach, because the approach to the iliac crest is the trajectory is a little tricky. If you place the cage improperly, it can you can land up in the end plates, and you can end up getting incomplete decompression. And doing a revision in these patients with the transcambin approach or any other approach is extremely tricky. Removing the cage which has gone through the foramen is, I have done few cases, extremely difficult to remove these cases which have gone into non-union. So it sounds very rosy that put a cage to transcambin. It's very easy in my opinion to put that cage, but if it doesn't unite, you should have a mechanism to remove that cage. Otherwise, this patient, it's a disaster for that patient who is into 80 plus years or 70 years old and who needs a revision spine surgery. So relatively, I feel the minimal invasive TLIF, it works and it has tested the time, it has proven over a period of time. Multi-level listhesis and instability in an elderly patient can comfortably done. 2 or 3 level TLIF can comfortably done in these patients with a minimal invasive approach with a use of matrix tube or a quadrant system. Now the quadrant system is a very rigid system. It is once it's bought, it doesn't get damaged, so it is cost effective because it gives you the returns when you buy that costly instrument. Other instruments which I feel with the endoscopy sometimes is, there is a lot of breakage of the instruments and they are very costly. The plasma and all those radio frequencies, so you can end up investing too much money in those instruments, and then you got to get the returns for the surgery. So advantages of minimal invasive TLIF, there is no change of positions. You don't need access surgeon as a OLIF. there's no risk of vascular injury, and there is no risk of lumbar plexus injury. So which I sometimes feel with the OLIF or all those approaches, I mean, even if there is 1% risk of a vascular injury or uretary injury, that 1% risk is a disaster for that patient. So that I'm not worried. So TLIF, minimal invasive TLIF always works. It gives a graft, restores lordosis, and gives a good fusion. Even in degenerative scoliosis, elderly patients, you can do a multi-level fusion at the symptomatic level, restore the alignment fairly good at that level, and patients do well. So there is enough literature to show that minimal invasive TLIF has stood a test of time over all these years. Any other levels, L2, 3 disc, you can comfortably do an MIS TLIF, L1, 2 disc and stenosis. You can use the metrics quadrant system, decompress all those levels under microscope. You have excellent vision, excellent hemostasis, excellent bone graft, and guaranteed fusion. So I still feel it has got a lot of importance in spine surgery. D12 L1 disc, yes, it's a challenging disc. There's a conus at that level. Still, you can safely remove the facet, get a good graft, go from the side and decompress that level and remove that hard calcified disc at the D12 L1 or L1-2 levels. They are challenging discs. So large traction can put a risk of injury to the conus or the quadra equina. So these are the cases you see. Most important advantage I feel is I sleep well. I know that this patient is going to fuse well because I have got enough graft. I have used any other adjunct bone grafts if necessary, and these patients fuse in 3 months. So that is what we want to see. At the end of 3 months, patient comes to your follow-up, and you're not worried whether this implant is going to fuse, because this is a fusion surgery, and it has to succeed. You can't wait for the fusion to happen as the patient comes for follow-up. So advantages: enough local graft, good restoration of lordosis, a single double level fusion almost similar to OLIF in most of the studies. And advantages is, it doesn't need any BMP or frackling kind of grafts, which BMP is expensive. I don't trust frackling or all those grafts because it's not biologic. I mean, I don't feel it fuses because frankly, I don't go to sleep well if I use the all these graft substitutes. Which are made up of hydroxyapatite, and sometimes they are so cheaply available, like 1,500, 3,000 rupees. I sometimes wonder where they really work. And the side effects of BMP, radiculitis, retrograde ejaculation, male sterility, cancer, infection, osteolysis, ectopic bone formation, and most common is non-union with the use of other grafts, which is a non-union is a disaster in any fusion surgery, whether it's done by OLIF or transcambine approach or anything. In this elderly group of patients, if it goes into non-union, it's a complete disaster for that patient. So MIS still remains the workhorse for lumbar interbody fusion, in my opinion. Thank you so much.
Thank you, Dr. Abhijit, sir. So nicely, precisely, timely concluded. Anyone want to ask few questions? Meanwhile, I'll call upon Dr. Anand Kavi, sir, for targeted spine endoscopy for lumbar canal stenosis. Dr. Abhishek, sir, Dr. Abhishek Kashyap, Dr. Vinod Kumar, please chair. I'll ask Dr. Gajwan Hassan to get ready for the next talk.
Good afternoon, everyone. Congratulate Dr. Pestanji. He has worked very hard to make it work. I think we'll start with the talk. It's going to take time, sir.
Yeah, looks like he's arranging for a converter to be attached to the laptop. So till that time, if you want, you can take the next talk.
No, sir. Meanwhile, we'll have a 1-2 minutes of previous few talks. Dr. Neeraj Jain, Dr. Abhishek, sir, anybody want to ask few questions in the previous talk? So this is session as question answer for 2 minutes before Dr. Anand Kavi sir start his session on targeted spine endoscopy for the lumbar canal stenosis. Yes, sir.
Is that a better way?
But how far it will tell us where the fragment is, where if any of it is there, I will pick it up from there.
No, no. What I'm saying is, you can have some sort of a guarded discography. In the sense, it does not allow the the dye to leak out. In such situation,
No, the point is, sir, we already know there is a big annular rent there, and there was a big fragment which is lying in the canal. So you've taken trying to take the fragment out, and we miss the fragment somewhere. It happens. It breaks,
also,
you know. So anything we put inside the disc now is not going to stay inside the disc. It's going to go into the epidural space in any case through the big annular rent which is there. Now, what to do with that fragment which we are left, or it is there? Should we leave it and we come home, or should we really try to find out and take it out? Or we do outside in now, or we do a conversion now? So that is what was the whole thought about. So when it is visible, mostly it is lying next to your, instrument. Mostly, you can do an angled, forceps, angle forceps or angle instruments. You can go and pick it up. So we just want to be sure where exactly it is. That's the reason we're putting in a little of that small thing will lead us.
but small things also should give satisfaction to the big guys who Rohidas who talked about sterility, no?
I know, I understand. That was a concern which was there. Very, very, very rightly said.
Thank you very much.
Masters, they have all things covered, all things covered. I know, sir. I know, I understand, sir, but we try to do a proper. No, but all these endoscopies are done, the flexible or the rigid ones, they are done with the sterilization, and they are doing it day in, day out, sir. Respectively, they should be good.
Anyone has an Apple adapter?
Dr. Ahmad, do you have that Apple adapter? Yes. Bhaiya, brother.
Sir, actually you had come up with a very logical solution that you inject a dye which will give us a very nice epidurogram, and in case there is some hard tissue remaining back, we can very well see that on an epidurogram. It will come up as a space occupying lesion, so we can confirm whether we have left something behind. And yes, fulminant discitis is a real worry because the internal milieu of disc is aneural and avascular. So putting in any thing, even the PRF and PRP, people have got fulminant discitis, maybe aseptic, but that is a real issue whenever we do any kind of intradiscal procedures. So
that's why I tend to combine. When I do this thing, I always try to put an antibiotic inside the disc and do my final works thereafter.
No, whatever you are doing is really path breaking. It may come up with something really great.
Yeah, that's what I'm saying, yeah.
But then I
thought I must share with the learned audience here,
yes.
so there's something new.
Thank you, Dr. Neeraj. See, ultrasound has been used previously also. They've been using it for residual decompression at even in open surgeries.
True.
Yeah, so they've been using it in thoracic myelopathies. They've been using it for heart calcified disc. Maybe doing it with an ultrasound with that probe might change, maybe a game changer for you.
Sure.
So I invite Dr. Anand Kavi. He'll be speaking about uniportal endoscopic targeted approach to lumbar stenosis.
Okay, so without much ado, I would just start off with my presentation. So I'll be speaking on uniportal endoscopic approach to lumbar stenosis. I would like to bring to your notice this basic pathology. Acquired stenosis of degenerative type is due to changes in the three-joint complex. Now this can start with facet degeneration, synovitis, Then there is increased facet capsule loosening, increased motion at the segment, accelerated disc degeneration, and finally body tries to stabilize with osteophyte formation and ligament flavum hypertrophy and mineralization. And all these things contribute to lumbar canal stenosis. Now this lumbar canal stenosis, that pathology can be ventral to the sac, it can be dorsal to the sac, it can be lateral to the sac, and it can be around the exiting route. So we need to identify the pathology and target it properly to get an excellent result, and which can be very well done with monoportal endoscopy. Now traditional spine surgery, whatever we do like lumbar discectomies or large stenosis decompression or large exposure surgeries, where we cut spinous process, the muscles are elevated, and there is laminectomy and facetectomy is done. So these are very challenging approaches for a very small pathology in the depth, and we have to go through several layers, particularly difficult in obese patients. And most studies in literature have shown that even after a good decompression, there is decreased leg pain, but not back pain. And this is due to the collateral damage which we cause due to our approach. So this is a basic picture of traditional surgery where we are removing the flavum to approach the canal. But what is the final goal? It is the decompression of the nerve, and which has to be safe and definite. So whatever collateral damage which we cause due to invasiveness increases the post-operative morbidity. So these are the comparative scars of the two procedures. Both are my own patients. One is around 15 years back and one is 5 years back. So with the evolution of several techniques, microsurgical techniques were developed. Dr. Yasser Gill introduced microscope. Then various retractors were developed to reduce the muscle trauma. And what were the lessons learned? That we require a preoperative planning, we require an access strategy, and we require respecting anatomic pathways. So 3 systems were developed, the tube systems, the mini speculums, and 3 approaches were explored, that is the interlaminar, translaminar, and transforaminal approach. So endoscopic techniques were being developed parallelly, and Dr. Hijikata is credited with transcambin approach actually. Later on, Dr. Pervez Cambin defined the safe triangle anatomy, and then the ES system, that is the transforaminal endoscopy, evolved further. Dr. Rutan is also credited for starting the interlaminar techniques. Now coming to what is minimally invasive surgery. We all know these are the basic book definitions of what is minimally invasive, what is minimal access surgery, and what is natural orifice surgery. So can we combine all these definitions with monoportal surgery? Yes, we can. And a monoportal endoscopy really satisfies all the conditions for all these definitions. These are the representative diagrams of the approaches of 3 different decompressive surgeries, that is the open discectomy or microlumbar discectomy, the MED, and the transforaminal surgery. So this is the minimal footprint what we get with monoportal endoscopic surgery. Some newer concepts. Now, as I've said, that we need to target where the stenosis is. Stenosis is not, every time it is not around the canal or the thecal sac. Most of the times it is the lateral extension of the flavum in the intervertebral foramen which gives rise to stenosis symptoms. Now symptomatic stenosis in foraminal and subarticular zones are actually very much neglected. This is a diagram of a practical MRI grading system for lumbar foraminal stenosis. I would like to bring to your notice the last enlarged square, where you can see that the 2 boundaries around the exiting route are fixed, whereas the disc and the lateral extension of flavum are malleable. So we can change these 2 boundaries to release that exiting route and get good relief from symptoms. So friends, claudication and radicular symptoms, they can be unilateral or bilateral. Bilateral claudication can be due to bilateral foraminal stenosis and not always central stenosis. Now, in case you come across patients with bilateral stenosis, you need to inquire that whether the symptom has started on the same day, and commonly the reply is no, it has started differentially. Now let's come to the radicular pain. and these symptoms are due to compromise of the dorsal root ganglion and not posterior to the dural sac, which we usually decompress in our conventional interlaminar approach. The commonest symptoms what we see in our patients, nearly 70%, are due to L4, L5 dorsal root ganglion, and which is inside the foramen. Now with the advancing age, what happens is there is no change in the dimensions of the bony boundaries of the foramen, especially after the skeletal maturity. What changes is the disc height. It reduces due to the collapse and it herniates. And then what happens is the tip of the superior articular process, it rides into the superior part of the foramen, and then tissues around this tip hypertrophy and make the area more narrow, hard, and unyielding. And this is the reason for compression of exiting root, which gives rise to claudication more often. Another thing, the exiting root is very tightly held in position with foraminal ligaments and which do not allow it to move. And with foraminal compromise, there is increased vascular congestion, and this is the reason for classical neurological claudication in our patients. So foraminal decompression and detachment of this lateral border of ligamentum flavum is very difficult from posterior approach. Access to the ligament flavum from till the lateral attachment at lower lumbar levels requires more resection of lamina and pars, and then we create iatrogenic instability in these patients, and that is the requirement for fusion. Yes, but it can be approached very easily by transforaminal route. Endoscopic approach around the superior articular process is very easy. Removal of the lateral spread of the flavum and the junctional tissue gives excellent relief to the patient, and it is very lasting. I have more than 10 years follow-up of my old patients, and they are completely symptom-free even today. This is a very important anatomical landmark. This is the line passing through the inferior end plate of the upper vertebra, which touches the superior tip of the superior articular process. Now, whenever there is a collapse in degenerative spine, this SAP tip will be cranial to this line. There is a very good literature study by Saeed Usman and his colleagues, and in their conclusion, what they said was that by transforaminal route, we can create a significantly larger decompression without the risk of surgically induced instability in most of the stenosis patients. And mind you, this we can do under local anesthesia in a completely awake patient, so there is further added advantage. So this is the basic endoscopic view what we see through the transforaminal route. We land between the Cambin's triangle. This is the tip of the superior articular process. We do a limited burring and remove the inspissated tissues around that tip to get a good clear vision of the axilla and complete ventral aspect of our dural sac. We require simple instruments for this: the hook, curette, endoscopic Kerrison punch, a burr, and an up-biting forceps. Let's see some video examples. It's playing. Okay, herein you see that we have just landed at the superior articular process tip. So we do a limited burring of the tip. And as we do, we come across this lateral expanse of the flavum, which is extending into the intervertebral foramen. So we tease it out, we separate it out from the neural tissues. And this is a 3.5 mm endoscopic Kerrison being used. And piecemeal, we can remove that flavum completely to actually see the exiting root, the axilla, as well as the traversing root. Now, sometimes the pathology is ventral to the thecal sac, like in this case, there is a down migrated fragment, which we can very well go there underneath the dural sac. And as Dr. Rohidas just pointed out, that it being a rigid endoscope, we have an excellent vision. So we can actually see what we are doing there. So this is the lateral recess being decompressed. This is the dural sac. Another case of foraminal stenosis, that is a parasagittal MRI scan, and this is the lateral recess. This is the ventral osteophyte, which is causing ventral compression of the thecal sac rather than posterior compression. So again, you approach it through the foramen. You do limited burring. So you are not creating any instability there. The facet joint is completely intact. What you have removed is a small tip, just 2 millimeters of bone around the superior articular process tip. Now this is that osteophyte which we have seen in the MRI. So you can use an endoscopic chisel to morselize that bone. Once you do that, you can remove it piecemeal in total. And all these things you are doing completely under local anesthesia and minimal sedation. So even in very old patients with completely multiple comorbidities, we can very safely approach. So once you remove that piecemeal bone and the ligament flavum around it, the area is completely decompressed. That is the ventral part of the thecal sac, the lateral recess. That is the axilla, that is the exiting root. So you have taken care of 3 pathologies, that is a ventral osteophyte, foraminal stenosis, as well as lateral recess stenosis. This is the post-operative MRI showing the good lateral recess stenosis and recreation of the foramen, where you can see that the exiting root is totally free. So we should be worried about this structure, that is a radicular artery shoot which just passes cranial to the exiting root while you are doing the surgery.
Last 30 seconds, sir.
Yes, I will skip through. There are no technique or no surgery is devoid of complications. There are complications here also. What can happen is dysesthesia, which is usually short-lived, but which can be very well controlled with analgesia. Yes, dural injury, bleeding, discitis, these are possible, and you need enough experience to handle these things. There are pathologies which are beyond transforaminal approach, which we can very well target with other techniques like interlaminar, PSLD, or UBE. I would skip this presentation because this will be taken care of in the subsequent 2 days with multiple speakers. So thank you very much.
Thank you, sir. Very good demonstration, very good video. Thank you very much. I call upon next speaker.
Preoperatively, how do you know about this? Are there any ways to make out?
Sir, we'll cover few questions after this session.
Okay.
Sorry, extremely sorry. Yes, yes.
I will just give you a
meanwhile,
short answer.
Meanwhile, answer please.
I will just give a short answer to this, sir. It is said that you can only identify or diagnose the things which your mind knows. So one should be aware that it can be the foraminal stenosis or pathologies ventral to the dural sac which can give rise to claudication, and not always dorsal to the sac. Thank you.
Thank you.
Thank you, sir.
Dr. Ghazwan Hassan, he is endoscopic spine surgeon from Iraq. He is going to present upon far lateral stenosis. It's time to reconsider the missing pathologies.
Yeah, first of all, I would like the organizing committee for giving me this chance. Actually, I put this title because the one that's who get the benefit from this title is me. When I deep dived in this talk, I saw lots of controversy, and my aim is to make it clear a little bit. So these are my disclosure, nothing to be related, and I will start with this MRI, which is a 4-5 disc in a middle-aged patient presented with back pain, radiculopathy to the thigh, and I did some sort of treatment, and this is the MRI post-op 1 year. So what type of technique that I'm using in this technique, in this patient? Transforaminal, interlaminar, UBE, other technique. This is a complete conservative treatment done as the patient just complaining from pain, and he refused surgery at that time, and I follow up. So my take-home message, first of all, don't miss your first wife. So these are my learning objective of the talk. I will have some definitions, approach to diagnosis of far lateral and extreme lateral stenosis, and have some cases and end up with the take-home message. So when I start to read about these topics, I saw that there are some terms, which is one of them. It's what's called lumbosacral extraforaminal stenosis, which is some sort of compression that's occurred to the nerve root outside the canal, spinal canal. And there is what's called also a lumbosacral transition vertebra definition, which is a variant, anatomical variation that's occurred to the spine. One of them is Bertolucci syndrome. And while the far out syndrome, it's defined that's the compression of the L5, specifically nerve root outside, which is due mostly to the pseudoarthrosis or any other pathology that's occur outside the, let's say, the spinal canal. And finally, the Bertolucci syndrome, which is actually some sort of the type of the lumbosacral transition vertebra, in which there is some what's called a pseudoarthrosis that could be presented with mostly back pain and sometimes with a radiculopathy. And when it's come to the far out syndrome, because in the literature, most of them they define as a far out syndrome is the same as Bertolucci syndrome, is the same as other type. But in the reference and the literature, they define as a far out syndrome, which could be occur due to the Bertolucci syndrome, but there are many other factors that could cause the far out syndrome. One of them is the, let's say, extraforaminal disc. And actually, the definition was put by Wilson and Danforth in 1925. And Wilson, who in 1984, who was the first one who defined the surgical approach, how to treat and how to decompress the pathology outside the cervical canal. And these are the type of the MRI in which the patient have both pathology. One of them, it is intradiscal, which is as seen here, and the other is a far out syndrome, as you see here. So two different pathology. And again, CT scan is very important, as you see in such cases. That's the main pathology is extraforaminal pathology that's occurred due to the osteophyte at the disc level. While the Bertolucci syndrome, as we know, it's some sort of the lumbosacral transition vertebrae, and it's occur due to the different either pseudoarthrosis or fusion, whether it is unilateral or bilateral, and the presentation mainly back pain. But there are some sort of radiculopathy, but all the reference supported that when you have a neurological deficit in the Bertolucci syndrome, you have to reconsider the intraspinal pathology that's occurred, because it's almost rare that the patient presented with Bertolucci syndrome and the neurological deficit. But radiculopathy, it could be happen. When it's come to the incidence, it's almost 4 to 18%, which is I start to reconsider it. In my practice, because it's a frequent cases, more common in the patient less than 30 years, and more common in the female in the male when compared to the female. And lumbarization is more common in the female, while sacralization is more common in the male. And as I mentioned, that's ASD for the level above, it could be occurred because it's, as we know, in the type 2 and type 3 Bertolucci syndrome, when there is a pseudoarthrosis and diffusion. So it's the same concept of the fusion that's occur. And these are the classification that's, I think that most of you No, and these are the radiological finding of this classification. And the clinical presentation, I just want to highlight the difference between the far out and the perturity. In the perturity, we almost see the back pain, while rarely the radiculopathy, while in the far out syndrome, mostly let's say the radiculopathy and even the neurological deficits that's occur. No patient presented with coda equina in both groups. Investigation, nothing important. As usual, CT, MRI, bone scan could be helped to identify the pseudoarthrosis. But in the perturity syndrome, you can confirm the diagnosis by local injection at the level of the pseudoarthrosis, while in the far out syndrome, you will inject in the foramen in order to identify the compression on the selected nerve root. Treatment, it is almost the same. Conservative started, non-surgical local injection, and radiofrequency could be worked in patient with perturity syndrome. While the surgery in the perturity syndrome, you have to have what's called a processectomy, in which you have to excise and let's say, do the pseudoarthrosis at that level, because the main pathology is back pain. While in the far out syndrome, you might do a decompression outside the foramen canal and unstable infusion in case of the instability. When it's come to the surgical approach, many approaches, but we will let's say concentrate on the endoscopically. From my perspective, I saw that's the endoscopic decompression or dealing with this pathology. It's difficult because unfamiliarity and also the depth of the surgical field. When you try to do it, you will discover that's how it's depth. And also, especially for 5S1, when there is an inclination, and don't miss the bleeding in this field, because almost it is intramuscular. So I will end up with couple of cases. This is a 30 years old presented with back pain, more than 9 month pain, mainly on sitting, non-neurological deficit. This is the CT scan. As we know, this is type 2 perturity unilateral. And this is the MRI, which is completely normal. So the patient only complained back pain. So the trial of injection was done at the level of the pseudoarthrosis, which was positive finding. And then later on, I did what's called the prostatectomy, which is by the UBE. And this is the first step, that you identify the bony bar, the extension of the transverse process. And then you will do, let's say, excision of this bar by high-speed drill. And also I prefer to use, in addition to the high-speed drill, the osteotome, because it save more time, and also let's say control the bleeding in this time. This is the second case, which is a 50 years old. He's a pediatrician. He came to me because of dilemma, because the pain involving the L4 nerve root, no response to conservative treatment. He did before L5 nerve root injection, but he didn't get any benefit. So when he came to me, I tried to consider there is, let's say, a bulge in the disc, and the patient presented with L4. So I tried to think about L4 nerve root. When he tried the L5 nerve root injection without no benefit, I discovered the perturity syndrome. So I did a far lateral selective nerve root injection, which is L4, and then after that I decompress the extraforaminal part of the perturity syndrome, just decompression without excision of the bar, because the patient has only radiculopathy without significant back pain, and he got response to the nerve root injection of L4. Last case, which is a 50 years old female, back pain, right side radiculopathy involving the big toe, and this is the MRI. As we see, it's an extreme lateral or extraforaminal disc, which is some sort of far out syndrome. And what I did, actually, I went up to a paramedian approach through by the UBE technique, and see how big the discs are removed from this approach without tackling the intraspinal canal. So my take home message, that's accurate diagnosis is mandatory, and we have to rule out other possibilities. I recommend all the steps started from the CT, MRI, diagnostic test, also check the intraspinal in addition to the extraspinal. If you see that's any patient presented with peritoneal syndrome, so this not always the pathology, so you have to figuring out the causative pathology. Local diagnostic injection, I'm always keep it in as a first step to deal with such cases, and decompression also could solve the problem, especially in most cases when the presentation only radiculopathy. Thank you.
Thank you, Dr. Ghazwan Hassan. We have the next speaker here, Dr. Nafas Sadoun. Okay. Okay. Do we have any questions for the previous talks? Dr. Anand Kavi and Dr. Hassan can take questions. Yeah, we have one.
Last two sessions question answer which remains. Meanwhile, I'll call upon Dr. Rodolfo Perez.
Hassan, and I have a question for Hassan. Hassan,
Yes.
what do you think about the resolving?
Meanwhile, I call upon chairpersons, Dr. Son Venture, Dr. Nantawat, and Dr. Sutipash. Please continue the question.
Okay. What do you think about the resolve two problems in this with the same approach? In biportal surgery, you can do it the descompression interlaminar and resolve from the transforaminal only without change a little the hold from the approach.
Yeah, as I mentioned, that's in the last case when I did L5 nerve root, the patient didn't get any benefit, but when I did L4 nerve root, the patient get the benefit. So I start to realize that the pathology is extraforaminal, so I did the decompression. But if I have both pathology, so it could be an option going interlaminar, doing let's say decompression, and in the same two holes and the same incision, you can go out by let's say extraforaminal and dealing with it. Double crush syndrome, that's okay. Yep, okay. Peritoneal syndrome, yeah. You know, when I have a couple of cases that I excise this, let's say, bar, one of them is recurrent after 1 year. So I start to realize that I will excise it when it's symptomatic. If it's not symptomatic, so keep it because it's already stabilized the spine at the end. Yeah. Thank you.
It's a great honor for me to welcome a very good friend of mine, Dr. Rodolfo. He's going to speak on a topic that's you need a lot of need to be very brave to be able to do this surgery. So, addressing myelopathy in cervical spine.
Thank you very much from all the professors and all the presentation and professors and the Congress for inviting me again from this wonderful program. And in these cases, it's an honor for me to stay again with you and represent to the Mexico people right now from the UV and from the world. And my team, my pathology or my topic about the cervical pathology is because we need to change to the form to the C, the endoscopic and the spinal surgery. Because when we're talking about the myelopathic, we need to change around to the C this pathology. It is wonderful to state here, AMSEVIC and the Association of the biportal surgery in Mexico is welcome for everybody, for all. And the problems with this patient is, with the patient need, what is the possibility to relieve or recover the life, and what is the risk benefits about this surgery or that type of the pathologies. And you remember the Dennis Column the simple processes or the simple physiopathology about this. When these fall, the building fall. In Mexico, we have 100 to 29 millions of the people, more women than men. But like India, China, USA, because that is the 10 more people who have in the world, the age of that people change. The curve is more from the old people. When we thinking about the myelopathic surgery, we're thinking about the different problems or different forms to treat that. Open surgery, conservative, microsurgery, posterior surgery, fixation, all without fixation. But the result of the principal thinking when we're talking about the MIS, we're talking about endoscopic, is primum non nocere. Change the open surgery for the endoscopic surgery. And remember every topic of the Dr. Lim, endoscopic surgery is like a fly a drone. We can change the form, close, fall, change the lateral, posterior, and this changed the form of the view, everything. Every part of my patients, every times, I try to do it with a neuromonitorization. You know that from the first the 2 years ago, and we try to do it that because it's more safe for me and for my patients. The principle of thinking that in the cervical, because it's different than the lumbar back, is try to imagine that it's an arch. This arch have a specific things. In these cases, it's like a lamina, pedicellus, and facet. And no matter what is the arc, in Guanajuato, Mexico, in India, in Berlin, in France, all have the same things. And you only need to know what is the form to the triangulations. Is more open the window, is more close and is the right side, is more close and is the left side. That's you thinking that's in the imaging, please. And in the cervical endoscopic surgery, you need to know what perfectly about the muscles steps. The specific from in this video is specific for see the steps in the muscles in the three capos. When you know that, you know in the lumbar back is very different when you stayed in the cervical. And the last year, in 2023, we're talking with Dr. Malcolm about this. When you have myelopathic problems, why not only open a big window and resolve the problem from 2 levels? And that is new. No is new for endoscopic, but no is new for the open surgery. That is a article of the 2020, and is defined the autoconfollowing, the laminectomy, the fusion versus only laminectomy with a degenerative cervical myelopathic. And the other one is the laminectomy for multi-levels for the cervical stenosis, a following for 10 years. And in both articles, the people show that the authors show not happen nothing because normally in these patients, the problem is resolved for natural fixation. You don't need to put the screws, you don't need to put a cage. You only need to free the medulla and the nerves. Let me to show one cases. This is a patient to 79 years, and that is the X-ray. It's obviously that is compression the medulla. This is the surgery. In these cases, we do it one lamina and hemilamina, the C5, C6, and we try to retire every compression around to the medulla. We need to know with these changes, and normal chronic changes, one is the bone is more easy to cut, but under the flavon ligament, we need a very congestive veins, and we need to take very careful that. In this, you can see, I do it open, a very big open, and after that, very careful, I cut the flavon ligament, and under the flavon ligament, you can see the big veins, what is the form, and take it very careful, because if you don't take very careful, it's very easy to convert that into disasters, because in this moment, you see it, you find that like a map. It's very common for the neurosurgery know about what talking about this. This is the vein. The normal vein in the chronic problem in the patients and the chronic degenerative problem in the myelopathic. I need to be very careful because it's very close to the medulla. And if you cut or you burn very close to the medulla, maybe you produce a very big lesions because the cordon, the spinothalamic cordon is very close in this part, and the pyramidal problem is more lateral, but it's close too. It's very close to the nerve, and it's necessary taking very careful. In that moment, I can't cut. I need to see first, open the flavon ligament, and in the moment when I see it's free, I can cut. If you don't have the 100% certeza, you know stay close to that vein, please don't do that. That is for the people who stayed here and do it the cervical endoscopic surgery. Is very common. In that moment, the hematoma is imminent, and that fluid of this vein is very high. If you do it with careful state, and you have a time, the surgery is one of the part of the benefits is you need to have a time. You know what time you enter to the surgery, but you don't know what is the finish. And you can see it's very easy. You only close to the veins, put a FRA, and that's it. In any moment, I push my radio frequency in the spinal cordon or dura. Is only close, and with that, resolve the problem. Okay, the most recent article about this is the Dr. Samway. Is the February of the 2023, and he have 18 patients with very good results, and in this paper, no mention never in any patients the necessity of the fixation in the posterior anterior form, because that patients, I say, no is necessary to put screws in posterior cervical bag or produce a cage from the anterior. It's necessary to open a big windows for recover the fluid from the medulla. In these cases, these patients recover the move of the arms, recover the legs, obviously walking with a special with a cane, but you see the patient is autosufficient, and we try to do that, recover the life of the patients. We have right now 32 patients with this age, more men than women, is the more common. But the more important on my presentation is this. The myelopathic cervical process is more common than the home hover work with prosthesis and PCIF. More than the 80% of the myelopathic process are in people very old. But remember, prima non nocere, the quality of the life is better than the beautiful X-ray. The next patient will be you. What do you like to attend for wherever doctor you take into attend? Welcome, Mexico. Thank you very much, Dr. Malcolm.
Thank you, Rodolfo. I think we'll take questions afterwards just to try and limit the turnaround, if that's okay. We're going to have Dr. Ricardo Grau from Madrid come have a presentation on the evolution of endoscopic fusions, which is great. Thanks.
So, good morning, everybody. I want to thank so much Dr. Pestonji, Dr. El Morsi, and all the organization for its invitation. I want to tell history. There's a first thing. The first thing is a name. Is what we want to achieve, which is not blow up the mountain, but just go to the place and solve the problem. That's our aim. And what is our history? Our history is how we did to reach or to achieve that objective. I'm Ricardo Casal. I'm from Spain. We have a surgical group. We're specialized in endoscopic spine surgery. We almost only do endoscopic spine surgery. And here we have how the AO classified the fusion procedures. And as you can see, is a little bit incomplete. And I'm going to try to explain why. I want to show this scheme about indications and techniques. And as you can see here, we have a lot of indications, and the spine endoscopy world grew up a lot the last years, and there's a lot of things that we can do through the endoscopy techniques. In the right side, we find these 3 tools in green. Maybe we could add the biportal because people are beginning in biportal directly. But all these are just tools to achieve some different things. And in the lower part of the iceberg, we see all those more complex techniques that lets us do just amazing things that a few years ago we could not think about it. And finally, the rescue surgery, in which the endoscopy has been really resolutive, really amazing results. Okay, so which is our history? The history I wanted to tell is how we did since 2015 for finally be able to fuse every segment in the lumbar spine, avoiding all the risks and making all the procedures more safer. And as you can see, we have there the EndoTLIF in 2015, which we already heard about today. It's true, EndoTLIF is very intuitive when you do transforaminal endoscopy. You just want to put the cage on that hole, it's very easy. But there's a few things that that you don't have to solve all the problems, because in L5S1, for example, sometimes you don't have plays. The exiting nerve roots sometimes doesn't let you get in with the correct size of the cage. Maybe you have to put a cage that is smaller than necessary, for example. So all these problems we solved by thinking about how to solve it. And when we realized that the L5S1 was a difficult level to go TLIF, we thought about going trans-SAP, because the space between the exiting nerve root and the traversing nerve root, the S1, was the biggest one. So trans-SAP is a very good way to go L5S1. That was what, our second station. But as you can see here, an example of the TLIF, the traditional TLIF, oblique, with a cage that goes into the space, but it doesn't give you anything else. This is an example of an endo TLIF over the wire with a second portal, with direct vision of the cage, how it goes inside. This is really our past now. You can see in the skin the 4 screws and the 2 portals to go endo TLIF. And here, for example, a TLIF in a spondylolisthesis. And the video of 12 hours after the surgery. What we did here, we changed the endo TLIF, adding an interlaminar axis that lets us change the cage completely coronal, because we wanted to change that oblique cage in the transforaminal to something coronal that lets us improve a little bit the lordosis, which is one of the things very criticized of the endoscopic fusion. This is an example of the trans-SAP. Again, is the same thing. We tried to find the wider way to put the necessary cage, and after that turn it to coronal. And well, this is an example of the RX sequence of the trans-SAP. I'm not very good on the time, so I'm gonna skip it. To talk about another solution. The next solution in our history came around 2018 or 2019, because the expandable cages brought something better, something new, to go for that aim. And these expandable cages lets us do a few interesting things. When we go TLIF, maybe we don't need so big foramen, for example, to go TLIF, and we can go 7-9 millimeters to finish in 12 or 14 or even 15. The second thing is that make us able to go endoscopically PLIF. The PLIF is the third station in our history, because lets us improve lordosis with a very, very low risk. And we added this on this way. The first point is to go TLIV, and the third point was to go endoscopically PLIV, as you see there. We are able to put the cages completely sagittal and get rid of the maximum lower doses that the cages lets us achieve. The cages are also improving, so we can go for more degrees on the lower doses every day. This is another example of PLIV. And this is our scars for one level PLIV, for example. You can see there the scars for the screws on each side, the endoscopic portal for decompression and cage, and another scar for the graft taking, because one of the things is that we systematically go endoscopically to the iliac crest and take the bone graft and always put autologous graft, which is an important thing also, I think. This is an intraoperatory image of a two-level PLIV, as you see there. Another example of two cases. Now, in the face of new challenges, there's a few things that are necessary, but one of them is to go beyond and try to find what is necessary to improve the safety of the patient. So I saw in the presentation of TLIV, I saw that in a 3-level TLIV, you was going L2 to L5, and in L2 you decided not to put cage. I saw this case 1 hour ago. Why? I think I know why. Maybe I would do it the same, because the space in L2, L3 is very narrow. Maybe you put the cage and you got an exiting route damaged. That's true. So we tried to keep thinking again, and we thought about going endoscopically completely lateral, and we improved this approach for the lumbar spine, the completely lateral endoscopic approach, and this is what we're talking about. Not tomorrow, the day after tomorrow, on Saturday, I will be here talking about the lateral approach, which gives the last solution for being able to fuse all the lumbar levels with a very, very low risk. And I'll be pleased to talk about it in 2 days. Just to mention that all these endoscopic techniques depends a lot on the planning, on the study of the previous image, study of the Cambin's triangle, which is not a triangle, is too deep, it's very long, it changes from outside, from lateral to medial. All those things have to be studied when you plan those surgery, the study of the canal, of the foramens, and the previous MRI to plan a good procedure for fusion and select the correct technique in each case to decrease the risk for the patients. And well, of course, there are only experts' indications. All these procedures have to be achieved step by step, slow, selecting very good cases, and not taking excessive risks. I'm president of the SECPEC this year, I want to introduce you and invite everybody to come to Spain to see us or to participate in all our events. And that's all. Thank you very much.
My photo. Okay, may I invite Dr. Perez again? Next speaker. Okay. Gustavo Perez. Huh? Okay, please proceed. Okay, the next topic is biportal endoscopic surgery in revision, good options, by Dr. Gustavo Perez from Mexico, right? Okay, please.
Pero si usted es el conductor, usted es el conductor. Pues it's the same, right? Sí, it's the same connector. Just can open and has to go. It's the same connector. It's the same, right? Yeah.
While we're waiting for the setup, is there any questions for the first two speakers, perhaps?
Okay. The answer of that is the normal and the more common is the open surgery. And the difference between anterior and posterior is because in these cases it's specific for the myelopathic problem. And in the myelopathic problem, in the most of the cases, no, it's necessary to do it as anterior surgery. It's a posterior surgery. And in some cases only have an instability because for this reason you do it a dynamic X-ray, CAT scan, and everything. And if you don't have, in the most common is not have, you don't do it a move in that of patients. You only decompress with an endoscopic surgery. It's possible to do it a laminectomy, hemilaminectomy, more of the 3 levels with hemilaminectomy, and that's for the reason of the endoscopic surgery, because it's more safety, it's more easy for this patient because this patient have a hard marker-pass, anticoagulation, and other disease. And if you do it, I don't know, you do a open surgery, you know in the posterior cervical procedures is a little more difficult than the anterior and the lumbar back. And the endoscopic resolve that. It's like a very fat people, and you do it a lumbar discectomy is more easy than the open surgery. In the endoscopic surgery is more easy do it endoscopic than the open surgery, no matter is the myelopathic. No change nothing, change only the complications, and is more easy for and recovery for the patients.
So I have one question. So
The other question.
your questions. How about you adjust the water pressure of and how you adjust the strength of the countering. So water pressure is very important. We afraid about the increase in intracranial pressure.
In my patients, in my experience, I don't do it a bump. I do it only at a gravity, and it's more easy for me to regulation with depends of the beat of the medulla, and I only put a 1.5 meter of the water, and the coagulation is the more low. I never touch the dura madre. Every time I put my radio frequency in the spinal cordon, retire a little, a millimeters, and burn, and that's only I do it. I only have one patient for my. Okay, in my for my fall, I touched the spinal cordon, and the patient have a dysesthesia for a couple of months in the arm, and that is only happen. But this very careful. I see other patients for the other doctors with the bomb, but because continue bomb more than the 50 millimeters of the centimeters of the water, and produce a very big lesions in that patients. For this reason, my recommendation is only for gravity, and it's better to you see the clinical is first. You see the dura madre to bit, than you have a very great visions for you try to put more pressure in the water. I don't know if that is the answer to the question there.
Regarding your question for him, there's an important thing that it is that endoscopy can combine with every other technique. I mean, if you have the endoscopy as a tool, as your tool, you can go anterior and stabilize one level and decompress on posterior. So it's the same thing with the fusion I was talking about. If you go endoscopy, if you go endoscopically, you can combine fusion with decompression, and that's what I used to do. I have a 4 level, and I put 4 cages, and I decompress 3 foramen, for example. There are all combinations that you can't do if you don't have the endoscopy as a tool.
Thank you.
I think that's important. Sorry.
Don't worry. We'll start. Thank you very much. Thank you a lot for the invitation to World Federation and all of the organizers and this amazing Congress, Dr. Malcolm. Thank you very much. And I feel so proud to stay here with all the endoscopy spine masters in the world. And the focus on this lecture has demonstrated how can resolve some cases with previous surgery. As we know, the name of lumbar revision surgery is a lot of issues, and we can focus a little bit. My name is Gustavo Vera from Mexico, and well, really feel so proud to be a part of the World Congress by the Mexican Association for Mid-Portal Spine Surgery founded 1 year ago. Thank you for your support and aggregate to this Congress, Dr. Malcolm. Well, before I start, I want to say whatever MIS technique you use is totally adequate. But we need to know, must try other techniques to really feel comfortable and have real progression of this technique. Maybe these are the unique for to understand all the tools we have in MIS surgery. But in the last few years, I feel really comfortable with the biportal techniques. This is my focus. But I really have some limitations in our tools. I mean, I think the ultimate year we have a less limitation because we do a more techniques, we are most surgeries, and when can progress, we can do more intensive surgeries. Actually, have few papers in the wall about revision surgery, as we know, but 2 years ago doesn't exist anywhere. And this paper to demonstrate more advanced techniques. And these herniation, fusions in revisions, supplementary instrumentation, but by UV. This is the first case can demonstrate. This is a female, 32 years old, radical left pains 10 months ago, do a caudal blocks with 2 months to improve the return the pain. And she's a cycling profession, is so activity, so high, and not have lumbar pain, never have lumbar pain. Remember that, never have lumbar pain, and the X-ray without instability. Like the other procedures in endoscopic surgery, we use a ESP blockade at bump infusor, TIBA TCE by propofol induced with a way patient like ERAS spine protocols. And when this approach is used, is interlaminar left approach, a classic fragmentectomy, probe 360 grade, subligamentary fragments, intradiscal pressure water, and pragma contraction the annulus by RF, like classic UV discectomy. And well, all is okay. The patient have a normal evolution without complications. We can see the MRI with adequate decompression and no lumbar pain. Well, 7 months after the surgery, called me by phone and feel so afraid. When she started in the 6th daily class, because it's high activities, we tell me, I have the same pain before the surgery. When saying anti-inflammatory drugs, but 2 weeks after, but doesn't work. And we see the reason. I take another MRI, and I see the one re-herniation so big, the same label and the same zone, without lumbar pain, but not have pain again, okay? 7 months after the surgery. Well, like all of us, we can think what we do, and remember which are my tools right now, and in this moment have 2 ways. This fusion to condemnate to this active patient to lumbar pain, or do the preservative surgery. And well, I feel that this moment comfortable with my eView tool, clear view and the revision and go again. I prefer do another interlaminar approach for revision. As we know, in the axial view, see 2 things. I see the good virgin windows in the interfacet ipsilateral zone and huge intracanal disc. I prefer do the interlaminar for the revision approach of the patient because it's L5S1 and the fragment is too big in the center of the spine. Well, we start the spinolaminar junction, as we know, start to improve the clear vision with arrive with the 30 degrees on the contralateral side, has a normal, like this, a normal UV technique. The other thing we must do is when rotated 30 degrees is lateral, we can see better out 2 corners. They need to do a new little laminotomy with drill, and when search the native flabum in this corner is enough for drilling. In the same in the ascending facet corner, the other side, under the facet. We need to see native flabum. Is this the key? Just need a little bit with drill to see the native flabum. This is the key. Don't go directly to the medial, to the fibrosis. This is not safe. It's more safe, keep to the bones. Well, after the flavectomy, the more tissues are familiar to us, and the normal view, we can see the shoulder, we can see the axilla, and can with hooks search broken this fibrosis, and the center root can clean it up. When see the complete anatomy of the root, we can, some surgery, can see that with clear view, can divide the dura mater and these fragments, and can this step by step, take this herniation and get out this herniation. Well, we can see the huge fragment get out, and with MRI with a lichohematoma, but the patient without symptoms. Like Dr. Nehar said, the patient happy 2 weeks after the surgery. This is the second case of revision. One male with 60 years with 2 years ago endoscopic descompression. You see the windows is opened in the center and the left side with low improvement after the surgery. When see the patient do a caudal block again, but return in the next 3 months with radicular pain associated to lumbar pain with X-ray instability. Well, in this patient, think it's a fusion because it's an instability, and have a closed both foramen, cannot do a simple descompression. In this patient, think it's a fusion, but can do the other ways to total tools to UV techniques, use a station of the bases on the base of a cambium triangle with the facetectomy, with this extension for do a big gauges. This is the preoperative marking, do interpedicular lines, medial lines, contralateral lines, and do the portal vision 1 centimeter lateral and the portal vision 2 centimeter pedicular line. That is the key maybe in the fusion, because in the UV techniques would have in the same level the portal, when can introduce the camera in all the cages, we put it in the camera. If we can see more medial the view, we can introduce the big cages without smash it with instruments. Well, the first step in this expansive laminectomy to search synaptic flavum again to caudal, and ipsilateral laminofacet zone like this, uses the drill, but I like more use a carry zone, because remember, take some piece of this bone laminotomy for use in the cages for a bone graft, autologous bone graft. The other stills is do the facetectomy by isotome to take more bones and expose all transverse nerves. But in revision fusion, it's better to do all the work close to bones mark. It's so safe again. Don't go do the fibrosis. And the better target when have a lot of fibrosis inserted above is search at the pedicle. Look in this inferior corner. Look in this inferior corner. We look the pedicle. In this side, if the anatomy is not normal, I recommend it to you take an X-ray lateral to see where are the pedicles, and obviously above that the pedicle can enter to intradiscal form, okay? And the other step can work intradiscal space with curette, receive this and hooks, and cut and show all the cleaned platform, the caudal platform and the distal platform, to get better result in the fusion. I think this is the most stronger things the UV fusion have. The work in intradiscal space. We can clean the ipsilateral intradiscal space and can drill, and we can clean the other side intradiscal space to prepare it to receive the cage and bone graft. Well, you can see the insertion of cage, guidance with endoscopic orientation. This This endoscopic orientation due by the surgeries, again and again surgeries. This a TILSA 15 to lateral to put these big cages. And fluoroscopy zone in the few cases, in all the cases you must do and must to use the X-ray. And well, when half the 18% of the cage introduced can do the transverse situation of the cage, you can introduce this biscage or large cage and horizontally to put in the correct form to get a better footprint, okay? Look, this is transoperative vision. When do the surgery, the fusion surgery, the good form to see how it is the localizate the center of the cage, you see this number. If the 30 degrees is orientate the contralateral side, and you say about this view, the center of these numbers of the center of these cages, you stay in all cases in the center of your the spine, in the correct form to get the cage. Don't worry, don't matter if you have little cages, more bigger cages, doesn't matter. This is a result for the adequate decompression patient with huge footprint with these piece cages and screws, and with the same portal, do most extensive this little portal to view portal to introduce the same screw. We use it the same portal to introduce two screws and say we can see the MRI with the complex decompression and the adequate alienation of these patients. For weeks after the surgery, without pain, all the scars, we can see it's a little bit, right? Well, the conclusion, the important endoscopic techniques provide a real-time magnification images of the surgical field through the endoscope. Only a limited surgical dissection can provide sufficient surgical field to perform meticulous lumbar discectomy, as we know. Delicate and gelatin handle of the neural structure in the surgery could also decrease the risk of over-manipulation by forceful retection for visualization through the scar tissue and very narrow surgical fields in revision surgery. Lumbar discectomy by UBE includes the short operating time, low estimated bleeding loss, short length of hospital stay, immediate reduction in axial back pain and leg pain after the surgery, and high patient satisfaction. We believe the BEs or UBE techniques could be a viable alternative to recurrent to herniation disc, the conventional open surgery or the fusion surgery, because it's preservative surgery. Revision surgery in the spine with the portal endoscopy would absolutely feel more comfortable to identify scar tissue and blood control. Thank you very much for your attention.
Okay, next speaker is Dr. Antonio Estrella from Mexico. He's gonna talk about UBE initial training. Okay, question first.
For your first case, I realized that the patient has L5-S1 disc herniation, broad-based disc herniation, and I wonder if the L5-S1 disc herniation is broad-based. It is a candidate for recurrence, right?
Yeah.
So, do you inform the patient that it will recurrence before the endoscopic surgery?
Yeah. Yeah. In all the patients, I inform, and that is the reason I put the activities of the patient, because as we know, the younger patients, the activities of the high activities in the patient can augment the percentage of these recurrent discs. Yeah, the patient know that.
This is, yeah, when do you do sclerofixation if the patient has recurrence disc herniation?
Why not?
When do you do sclerofixation? A second recurrence or third recurrence? Which time do you recommend to the patient?
Well, in the beginner, when they do these surgeries, when they open a microdiscectomy, when have the recurrence, always do a fusion. But I put the real case because in a younger patient, always had enough lumbar pain. And this herniation can fusion in the second surgery, have insatisfied for the surgery because has no pain, have a lumbar pain, but they patient don't have radicular pain, but have a lot of lumbar pain. And they patient have a insatisfied for the surgery. And the ultimate years, I try to be preservative of the patients, especially in the young patients, because feel more comfortable. And as we know, these UV techniques or micro descompression or monoportal techniques, as we know, is not instability technique. And as we know, if the patient previous have a surgery and do another surgery, they cannot do instability. In the most patients, in some patients, and I say the patient, this is the second surgery. Can I try without fusion? Because the most probably if you have the lumbar pains in all your life. But in all the patients say them, you have another percent to have to second herniation or lumbar instability for this preservative surgery. And all the patients know they can receive the fusion in the second surgery. That's it. That is my kind to resolve these cases, especially the young patients.
Thank you.
Thanks. We're quite pressed for time, so if we can maybe get the next speaker on, if you don't mind. I'd like to just urge all speakers to try and keep to their time slots, then it allows for more questions afterwards.
Good afternoon. Good afternoon to attendees to this fifth World Congress of Endoscopy. I'm very glad to be here and I'm very honored to be here in Mumbai, India. To get to know one of the core cultures of humankind is a unique experience for me. And well, thank you for all the organizers here. My name is Dr. Antonio Vallejo Estrella. I come from Mexico. And I have no conflict of interest, and I appreciate the opportunity to share the UVE initial training topic that I'm going to talk about. So as we know, UVE, unilateral bipolar endoscopic surgery, or UVES, is a technique that has been evolved in the recent years. The objective of this thing is to get to know and return to the basics. We have already some of the masters of UVE. These are some books and editions of these books that guide the beginner to get to know the general view of this world of UVE. So we will discuss the main the basics of UVE and also the process to get the first cases of these things. So the nomenclature is very clear. It comes from endo, which means inside, and scopia, which means exploration. It implies the use of a coaxial lens, which usually contains image transmission, illumination, and also a working portal. In the case of UBS, we use two portals, and it is a water-based continuous irrigation technique. So in this case, a brief historic context, we know that in 1998, Dr. D'Antoni first introduced the biportal endoscopic approach. He performed an epidural endoscopic discectomy, and he also stated in his article the first substantial changes appeared in 1975 with Dr. Hikata with the percutaneous nucleotomy. Also in 1985, Dr. Schreiber added discoscopy, and later Dr. Cambi also approached through the foramen. So currently biportal endoscopic surgeries are performed from the cervical to the lumbosacral region. And the review of all great doctors who have developed this technique, it's a very broad topic, so which is outside of the subject of this presentation. Having said that, in Mexico, the development of the technique is a must. We acknowledge in this, we have experts in our country, but not a widespread understanding for the rest of us, the beginners. So in 2023, the Mexican Association of Biportal Endoscopic Spine Surgery was created. And in this year, we started with an international UBE Congress and also an intensive workshop. And this can be one of the UBE initial steps, getting involved by a Congress like this one, workshop or a clinical rotation with an expert in endoscopic, and acquire the concept. It is a minimally invasive. You need the two portals or two working channels, one for the arthroscope, the other one for all the equipment. And it is a procedure performed under continuous irrigation and assuring also the gentle drainage. You have to be familiarized with the equipment, the materials, scalpel dilators, arthroscope, radiofrequency, Carrison drills, and all the different lenses, and also in some cases the infusion pump. No? The values we used, we already mentioned them. When you use work under natural gravity, we used from the floor. We place the bags to 160 to 170 centimeters, or taking the patient 70 to 60 centimeters, or infusion pumps, we use usually 25 to 30 millimeters. So now that we have the concept, we need to get very clear about the approaches. We could say that these are the basic approaches: the ipsilateral interlaminar approach, the inclinatory approach, the contralateral sublaminar, and also the bipolar paraspinal approach. In this case, the ipsilateral interlaminar, I like this article. It has mainly the view and the inclination of all the area you can treat with this approach. And the contralateral gives you a little more inclination. Also, the ipsilateral can do this by an over-the-top decompression. And in the case of the paraspinal approach, would be more like a transforaminal approach. You can access direct to the foramen. And in the inclinatory approach, in the UBE, it allows you to have very good manage of the contralateral, mainly right side pathology, avoiding the switching of the place of the surgeon. And this would be an example, and having this inclinatory trajectory to all these approaches can be practiced on anatomy models or in workshops. And so the first cases in UBE initial training, we usually use approaches simple, ipsilateral, interlaminar approach, and you are searching for the pathology that is at your level of confidence, and also be guided by somebody that is an expert. Like in this case, the choice of first cases can be yellow ligament hypertrophy, posterolateral disc herniation, lateral recess stenosis, pathology for the left side, and also some of the pathology that could need over-the-top resection. So what is the objective of this first stage? Decompression. You are not thinking about stabilization, and because you are in the process of very safe technique, so you have to develop it like it is. So the patient position is in a prone position. We usually use a Wilson frame, which allows us to open that interlaminar spaces. We check with the X-ray and to mark the midline, the mid-pedicle line, the intervertebral space. So once we have that, we mark the skin incisions 1 centimeter above, 1 centimeter below. So we accomplish the triangulation, and we confirm that in a lateral view. Asepsia is done, and later a U-shaped drape is placed with mainly this disposition of the operating room. So once we have this, also we were looking for, or we're searching for the lower lumbar spaces, because we have a wider window in this case with L4, L5, maybe. And progressively, we will start with re-interventions in this case. So now I'm going to show a video in which the main focus is on the dissection of the muscles, and also to accomplish the decompression of this. So in this case, this is the final view that we are looking for: the discompression of the intervertebral disc, the freeing of the ipsilateral root, and also the dural sac and contralateral view by over-the-top resection of the yellow ligament. So we have all the components that we are looking for. So for conclusions, the unilateral bipolar endoscopic technique for spine surgery requires initial knowledge of surgical anatomy. It's the basic. Open surgery and microscopic surgery are cornerstones to start performing this technique. If you don't have any experience in the rest of this, you cannot achieve more advanced techniques if you don't have a very good knowledge and experience in open surgery. Endoscopic surgery requires the continuous flow of the saline solution, and the basic principles also applies to this surgical and radiology guidance. Hemostasis, which is, I think, the first stage in any technique. So in this case, it's the same: hemostasis with radiofrequency, hemostasis, and pay attention to the solution, and the careful dissection of the tissue and bone dissection. So the choice of the cases must be progressive, from simple decompressions and later more complex cases. Thank you very much.
Muchas gracias. Muy bien. We're going to move on to the next session. Are we going to go for lunch? Yeah. Okay, great. Thank you.
Select.
to unmute. Yes.
Do you hear me from the screen?
Yes, you have to share it.
But the meeting owner didn't permit me.
Done, sir.
He didn't want me to share screen.
All participants. So you share your screen, sir, and start with your talk.
Shall I do screen sharing?
Yes,
Yes,
sir.
I am doing it. Okay. Okay. Just a moment. Yes, we are doing screen sharing just now. It is green. Hello? 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 Do you... güzel. Muscle and pain generation. It is written. Is it? Okay.
Have you? You can start.
Hello?
Hello?
Hello? Do you hear me? I hear you.
Please go ahead.
Dr. Sameh.
Yeah, Dr. Tariq, how are you?
Nice to see
I
you.
hear you clearly. Start.
Nice to see you, dear friend.
Thank you.
Are we alone or the people? Shall I start? Hello?
Yes, please.
Yes. Muscle and pain generation. It's an interesting topic, but very important, of course. Unfortunately, we have some people post-operatively UB operation, they are not happy, maybe 15 to 20%. But the UB technique is not the problem coming from the UB technique. Technique is perfect, but preoperatively, this period, preoperative period preparations are not good enough. For example, Dr. Norman Marcus, a clinician who is dedicated his career a big study of the muscle pain generation. Soft tissue includes ligaments, fascia, capsule, muscle, tendon. Unfortunately, soft tissue representatives are important pain generators. Muscle constitute approximately 40% of the body weight and are thought to be an important cause of non-specific low back pain. 85 of these patients presenting with non-radiating back pain. Muscle is an important primary source or producer of back pain. Careful preparative evolution for muscle-generated pain is crucial in avoiding failed back spine surgery. Oh. And here we can see a somatic nerve, and we can see the musculoskeletal muscles, and we are able to control these nerves, and let's go on. And muscle can be independent source of pain in patients with degenerative spinal disease. Understanding the pathophysiological mechanism of muscles enhance the capacity of the surgeon to identify the existing complicating post-surgical source of pain. The pictures small, I have small pictures here, and they are okay. The understanding the pathophysiological mechanism of muscle pain will enhance the capacity of the surgeon to identify muscles as a pre-existing or complicating post-surgical source of pain. Physical therapy and healthy exercise are key to treating the muscle-generated low back pain. Even the less invasive MIS procedure may be compromised by muscle-generated pain, especially if it was present before surgery. Here, Dr. Sameh, it's technically something wrong. Education patients about the muscle-generated pain can help to reassuring them concerning postoperative discomfort. An interdisciplinary approach consisting of pain management, psychiatry, physical therapy, and when indicated, psychiatry improves the ability to diagnose and treat muscle-generated pain, ideally before considering surgery and when it occurs after an otherwise successful MIS procedure. For example, here we can see the body muscles, three types muscles we have. In the middle, we can see the skeletal muscles, and we can control the skeletal muscles. Of course, its somatic nerves they work with our voluntary. Here we see the contraction and relaxation. This is the skeletal muscle. This is myosin. This is actin. And calcium ion is very important at this stage. With calcium ions, on the myosin, they are happening something in nanotechnologic action. And with calcium ion, ATP changing ADP, and some energy is free now. And the actin is sliding, actin and myosin slide over each other, and contraction and relaxation occur in the muscle. So we have 600 skeletal muscle in this topic. Clinical this is nerve, this is synapse, and Dr. Sameh. Kraus-Weber test is a measurement and treatment technique. It's quite useful preoperatively. We may distinguish the problem. Does it coming from the muscles or the neurologic system? So in statistical manner, 54% radicular problems we have, and 22% mechanic, 9% myogenic, and 11% discogenic problems. And there are a very large more than 25 very good reference, but in the preoperative period we have to do very deeply investigation for the muscles. And excuse me, this is very wrong presentation. I'm so sorry. And if I get a chance, I will correct the presentation. Technical problems I had, excuse me, and many thanks for your kind attention. I will give it stop here.
Thank you, Dr. Tak, for this nice presentation. I'd like to welcome you all to the first day. This is session 8, and I am Dr. Sam Hamousi from Egypt, the president of World Federation of Spine Endoscopy, and the man who is responsible for the international accreditation for all these courses during past years. I'd like to welcome my co-chairs, Dr. Bao from Taiwan. He is an eminent spine endoscopist and a close friend too. And Dr. Sambusha Thank you for joining us. And now we will shift to next speaker, Dr. Adam. Dr. Adam, are you there?
Many thanks. I'm so sorry. Technical problems. It
Okay,
was too
okay,
bad. I'm so sorry.
Dr. Adam, do you hear us? Yes, yes. Is he? Is he? I know. Is it recorded? Okay. I know.
Shall I
Please
go
unmute
out?
yourself, Adam. Thank you, Dr. Tag. Unmute yourself.
MIS endoscopic spine surgery at Holy Spirit, Mumbai, India. This is my country. I lived in Indonesia, in Yogyakarta, 600 kilometers east from Jakarta and 600 kilometers west from Bali. And this is Bali. You can see this is my hospital. The advantages of a endoscopic spine surgery, there is a good visualization, clean water irrigation, and less damage muscle, less infection. We avoid fusion surgery. And for the local anesthesia, we can perform erectospinal block, with caudal epidural anesthesia. And this is the ESP procedure before the surgery. We put the ESP and we combine with caudal epidural catheter because we try to take 10-minute post-surgery. We try to make the patient walk after the surgery. And there is a technique, the endoscopic PSLD and UBE. The principle is almost same. The difference is in UBE, we perform with 2 portals, so we have to meet the triangulation. The 51-year-old man presented with foraminal stenosis at the leftist side here, you can see, and the dermatome L5 root symptoms, not the better with conservative. And this is the instrument, this is the patient preparation, and this is the marking. The marking is the lateral from the transversus process of the L5, and we make a 1 centimeter incision to the right or the left, 1.5 centimeter. It's up to you, but the target is to form the isthmus or the transverse process. We try to make a triangulation directly there. There's approach is we have to see the root and we take the disc bulging and we clear from the TP transfer process. We drill this and take the lumbosacral ligament and we visualize the nerve. We take out the SAP here, and this is the picture. And as you can see here, we directly find the SAP, or we can target the isthmus. We land in the transfer process and we drill the transfer process here like this with a reverse method. And after that, after we visualize the SAP, we take out the SAP with scissors. We grasp the scissors. We take out the ligamentum flavum here. Be careful not to destroy all the SAP. This is the principle. And then you take the grasper to take the SAP tip with the grasper, upright grasper. And we can also take out the ligamentum flavum with the garrison very slowly. Please try not to injure the exiting nerve root. If there is a bleeding, we can coagulate with the RF probe, and it will be very, very cautious in doing this because the area is very, very bleeding is going to likely. And after the decompression, we final check, we check the nerve and the nerve pulsate, you can see here, and we use L probe to make sure there is enough space. And also if there is adhesion of the soft tissue, you have to clear everything and try to mobilize the exiting nerve root. And this is the MRI post-op. You can see this is totally free. And for uniportal, the same method, but the different approach. The difference between transforaminal is the transforaminal more lateral, the para-PSLD is more posterior. And this is the patient, this is the para-PSLD case. The landmark is 5 to 7 centimeters from the midline. We can check the lateral C-arm only, tuck in the foramen. And we can see here, we clear everything here. We take out the vicarition, the grasper, the soft tissue, the fat. Please try not to injure the exiting nerve root. And then we ablate, calculate everything. And after we meet the ligamentum flavum, we can use the carison here to take out the carison. For this, we can ablate everything and we clear. And you can see we clear everything until the exiting root is clear. If there is a space that is very blocked by the hard tissue, you can use drilling. Here in PSLD, you cannot use the chisel, so you rely on the drill and the carison. So if you want to learn uniportal or UPE, it's according to you. If you're good in one hand, or you're a neurosurgeon, maybe you prefer doing uniportal. If you're an orthopedic surgeon, maybe you get used with arthroscope, with doing with biportal or two hand. It's up to you. But in my opinion, all the surgery have advantage and disadvantage. After clearing the root everything, we have to perform the final check. And sometimes you need to do slightly discectomy. You just ablate or take with a grasper here, or you can use carison to take the disc to make the space more for exiting nerve root. This is a L5, as you can see. The principle is taking the foramen, clearing this, make the water pass very, very clear. And there is the stone near here is the foramen area, the bony, we can drill here everything. And the plantation here is the ligamentum flavum. As simple as that. And this is the MRI post-operative, very good. There's a meta-analysis from China that the result is not different. It's same between UPE and PSLD, but the uniportal has a lower operation time because it's straightforward approach, and that's all. The hospitals say same. The other is almost same. And according to your steep learning curve, or you want to have easier, or which one is easier for you, or the instrument they available in the hospital, it determine which one of the approach which is better. Thank you for your teaching, all my teacher. I'm going to give applause to all my teacher. If I have seen further than others, it is by standing upon the shoulder of the giant. Thank you, Dr. Malcolm Pestonji. Thank you, Dr. Lim. Thank you, Dr. Pau. Thank you, Dr. Gore, Maxim, and also Bu Pangpung, my friend. See you again next time. Thank you.
Okay, thank you for your attention. I'm sorry I cannot attend to India because of family business.
Any question? Any question for Dr. Adam? Yeah, then we'll go to the next topics. The topics will be the scoring system of predictive factors for non-favorable outcomes in transforaminal percutaneous endoscopic lumpectomy by Dr. Sakti. Dr. Sakti, also online? Sakti. Did you find your luggages? Not yet. He just lost all of his luggages.
Not yet? Okay. First of all, I'd like to congratulate all of my seniors. Professor Dr. Malcolm Pestonji, thank you very much for the invitations. I'm Yuda. Dr. Prau, thank you for the quick introduction. I just lost my luggage, so apologize my supposedly inappropriate attire. So despite that, it's really nice to come here again to India. I'm Yuda from Indonesia. So I think all of us here know that endoscopy is a game changer surgery. I'm brought up as an open surgeon, so I've been doing the endoscopic, started with transforaminal, but now doing a little bit of everything because the indication is expanding. However, because I'm from a university hospital, we're trying to create a scoring system in which, because there are some non-favorable outcomes following our transforaminal endoscopic surgery. So I'd like to know more on that. So I will be quick about the background, the research, and hopefully the conclusion. So this is one of the things that are really interested when doing transforaminal awake and aware. You can do it. The patient still conscious. You can ask the patient, is it getting better? Do you take the right amount of this? Do you put your docking in a good position? However, sometimes the result is not that favorable. That's why we tend to choose whether interlaminar, transforaminal, do UV now, you don't fuse it, not fuse it, put instrument or not. However, we are strictly evaluating the TPELD cases only, in which what kind of a parameter that creates non-favorable outcomes. Despite that, it's really nice surgery. I think everybody here agree on that. And then as a background, just going to quick on that, early surgery, fast, quick in, quick out, less than, not more than 2 days usually. And then a lot of good things doing endoscopic transforaminally. However, there are anatomical changes in which these anatomical changes might be related with those unfavorable outcomes. For example, if the patient have a degenerative changes, you have bigger facet. If you do transforaminal only, will it give favorable outcomes? Sometimes it creates changes. Big size patients, large facet joints, or usually if we do people doing transforaminally, you tend to dock your instrument anterior than 1/3 of the posterior annulus. Then your decompression may be not as good as it should be. Then maybe it creates a parameter for non-favorable outcomes. Those becomes our background. So just to see, just a lot of previous studies said about the endoscopic benefit zone, in which sometimes maybe doing it not to extend it, then thinking about open surgery, it's something that we need to be more wise if we see patients about this condition. That's also one of the background. Maybe there are cases or there are parameters that may lead to non-favorable outcomes in doing transforaminal surgery. So with this in my mind, there are gray zones in which, or dilemma in which endoscopics may need to be considered. Body mass index, more than one level endoscopy, that's shown by previous studies that there are factors that can create unfavorable condition following transforaminal surgery. However, there are not yet scoring system that's being proposed to these non-favorable outcomes. So that's where our research is. So this is the, there are no consensus tools available. The research question is, can we identify factors that leads to non-favorable outcomes? And then is it possible to create some kind of a scoring system? And this is the conceptual parameter, patients having lumbar disc herniation, and then evaluate the predictive factors, and we analyze those factors. Which factors tend to lead to non-favorable outcomes following transforaminal lumbar endoscopic discectomy? This is a hypothesis. This is a material method. So early study. So this is the research. What creates as, what poses as non-favorable is those patients with VAS score more than 50%. So if the VAS score less than 50%, we call it a favorable outcome. With increasing ODI, we call it non-favorable. So if we see this, I think most of us agree. Older patients, difficult anatomy, maybe not favorable outcome. Gender, maybe non-favorable outcome comparing female and male. BMI,
bigger patients, maybe less. That's what we are identifying in our samples, and we try to analyze this. Tobacco consumption, the big, how big is it, and then the location, is it central, transforaminal? A lot of studies saying if it is paracentral, foraminal, leg pain, better outcome. So we will see on that. That's what the, and then also history of spinal injections. Okay, this is the, I will skip with this. We do bivariate analysis in which after multivariate analysis, these four parameters comes up more, showing that it is showing less favorable outcomes in compared to the other group, in which patient with spinal injection, previous spinal injection, bigger patients, more than one level condition, and gender. So if we see those factors after the bivariate and multivariate analysis, all of those being excluded, it leaves 4 of these factors that leads more or less creating non-favorable outcomes. So is it the same with what the previous study said? BMI, a lot of studies showing the BMI creating overload, more problem in the disc, fissure in the intradiscal pressure creating more pain, maybe not as favorable if compared to the non-big patients. Gender, previous study already showed that older age, female gender, tend to be due to social and psychological factor, not to be gender discrepancy here, but the study showed that, like if you have female patients with multiple other conditions, maybe tend to have less favorable outcome. Multiple levels, I think we all agree on this, and the history of spinal injections. So what our study has shown us, our research shown that this spinal injections tend to be, if we see the number of the coefficient is bigger in spinal injections, in which we can, in a way, create scoring if we divide them with the standard of error. So the constanta is B, and the standard of error is SE. If we divide that, we kind of have a scoring. So this 4 condition, if you have all of this, most likely it tends to have non-favorable outcomes. But we have to check that, right? So we check that. So if we check that, if the patient, we go to the gray box in the right-hand corner there. If the patient have 5 score, so 1, 1, 1, 2, maximum is 5, 99% of the patient will have non-favorable outcome, at least in our group of samples. If it's only 1, only 4% have non-favorable outcomes. And that goes with the table in the right hand. So maybe this could be a starting point to see if I have patient with these parameters in hand, maybe we should think of possibility of better education, thinking of other surgeries by means of maybe you will have non-favorable outcomes. This is, we backtrack the research and evaluate that. Then we have this number in the yellow part is non-favorable outcome, in which if the patients more than 4 or 4 have these parameters, then 96% of our cases leads to non-favorable outcomes. So as a conclusion, will this stay as a predictive vectors? Still we are still increasing the number of our studies, only 1 year evaluation, 2-year evaluation. So we are pushing the numbers, and hopefully there will be a reliable scoring system. Although I think it depends on our hand case-by-case evaluation in which what kind of technique we'll choose. But at least we have the idea that there are conditions that may lead to non-favorable outcomes following transforaminal endoscopic lumbar discectomy. I think that's it. This is my reference, and I also come with together with Dr. Adam. So I'm come from Yogyakarta. We have a meeting in August. So thank you very much for the opportunity. I close this. Thank you very much.
Thank you, Dr. Yuda. Can we just have you for a moment? I have one question. So you took BMI, gender, multi-level, and history of injections as
Yeah.
unfavorable. But I believe that if I take these 4 and do any kind of surgery, if it is a MED, open surgery,
Yeah.
fusion, I think even in those surgeries, I might get an unfavorable outcome. Because the characteristics which you have mentioned to us probably will give us poor outcomes in any kind of a spine surgery, most likely. So
very good.
have you compared, like say for the same pathology, if you do an interlaminar or if you do a UB or if you do an open surgery,
Yeah.
are they having better outcomes as compared to transforaminal?
It's very, very good observation, sir. So this is to say challenging patients, a group of challenging patients. If you transfer this in any kind of surgeries, maybe you will not have a good favorable outcomes. However, the scoring, that's what we are trying to underline. Do we need in some kind of a scoring mechanism in this factors in which are contributes more of the non-favorable conditions?
So I can use this scoring even for other surgery as well, as a general rule, I'm saying.
Yeah, yeah.
If I use this scoring, probably even if I'm doing a fusion surgery, MIS, TLIF, I would still probably, could be a predictable outcome that it may be unfavorable to explain to the patient. So not necessarily that it can be worked only for a transforaminal surgery.
Yeah, thank you very much. So it will be challenged. Unfortunately, we don't compare those groups. So actually, it comes from a condition in which we would like to ask, how come this kind of patient usually, at least in our TPLD case, we don't have this condition in we don't really look at this condition in our other techniques. But if to compare that, I think it will be much more interesting then. Thank
And
you.
just last one more question. That suppose you get a patient with unfavorable thing. So what do you offer them then?
Core surgery.
But
Because indication will not change with the scoring. Indication will not change with the scoring. Indication will be based on our patient's evaluation. Yeah.
But even if it's a 99% chance of unfavorable outcome, would you still proceed with it? So this is just more of guiding the patient with regards to what their outcomes could be.
That's why I'm in my closing statements. It's the important thing is about the education. By knowing this, you have high chance of possibly of doing. Although I think I need to evaluate more on these factors why it creates problem to those group of patients.
Thank you. Thank you.
Thank you very much. Yeah, that's yeah. You will do thank you very much, sir, for the question. You will still do surgeries because surgeries is not based on the prediction of the less favorable condition, because you're doing surgery because of the indication in the patient.
So what is the purpose of this
no,
scoring?
no.
What is the purpose of the scoring? If you are not going to follow the scoring in treatment of the patient or advising the surgery or no surgery, so what is the purpose?
Okay, that's a good question. So it's not means that we go back to our group of unfavorable outcomes. Of our group of unfavorable outcomes is those ODI more than 22 and the VAS decrease less than 50%. So that's one of the groups of the condition in which it may be associated with the techniques of TPLD. I mean like that. So supposedly we have those 99% possibility in our group of patients will be failed or non-favorable in TPLD. I will choose other type of surgery like that. I mean, maybe the position, the docking is not good, and the location multiple. I cannot do multi-level surgery in this case. Don't push myself to do TPLD. I will choose other type of surgery.
Yes, yeah, very interesting discussion. I have only one comment, very short comment. I think you should incorporate the surgeon's factor into your scoring system, because an experienced surgeon and a novice surgeon, the result may be totally different.
Of course. Yeah.
Thank you for your
Thank
talk.
you very much.
Now we have talk by Dr. Sigim Mumku. I hope I'm getting the pronunciation right. From Turkey. She'll be talking on biportal endoscopic spine surgery, pitfalls and early learning curve.
Dear Chairman and dear colleagues, first of all, I would like to thank Dr. Pestonji and his team and all the committee for organizing this great meeting and also for their kind invitation. I'm Dr. Çiğdem Mumcu from Turkey. Today I will present biportal endoscopic spine surgery, its pitfalls and early learning curve. And the advantages of UBE is unnecessary to expensive, fragile, and spatial toolkit. You can use two portals in all directions, and you can use endoscopic trajectory, same as microsurgical trajectory, and you can use this procedure in a wide range of cases of spinal disorders. And in UBE, one of main principle is triangulation. We have two ports, one for input, one for output. With this way, you can adjust fluid irrigation and you can create working space. In early learning curve, it is better to start with training and cadaver courses and then start with simple disc herniations, especially in cases with left-sided disc herniation, using a 0-degree endoscope in early cases. Basically, we have two different approaches, paramedian and paravertebral. In paramedian approach, our second incision is in medial pedicular line, and you have two holes here. Then you can arrange two incisions. The distance between two incisions should be 2 centimeters or 3 centimeters. However, for paravertebral approach, the incision is almost 1 centimeter lateral aspect of the vertebral body. The most important thing in UBE is creation of working space. For this aim, you need to focus on multifidus muscles. Over lamina and below the multifidus muscles, we have gap, which is called multifidus triangle. You need to work in this area. You can see here triangulation, position of the ports of these cases should be confirmed under fluoroscopy. The distance between two incisions, skin incisions is very important. It should be almost 2 or 3 centimeters. The middle one in this slide is a perfect case, but if they are very close to each other, there is a risky of the fight between instrument and scope. And if the distance longer, instruments cannot be seen. Of course, before surgery, you need to training period is better to increase hand and eye coordination. Therefore, I recommend to use joysticks. Something like that can use computer games. It contributes hand and eye coordination your surgery. We can see here placement of endoscopic and working portals. Taking the left approach as an example, the endoscopic portal is located on the cranial side and the working portal on the caudal side for right-handed surgeon. The triangle is addressed to the spinolaminar junction for paramedian approach and to the laminofacet junction for paraspinal approach. Identification through the endoscope of the spinolaminar and laminofacet junction is critical for starting with bony drilling. Water circulation is also most important aspect of UBE surgery. So the outflow fluid is very important. This should be balanced very carefully. Therefore, you need to keep the hydrostatic pressure at 30 to 50 millimeter mercury. You can see here clear surgical view after placement of the portals is very important to get a hemostasis. Then you can verify ligament, muscles, and bony structures. I would like to show you other aspects using endoscopic videos. You can see here the use of RF in order to clean surgical area from the soft tissues. Here, after cleaning, you can start laminectomy from the spinolaminar junction using drill and Kerrison punch. However, during laminectomy, it is necessary to be very careful to keep the drill in the endoscopic view center continuously. The bone drilling should be completed before removing the ligamentum flavum during the surgery. You can see here we always keep the drill in the endoscopic view center. It is important. You can see here ligamentum flavum is carefully dissected and removed in the lateral aspect of the canal. For discectomy alone, we preserve ligamentum flavum as much as possible. After removal of the ligamentum flavum, you can retract dura or nerve root. Then that you can remove the herniated disc. This may increase the bleeding amount. Therefore, this point is very important to use radiofrequency for hemostasis. But very carefully not to injure to neural structures. There are some complications, especially in the early learning curve. We can see nerve root injury, dural injury, incomplete decompression, hematoma, infection, and also sometimes intra-abdominal massive collection can be seen, but very rare, and also it is mostly mortal. Increased intracranial pressure may lead to headache, neck pain, and sometimes visual loss. In summary, UBE is a safe and innovative technique under the clear and wide endoscopic view for spine disorders. Training and cadaver courses are the most important aspect of this procedure. In the first cases, appropriate case selection is very important. For beginner, making working space, fluid balance in inflow and outflow, control of epidural bleeding are very important. Successful bony drilling may be challenging and it may require more times. Thank you for your attention.
Thank you, Shidam, for this valuable, nice presentation. Is there any question? Okay.
Very nice demonstration you have shown. I just want to learn from you. I am one person who started with a simple laminectomies in 1986. I'm an old timer. And now I have started learning this also. What are the indications? Which are the cases where you will never do endoscopic surgery? Or you will say, no, don't do endoscopic. What I'm seeing, every case is being done endoscopically here. What is your teaching? Don't do endoscopy in such cases, you can be in trouble. What is your indication? Thank you.
For me, if there is some, there is intradural pathology, tumor also intradural, sometimes disc herniation. That's never, I never do endoscopically.
I'm seeing a lot of presentation being done for intradural tumors. I'm a neurosurgeon, so we don't advocate
I'm
endoscopic
too.
surgery and intradural surgery, intradural pathology. But I see a lot of people are doing and showing their good results and claiming good results. I'm not talking about, I'm talking about degenerative spines mainly.
Degenerative.
Yeah.
Actually, in my opinion, we can do every degenerative disease operate endoscopically.
All levels?
It is possible. Yes, all levels. Why not?
So there is no contraindication for that, you mean to say?
Maybe difficult, upper level or thoracal spine, cervical spine may be difficult, but it is possible. It's not possible to do. It's possible to operate every degenerative disease in spine.
Yeah. If there are patient is coming with multiple levels, still you feel that we should do only endoscopy and no other approaches?
First, I recommend by endoscopically, but the patient choose which one, which one wants. I mean, I recommend endoscopically to operate, but if patient doesn't want, because sometimes, you know what, we can explain the patient all risky, you know, maybe recurrence, higher risk of recurrence, or maybe instability, because if we do multiple levels, it is a higher risk to instability. And my opinion, I tell everything to my patient and then decide together. If they want to operate endoscopically, I can do. But if doesn't accept too risky, I don't do that. So
yes, I think, yeah.
Basically, I'm going to try to help you.
Yes. Okay.
Endoscope is a tool. Whatever we are able to do with open surgery, we will be able to do with endoscope. This is basic. Whether it is 0 degree, 30 degree, doesn't matter. In UV, we are using fluid medium. So in intradural tumors, it will be very difficult because that irrigating fluid may cause problem. But with dry endoscopy, we will be able to do intradural tumors, intradural extramedullary. The only contraindication as a neurosurgeon is the intramedullary tumor, because there fine dissection is necessary. So everything is possible. Endoscope is a tool for illumination, magnification, and to reach the narrow corridors. Other contraindication may be anterior cervical, where you don't have a cavity. When you try to create a cavity, you might damage the important structures. That might be a relative contraindications. So use endoscope as a tool. Don't say, and we are not compromising with any goal. Whatever we are achieving the goal with open surgery, we are achieving the same thing. That's why I call it as a endoscopic spine surgery, not MISS. It is not minimally invasive at all. We do all maximum, whatever possible at site of the pathology, but still we call it as MISS.
Thank you, Shidam, for this nice
I think we should call it endoscopic assisted surgery, which is very important. Yes, agreed. Patient wants that way, what we call minimal invasive. But there has to be somewhere where you can't do the endoscopic surgery.
Okay, thank you, Shidam, for this nice presentation. And for this discussion. Now we will shift to next speaker, Dr. Pradeep Singh. Pradeep, see?
Presentation.
Me opportunity on speaking on this pain generator in lumbar disc disease, which is actually relevant here in this meeting to speak on, because all we are aiming at the pain management here to understand. So we need to understand the basic pathophysiology and the bare minimum surgical anatomy to understand the pain generator. So if you see, the disc is basically nucleus pulposus, which is made up of proteoglycans, and which eventually, because of mechanical stress, inflammatory or so, there breakage of proteoglycans, which would lead to small particles, and that would lead to dehydration of the disc. And this would start the pathology here in the disc, which start pressing over the inner layer of the annulus fibrosus, which would lead to the back pain here. Without any evidently MRI finding, the patient would start having back pain here, and the MRI would still show normal findings. Eventually, what would happen? The disc, herniated disc, would start giving pressure to the annulus fibrosus, and here it would release some pro-inflammatory markers like cytokines and all, and this would start hitting the pre-neural ending there in the annulus fibrosus, this ligament. And here the pain would typically be there in the back as well as the gluteal region, and it might radiate down to the proximal part of the thigh, and sometimes because of the chemical irritation of the radicular any nerve, the pain might go down up till the calf or the foot. And this is, we call it, inflammatory pain, where the pain is all because of pro-inflammatory markers, cytokines and everything, and the annular tear basically. Tear is basically term reserved for the traumatic thing. Annular fissure is the correct term. So this is inflammatory pain. Eventually, the disc would start piercing the annular fibrosis, and it would come out of the this thing and enter into canal and start pressing the radicular nerve, and here the pain would be neurogenic pain, which is all because of mechanical pressure over the nerve. Could be chemical irritation of the nerve, and there could be vascular reason also. The vascular insufficiency of the nerve would lead to neurogenic pain, which is typically radiating pain below the knee, which is classical sciatica. And here, the structural changes there in the disc would lead to the physical insufficiency, the physical property of the disc would be lost. So the load would be transferred to the posterior column, then anterior column, so there would be increased loading of the facet joint, and this is now mechanical pain, which would lead to the facetal arthropathy. And there would be secondary hypertrophy of the ligamentous flavum, which would lead to the lumbar canal, secondary lumbar canal stenosis because of the disc and the hypertrophied ligamentum flavum, hypertrophied flavum sometimes. And the superior-inferior height of the disc would increase, which would lead SAP to go further up and would start pressing the exiting nerve root here. And this would, the combination of back pain and typically radicular pain would be there here. Why this is important? Because we need to deal with the back pain by fusing or the treating the whatever protruded disc and the radicular pain also. If you're treating with the block or some semi-conservative modality. Eventually, there would be uh, secondary to arthritis, there could be spondylolisthesis and other changes in the spine. This all would come under mechanical. So we can divide the pain into three categories: the mechanical pain, which would be the structural changes there in the spine, which would lead to secondary changes in the facetal arthropathy, and the superior articular process migration upward, which would lead to the secondary pressure over the exiting nerve root, and spondylolisthesis, maybe arthritic or maybe spondylolysis could be the reason. Other would be the inflammatory pain, which is basically due to the molecular reason. Initial stage basically is inflammatory pain. Eventually, once the structural changes are taking place, then mechanical pain comes into. Eventually, it would lead to mechanical plus neurogenic pain. The anatomy is relevant here to understand. This is basically foraminal pathology. If we have the foraminal ligament, basically would would give some compression to exiting nerve root and the radicular pain that need to understand. Foraminoscopy is one tool that would rule out the intraforaminal pathology. The position of ganglion is important here because L4, L5, the position of ganglion is mostly intracanal, where that's why the L4, L5 pain is maximum, where L3, 4 pain, the ganglion is slightly foraminal. So L4, 5 disc causes more pain because the ganglion is situated mostly in the canal. So broadly, the pain generator could be right from annular fissure, PLL, inflammatory process around the disc and facetal pain. And the treatment would differ according to the pain generator. Like if it is annular tear or so, we need to first understand the pathology, and then discography would be helpful in understanding the annular tear, the site of annular tear, and then anti-inflammatory, or we can go conservatively, or maybe endoscopically we can do thermoplasty or repair of that thing, or maybe intradiscal steroid could be helpful in this point of time. Facetal pain, again, we have medial nerve root branch block that could be helpful here. Intradiscal steroid is one of the important tools, and intrafacetal injection could be helpful at this point of time. In chronic pathology, we have neuronal sensitization and pathological innervation of the disc, which is very important here. And there would be refractory backache, which would not respond to anything. In that situation, we need to, of course, do discography, and then eventually the patient would need mostly the fusion surgery, where we need to fuse the two levels, which are pathological levels are. This pain generator is important. What we call it sinovertebral nerve, which is the branch from the ganglion. Even small paracentral disc, which is pressing the nerve, pressing the ganglion, would inflict the nerve, which is sinovertebral nerve. The pain would go to, though it's a radicular pain, but pain might be felt there in the back because of this sinovertebral nerve. So blocking this ganglion by giving lateral recess block could, I mean, the radicular pain would be better, but the back pain also will be relieved by this. And the sinovertebral block is very easier, the most commonly pain management tool we use here to manage such pain. Again, compressive pain, which is very common. We do it, we manage with endoscopically, transforaminal or interlaminar or microendoscopic, and whatever technique we can use, but the pain generator can be by doing discectomy or microneural dissection, decompression, we can achieve the pain relief. Adjacent vertebral end plate and body stress, pain response, modic changes, these are all basically, I would say, absolute indication for fusion surgery, where the neural development over the end plate, which would lead to the refractory back pain, which would not be corrected by whatever block, even the temporary pain relief would be there, but eventually the patient would need surgical intervention for such pathologies. So thank you very much for your patient hearing.
Thank you. Sorry, Dr. Wei.
Yeah.
Dr. Wei. Hello.
Yeah,
Oh.
True.
Okay, for sake of time, we will shift to next speaker, Dr. Boris Bavlov. It's a visual. Okay. He will talk to us about our experience in BELD anesthesia.
I, with my colleagues, represent the Neurospine Clinic from Kyiv, Ukraine. The main areas of our professional activity are orthopedics, spinal neurosurgery, and interventional pain management. And today, I would like you to acquaint you with our experience in different kind of anesthesia at the time of PAL performing. There is no conflict of interest in this work and off-label drugs and products using. So percutaneous transforaminal endoscopic discectomy, or PELD, performed under local anesthesia, has been gaining popularity in recent years due to improved endoscopic imaging and increased patient needs for minimally invasive procedures. The use of local anesthesia for endoscopic discectomy is recommended in order to avoid damage to the spinal roots. Local anesthesia allows patient to be alert during surgery. Thus, the surgeon has a verbal communication with the patient and can correct his actions while working on neural structures. However, clinical observations show that some patients experience quite pronounced pain during the operation, especially for such stages as the installation of working port, radiculolysis, the removal of large sequestered fragments. In addition, one report contained information that due to severe pain caused by manipulation of surgeon, the intervention had to be stopped. For these reasons, the use of exclusively local anesthesia remains controversial. The most widely used method of combined anesthesia, CA, which is a combination of intramuscular injection of 10 milligrams of morphine and local anesthesia with 1% lidocaine. Having proven itself functionally well, this method has a negative side, manifested in the form of such side effects opioids as nausea and vomiting. Another important method of pain relief, which assumes a clear consequences of the patient during the intervention, is epidural anesthesia, EA. Reasonable choice of anesthetic and control of the sensory sphere helps to prevent pain and at the same time to maintain the motor function in the lower limbs. In addition to being easier to control, this type of pain relief avoids the negative effects of opioids. Literature information comparing different methods of anesthesia during PEL is rather scarce, so we decided to conduct our study. To compare the effectiveness of various types of anesthesia during the performing of transforaminal endoscopic discectomy in lumbar spine. Assess unwanted side effects of each of these methods. The study included 32 patients operated on the herniated intervertebral disc in the lumbar spine. The patient's age was from 24 to 58 years. Among them, there were 22 women and 10 men. In 5 cases, PELT was performed at the L3, L4 level. In 10 cases, at the L4, L5 level. In 17 cases, at the L5 S1 level. All patients were divided into 2 groups, a group with combined anesthesia, CA group, and a group with epidural anesthesia, EA group. The first group included 14 patients, the second, 18 patients. In the CA group, 10 milligrams of morphine hydrochloride was injected intravascularly 30 minutes before the operation. After placing the patient in the probe position and preoperative marking, the skin was infiltrated at the site of intended incision with 1% lidocaine solution in an amount of 2-3 milliliter. Then an 18G needle, 10 centimeter long, was inserted into anesthetized excess trajectory, also with 1% lidocaine is in an amount of 8-10 milliliter. After reaching the superior articular process, 3 milliliter of 1% lidocaine solution was used to anesthetize the facet joint. In the EA group, the epidural space was punctured with a 2-Wahi needle by interlaminar access to segments above the operation level. As a photo, you can see an epidural catheter was placed and secured with adhesive tape on the patient's back. A black arrow marks the place of catheter in the artery, L2, L3 level. The white arrow, the level of the operation. It's L4, L5 level. Initially, 3 milliliter of 1% lidocaine solution was injected as a trial. After 5-7 minutes, making sure that the anesthetic was not injected intrathecally, 1/4% ropivacaine solution was added. The volume of the latter was adjusted until sensory motor separation was achieved. Transforaminal endoscopic discectomy was performed according to the standard Max-Mohr spine technique. The photo, you can see stage of the PELD operation. Left side drill and working port, right is located paravertebrally, and endoscope with forceps are inserted into it. Bottom right, the site of the epidural catheter. Before the intervention, most patients rated their pain sensation as severe, sometimes intolerable, from 6 to 9 according to the visual analog scale, average 7.5. During the follow-up visit to the clinic 7 days later, many patients had no pain at all. All were described as light transient from 0 to 1 according to visual analog scale, on average 0.5. The analysis shows that there were no significant differences in the level of pain before surgery and 1 week after it was performed in both groups. Significant differences were observed in the degree of intraoperative and early, 1 hour postoperative analgesia. Comparing the data obtained, we can confidently state that in the EA group, the level of intraoperative analgesia was significantly higher which ultimately resulted in the higher degree of satisfaction with anesthesia in patients. General view of the operation room during PELD using epidural anesthesia. The patient's eloquent gesture and the smile on her face indicate an adequate level of analgesia. Photo published with the permission of the patient. A similar pattern was observed when comparing the severity of postoperative pain. In the EA group, 2 patients, 11 persons, has transient muscle weakness in the lower extremities, which were regarded as a result of prolonged action of epidural anesthesia and a condition of insufficiently correct sensory motor separation. 5 patients, it was 28 persons in the CA group, had complaints of nausea and urge to vomit, the probable cause of which was a side effect of opioids. Dysuric phenomena were not registered in any of the groups. There were no and conclusion, epidural anesthesia, in our opinion, is preferable for transforaminal endoscopic discectomy in the lumbar spine, especially for beginners. It has a greater analgetic effect in comparison with combined anesthesia and is devoid of the side effect of opioids. If epidural anesthesia is performed by an experienced specialist, the risk of potential complication is minimized. This does not increase the total operation time and the radiation load decreases. The first encouraging results were published in 2021. However, our research on this issue is ongoing, and we are confident that we will soon provide you with more extensive data on this issue.
Okay, thank you. Because our time schedule is very tight, and now we have a next speaker, Amis Tapa. He will going to now. Yeah. Okay. Bye bye. Yeah. Change up. Potel, Dr. Potel. We're going to speak. Okay, just a start. Yeah.
Okay. Anyway, thank you.
I just need to speak your title. You can start.
The screen, please. Good afternoon, everyone. First of all, I'd like to thank Dr. Prestanji and entire team, Holy Spirit Hospital, and other organizing team for inviting me for this World Congress. This is my second time here, though I have also participated in the virtual meeting. My today's talk, I'm going to talk. Escort means circumferential. Suprapedi, S means suprapedicular, S means circumferential, O is opening, T is technique. That is suprapedicular circumferential opening technique for inferiorly migrated disc herniation. So when you see this type of discs, it is a challenge for the endoscopic surgery because it is hidden behind the bones. So to fight against this kind of challenges for the endoscopists, there are different techniques are practiced. In 2008, this foraminoplastic technique is abrogated, and later the foraminoplastic technique after this suprapedicular technique come after the suprapedicular. It's not changing. Suprapedicular technique is abrogated in 2009, and then after the adjacent interlaminar and technique is described in 2010, and in 2018 this contralateral transforaminal technique is abrogated. And 2016, in 2016, there is an advocacy of the transforaminal epiduroscopic technique. And in 2018, this is the technique that I'm going to talk about, we have described in the literature. And in 2020, there is a technique associated with the making a hole in the pedicle is described in 2020. And transpedicular technique is described in 2020 recently. So today I'm going to talk about on this suprapedicular circumcision opening technique, and this has the citation by the 27 so far, and there is a view more than 2000 views and downloads of this technique that we describe in the literature. Let's go one by one. The first step of this technique is working canal placement and the soft tissue removal. After doing the initial disc decompression, working channel is directed to the suprapedicular notch. And the suprapedicular notch is surrounded by the soft tissues, which is removed completely using the radio frequency coagulator. The second step is we have to drill 3 structures to make the foramen wide and to increase the ventral epidural space. So what are the 3 structures of the circumference and the suprapedicular region? First is the drilling of the ventral part of the superior articular process. Here, second, drilling of the pedicular, suprapedicular area, suprapedicular notch. And third is the upper posterior margin of the lower end plate of the lower vertebra. So circumferentially, we are making a big hole because the disc is behind the pedicle, the inferior disc is hiding behind the pedicle. The next step is we have to maintain. So then we have to remove the disc material very meticulously because it is beyond this bony structure, hidden bony structure, because of the chronicity. There is an engorgement of the veins. So we have to be very meticulous in removing the discs. And we need the special instruments. The flexible forceps and flexible forceps are required to manipulate the discs from the hidden part. And the next step, after removing the discs, we should maintain the hemostasis very meticulously. And then we have to check the freeness of the root. Freeness of the root is checked by the pulsation of the traversing root, because that inferior herniated disc is compressing the traversing root. We have to check the freeness, the pulsation of that root. Why escort this technique? Because it provides easier accessibility and it does not damage the native structure too much. We are just making the circumferential opening, neither violating the facet joint, nor the pedicle, nor the end plates. And it has a lower probability of the intradiscal damage. We are not damaging too much. It is extradiscal, though we do the initial decompression of the disc, but not much damage to the disc, which is targeted technique directly to the inferior migrated disc, and the risk of injury to the dura mater is relatively low. And it enables us for sufficient assessment of the traversing root decompression as well as the disc extraction. But it is not aware of the potential pitfalls. Like there are potential encounters. Sometimes, as I said, because of the congestion, the epidural bleeding may occur from the vascular engorgement. So we should be very careful while taking out the disc material and dissecting the directed inferior migrated discs. But if in that case, if there is a bleeding, we can control this with the radio frequency coagulator by increasing the pressure fluid for a few seconds to minutes, not much time, and we may use the hemostatic agent to stop the bleeding. And sometimes we may injure to traversing root. as I described, because it is compressing the traversing route. So we should be very meticulous and very careful. So there are some videos that some figures and video here. That's superior part. This is a preoperative, this is a facet joint, this is suprapedicular nerves, and this is the end plate of the lower vertebra. So circumferentially, this part is enlarged to go into the disc, which is hiding behind the pedicle. This is the coronal profile that we excise this part and we reach to the migrated disc. This is the X-ray view. This is the pre-operative, this is post-operative. Similarly, this is enlarged as you see in the CT scan also, how the foramen is enlarged by this technique. And endoscopic view also here. This is the traversing route. This is the suprapedicular area. This is the pedicle. Okay, suprapedicular. This is circumference. This is the facet joint, and this is the end plate area. So this is the enlarged window. This is the window. Take out the inferior disc. So this is short video. Just we are drilling circumferentially from lower part of the superior facet to the part of the pedicle to the end plate. So there might be some bleeding, but not much too much bleeding if we control everything. So meticulously removing the disc fragment from head to tail. So this can be found out in this website, that is Biomed Central. This technique is described there. The take-home message of this presentation is circumferential, the suprapedicular circumferential opening technique is safe and reliable method to achieve a favorable clinical outcome in limited indication for transforaminal lumbar discectomy high-grade inferior migrated discs. Because I don't have to explain what is migrated and high-grade migrated. It is already in the text. Everybody knows. So so only if the disc is calcified, there may be a limited indication because we need a specialized instrument to remove this. Thank you.
Thank you. Thank you very much. Great talk. Just have a question for you. Just 1 minute, if you don't mind. So normally, I believe that this technique would be amazing for a revision case. So where someone has been operated and there is an inferiorly migrated, it's a great technique because you are going from a virgin area. But will you also do this primarily for a L45 inferiorly migrated disc? Because it'll also be so easy to just do it interlaminar, because anyways the inferior migrated portion is in the interlaminar window. It's right there. You just have to mildly remove maybe a little bit of the L5 lamina, and you'll be able to achieve the piece of the disc.
The aim of the surgery is to preserve the soft tissue nature as much as possible, because the transforaminal does not contain too many structures that we describe, and we are not destructing too much structure by this technique. So I prefer transforaminal.
Okay, thank you. So do we move to the next?
Any questions?
Okay, thank you all. Now we conclude this session, and I'd like to call Dr. Barik to chair the next session. Thank you.
Sir, please come on the desk. Dr. Francois Lissois, please come on the stage. Dr. Amit Thapa, session 8, lecture, remaining 2 lectures. Thank you. Using intraoperative neuromonitoring, IONM, effectively for safe spine surgery.
Okay, that's it. Thank you. Thank you, respected chairpersons and dear friends. Today I bring to you a different topic. Since morning we have been listening to various techniques of UB and endoscopic surgeries. But as spine surgeons, we all have been using intraoperative neuromonitoring. So I'm trying to discuss on things which we found in my institution as well as in all of the places where I worked. This thing works very well, and that's how we want to do it. So there's nothing commercial related to this presentation, and it's purely education and sharing experiences. This is beyond any disagreement that the intraoperative neuromonitoring, or IONM as we say it, is a useful modality in neurosurgery to ensure patient safety. However, what has happened over the years is like, as the surgeons, we keep on so much engrossed in the surgery, and we do too much think our anatomical prowess is so good that sometimes we just ignore the INM calls. It is just like a husband ignoring the wife's calls. So why not to make the wife's call much more genuine? And that's how we wanted to make it better, because what we have found that's both the high false positive and false negatives, the results actually negates its benefit. So if in case we can mitigate the errors, and the most common errors which have been seen by most of the stakeholders is lack of communication between the technician, the person who's interpreting that, anesthesiologist and the surgeons. These are the four different stakeholders working with the INM. And that's why this error or lack of communication has actually got magnified whenever we're talking about the positives and the negatives in the INM findings. Now this has become much more extreme because of the rampant use of telemonitoring, particularly in this field. I've been hearing that in US, there are certain centers who are actually covering whole of the eastern coast, whole of the western coast for all these INM studies, which is very much difficult to understand, because the communication is something which is almost lacking when we are doing a telemonitoring system. So what we have introduced is a mandatory protocol where all these stakeholders should communicate before the surgery, during the surgery, and even after the surgery. And what we found was the initial problem with implementation, but however, when we actually adopt this protocol and try to use it in each and every case thoroughly, then it becomes very easy. It is just like a WHO surgical checklist which we follow in every patient. So this is how it looks like. I will just describe it in detail, and this is how it appears in our OR. So you can see the INM setup and at extreme top of the patient as we are preparing the patient for the surgery. So I'm dividing it into two lists. So this neuromonitoring alert response checklist actually starts with the name of the surgery and what all INM modalities we have put on the patients. Every INM event is being marked either as a focal or asymmetric event, which can tell us that it may be a root or a caudal cord injury, or it may be symmetrical changes which may be because of the anesthetic or hypoperfusion. And whenever these alert signals comes, the surgical pause has to be attended. So we have to stop the case, and then we have to attend to each of these signals, and then every senior, either from the anesthetist side, from the neurophysiologist side, as well as from the neurosurgeon, and the in-charge nurse has to come inside the theater and see what's happening. So now individually, each of these people will do the job simultaneously. So the neurophysiologist will try to reduce the noise and the electrical interferences. He will do a trial of the INM testing, starting with the increasing of the current, as well as check the electrodes and connections, check the impedance of the stimulating and the recording electrodes, optimize the stimulating parameters, and also assess the patterns and the timing of changes. The anesthesiologist, what does he do? He actually does check whether what was the last bolus of the anesthesia drugs or the muscle relaxant given, check for the train of 4 impulses, whether they are there or not, particularly when the dip in the electromyographic signals are there, and check the neck and the limb positions, because sometimes compression can also lead to decrease in the impulses. And then check the depth of the anesthesia and look at the various vitals like blood pressure, respiratory rate, heart rate, and the BIS indexes. The BIS has to be lowered to 40 and reduced. Usually in these types of anesthesia, we do not use inhalation anesthesia, but if in case it is being used, then reduce the MAC to 1/3. and stop inhalation agents like desflurane, IV anesthetic if in case given like a propofol, the dose has to be reduced. Add the adjuvant drugs like ketamine, increase the MAP. Now this is the first tier regimen. So in the first tier regimen, what we do is we increase the MAP from 70 to 90 millimeter mercury at least. And then we want to optimize the partial pressure of oxygen and carbon dioxide and maintain the pH values by doing the ABGs. And then we want to maintain the hemoglobin. The patient may have bled too much during the corpectomy or other procedures, so that has to be checked. So the hematocrit in these particular things should be kept around 30% and above. And then we want to maintain the normothermia and normoglycemia. Then the neurosurgeons, they're also doing the same thing simultaneously. So what they're doing is they stop the current manipulation. We do not reverse it now. We just stop the current manipulation. We evaluate any maneuvers which had just preceded the INM alert. If in case we are putting some tractions, the tractions has to be avoided, to be removed. And particularly when we are doing some intradural stuff, if we are putting some cottonoids over the dura, that has to be taken off, because these types of cottonoid or even application of wax or even like sometime putting a sponge stand or a gel foam as we call it can also cause cord compression. So these things has to be taken into consideration. And then we have to look for any implant in malposition by doing an X-rays. If in case the signal do not come by, then we can even reverse the corrective maneuvers or any rod removal if in case we have put that, particularly when we are doing our spinal deformity cases. The blood loss is something which we all should be cognizant about, because sometimes as a surgeon we keep on going on for a long surgeries and we forget it. And keep the warm saline on. Sometimes hypothermia can also induce it, so flush that area with the warm saline. And then we can give papaverine if in case the patient has some sort of a vasospasm. So local installation of papaverine with the papaverine dipped cottonoid is very helpful. And then we can arrange for a perioperative imaging. If in case the recovery of INR signal occurs by then we make a note of it, and we also put a note of it as to how much time did it take for this reversal to occur. And then what was the signal after this intervention. If there is no improvement, then we go for the tier 2 regimen, that we increase the MAP to more than 100 millimeter mercury, use the neuroprotective strategies like IV methylprednisolone or pharmacological burst suppression, that is for intracranial surgeries, and then give calcium channel blockers. And then if in case nothing is working by then we should always call the second team or the second surgeons who can always assist in these types of decision making, because this is a difficult situation where we have end up having created a sort of a injury in the patient. So that's why it's always better to ask for another spine surgeon, another neurosurgeon to be there in this particular area, where they can also suggest as something which we have missed during this whole plan out. And subsequently we can plan for a wake-up test or a body presence surgery. And after we do that, we actually go for the identification of any recovery during the INM signals and quantify how much signal recovery has occurred. And such patients, whenever we are transferring to the post-op, the post-op team has to be counseled regarding what we have found and what are the prospected plan of management in the later period, and the nature of the post-operative deficits the patient wakes up. And these things has to be signed by each 4 of these stakeholders, from INM provider, neurosurgeons, anesthesiologists, and the nurse in charge who is assisting us, so as we can legally also we can quantify as to what we have done during this particular sort of problem. Now, with this particular thing in mind and also training the whole team, we started implementing this particular project in a hospital almost 2 years back. So this was a 6-month study as to how this whole thing works up in our hospital. And we have actually done with various types of INM modalities in this particular study, and also we have trained our staff in that. So anesthetic protocol we have tried to maintain standardize in the whole operations where we used INM. So this is a set of things which we all know as to how the things work. So in a total 77 patients where the INM studies were used in a protocol-based manner, which was across all the age groups, as you can see here, we have done in both elective and emergency cases. So these are the different layouts of how INM studies were used in these cases. We found that there were 26 alarms during this particular procedures as compared to 51. There were no alarms, but in none of the patients who had the alarm had a post-operative deficits. And all the patients could have the alarm averted or reversed after the first tier management itself. So we found that the maximum amount of positive alarms was actually raised during the pedicle screw placement. However, they was all managed in the first tier management itself. So this is nothing new as such, because this protocol had been suggested way earlier in 2020, and also by in various other algorithms were suggested, and they have found that this is a very good technique if in case it is well versed with all the teams, and the team members should actually communicate. So what is the most important thing is the communication between the neurosurgeons, the anesthesiologist, the person who is doing this INM studies. So if in case all the people are talking to each other, this protocol-based INM is possible. And of course, this is one of the most important thing which can be done in the spine care. So to conclude, this protocol-based INM should be implemented. That is our philosophy in the spine surgeries these days, which has been found to have the best results, which actually minimizes the risk of the true positive as well as the false negative findings, leads to the high sensitivity and specificity, and allows for the patient safety during the spine procedures. So thank you once again for your patience listening, and I'm happy to invite you all from November 14 to 16. We have a national conference in Nepal. This is in the eastern part of Nepal called Chitwan. So it's a lovely place full of wildlife. Thank you once again.
Thank you, Dr. Amit. Very nice presentation, very good protocol. Do you use in all cases of spine or only intradural pathologies?
Well, it depends upon whether we are expecting any dip in the INM findings. So if in case, say for example, the patient is having a sort of a corrective maneuvers to be done, then definitely we will place an INM. However, we are restricting, or rather we are using much more frequently in an intradural pathologies.
Now, when you are doing a tumor excision, say intramedullary, and you are, while excising, you find there is a drop in the levels. When the technician tells you that there is a drop, do you stop for
Yes,
some
of
time?
course. Yeah.
And you continue after some time? Suppose it does not improve, then what do you do?
So as per the protocol, we have to stop it, and we have to stop and follow all the first tier regimen, so that we have to have a reversal of the signals. If we do not get the reversal of the signal, then we go for the tier 2 regimen. And even if the tier 2 regimen does not fail to show the recovery, then we have to stop the case, because the patient has already developed the deficits. So if in case we are already prepared pre-operatively that if the patient do have some amount of deficits, but it's okay with the patient, but we can go with the surgery, then of course we can go ahead. But in most of the cases, patients are very much concerned about any deficit. So if in case that happens, then we definitely like to stop, or particularly stop in that area where the deficit has occurred. We can carry on with the other area in the intradural pathologies.
We have seen, we have done the tumor excision, we are going ahead, and there is a drop. It does not improve. Now you stop the surgery, you reverse the patient, you come out after the closure, and patient does not have a deficit.
That's good for the patient.
Yeah, good for the patient, but is it not a fallacy?
Yeah, that's
we have found many times this is happening. So it is not always possible you follow this strict protocol. If this is not there, it's very difficult at the time of surgery to decide whether to stop further, to operate further, or to stop completely.
So this is why this protocol helps here, because what we have found that most often, just because of the blood clots itself, just because of the hypothermia, hypoglycemia, there are so many reasons which the whole team has not worked upon to look at, and that's why we are finding a false positive signals.
Exactly.
So the false positive is the biggest problem, because once a false positive signals appears, the surgeons are all afraid, so they will stop it. And we end up stopping the case which was supposed to be completed.
Yes, that is what happens in many times. And one has to be, take a decision on table whether should we go ahead or should we leave it behind. In certain cases, when we were doing intramedullary tumor, trying to excise the tumor, we found a drop, did not improve. I don't know, instinct said, okay, you go ahead and do it. We removed it and patient improved. Patient had no deficit post-op. So this is another fallacy which we come across many times.
Yes, you are right. So that's why following this protocol actually does just not addresses to most of the things which can actually give you a false positive, or even that, for that matter, false negative reports, but also can also make you legally safe. For one reason, because all the 4 stakeholders have done their best to revert the signals, and they have found it. So there is anything ignorant of all of these stakeholders. They have not taken into consideration while addressing this issue. So I think this particular protocol should be followed in every center where people are doing aggressive work, where the chances of neurological deficits is much more higher. So as not only to document what they have done, but also to give the patient the best chances of recovery after the surgery.
Yes. As a neurosurgeon, we find maximum problem is facial nerve. When we are doing an acoustic, many a times they say there is no signal, and patient wakes up with a facial nerve pulse.
That's true.
Correct. Thank you. Nice. Next speaker is Dr. Murat. Are there any limits of left for the uniportal full endoscopic surgery? Yeah. Dr. Murat is from Turkey. Dr. Surekar, please come this way. First row. Yeah, he's here.
Okay. Dear colleagues, I would like to first thank Dr. Pazunji for organizing and all the organizing committee for making a so huge and excellent symposium here. I'm from Izmir, Turkey. I'm a neurosurgeon. I perform only endoscopic surgeries, and I'm a unilateral guy. Are there any limits left for it? Actually, it's a unilateral, uniportal. It's a one skin incision for multiple levels. The indications are growing day by day. You hear every day something new. There is entering all hidden and forbidden zones, and it's coming day by day. The full endoscopic spine decompression, the over-the-top technique, as we use it in UBE and everything else, it goes minimal, and it's a daily-based surgery. The mobilization, the patient can walk just after the surgery, and return to normal life is really, really easy and fast. And we can see every corner, almost no blind spots are left. We can see such patients. This was a 56-year-old male. He had right arm pain, numbness on both hands, and his right arm was 3 to 5, about 5, and he had then Hoffman positive test. And I made a full endoscopic cervical decompression. Okay. There you go. Oh, sorry for it. Okay, now it's working. We took out, we can see both lateral recesses, even in cervical spine. It's obvious we have to see the both ends, because if we don't see it after the surgery, when we see the MRIs or CT scans, we see that we haven't done enough. So we have to see both sides, if it is free or not. If we can go beneath the dura, we should go, but we should always be very careful about it. And this was also a next case. You can see the difference. We can effective decompression without muscle damage is very important. We can do these surgeries. Before these surgeries were done, we had to do corpectomies, laminectomies, or laminoplasties. But after these surgeries are done, we don't need any one of. The patients are really very good after these surgeries. You see a small incision 3 levels of decompression, and he's very well. And we can also do some nice work even in the cervical disc. We can take it out. It makes us feel very good, and the patients also. Sorry, yep. And the lateral recess is very important, and in most of the cases we are mostly, actually I was in the past addicted to look at the middle zone, but the lateral recess is very, very important. If we have a very good lateral recess decompression and very midline is also good decompressed, the final outcome is very, very good. And we have some special also cases here. 100 minutes, okay, that's far. That this was a 37 years old male suffering from right leg pain, difficulty on walking. He was, the MRIs showed nothing. Then when he had an contrasted MRI, we saw a swollen nerve there, and pre-diagnosed was a schwannoma. And actually, I planned him and told him that I would make a schwannoma surgery endoscopically. I would try it for him because he wanted some like a surgery. But when I did the surgery, I saw that it was not a schwannoma, it was a swollen nerve, because there was a disc beneath it, and the body wanted to get it out. So there were so many veins around the nerve that squeezed it. After the surgery, I took out the disc and took out the veins out, and he was very happy. And there was a neurodeficit before the surgery that improved and got to normal. And this was also an interesting case. It was a 75 years old male. He came with an acute cauda equina syndrome. His bilateral muscles were 1 to 2, about 5. And you see this hyper intense signal. Actually, I couldn't think about what it is. I thought it was a synovial cyst, or I thought it was disc herniation, but it was something different. It was a ligamentum flavum hematoma. Look, here you can see the ligament. This is a contralateral side hematoma. When I tried to take it out, it was filled with blood. Okay, you can see the vessels in it. And after a couple of months of physiotherapy, he recovered also very well. No complaints now. And we see every day, we see most of the, in the x-rays, MRIs, we see some sagittal or coronal imbalances, but most of them actually are stable. We have to focus on the symptoms, and most of the symptoms are the nerve squeezing that is coming from the main central stenosis or lateral stenosis. If we treat them well, look, it is moving a little bit, but the main complaint was he couldn't walk for a long time. That was his problem. And a huge decompression, and it was also still fine with it. And again, a 53 years old male. He had an discectomy, aggressive discectomy 20 years ago, and that led to physiological effusion, and he had an adjacent segment disease. and he didn't want to. He was working in a weightlifting. He was his job was that, and he didn't want to get any screws. So he came to me. I said we could try, and we made a. This was, look. It didn't move so much. It is looking less. It could move, but it was not moving. And a decompression was done there. Okay. A classical thing. I'll skip this. We have so many. And with the, I won't show it again because it's very thing. With the full endoscopy, we can do everything. It's coming day by day. Every nurse, every surgeon, spine surgeon should learn endoscopy. Uniportal or biportal, doesn't matter. It will change because, as you can see, we can also repair dura with this. Because untreated dural, if the defect is big and if the nerve is coming up and down, if it's popping, it's a really problem. You can have really bad pain. It's a really devastating situation. We have to fix it. And it's, as you can see, we can do it. And even with the endoscope, we can take out gauzes. This patient had an open surgery 6 months ago, and after the surgery, he got bad, he got problems. I thought that he had a infection there, but there was a gauze there. They put a gauze in it for stopping the bleeding, and they forgot it. And we could be able to get it totally out. So we are also able to make a gauzectomy. It was something like this.
Yeah.
Okay. And the final take-home message: everyone should learn full endoscopy, biportal. It doesn't matter. You should learn. And thank you, everyone, to be here.
Thank you. Thank you, Dr. Murad.
Okay.
The next is Dr. Sudhakar. And then we'll start the next session.
Full endoscopic assisted odontite fracture fixation. Dr. Sutipas, first road.
You take the, I think you take the next stop. No, there's a problem. No, he's not able to do it. Not able to. Are you ready? Yeah, please. ये लैपटॉप है कि दूसरा है यहाँ पे बस दूसरा था यहाँ पे लिखना नहीं था उसके किसी और के उसमें किया था एक ही जगह इधर देखो
Dr. Sutipas from Thailand, full endoscopic assisted odontoid fracture fixation. Interesting.
Okay. Good afternoon, everyone. So I am Sutipat Pongmani, orthopedic doctor from Chiang Mai University, Thailand. Nothing to disclosure. I do only unit portals. I do lumbar spine like this. This is a case of bleeding, a lot of bleeding, and this is a calcified disc and large disc and like a multi-fragment disc and this and cervical surgery like this, and how we can apply endoscope for odontoid fracture. I will tell my journey of odontoid fracture fixation with minimally invasive surgery. So I study about the odontoid fractures, and this is a maybe 200 CT scan analysis of the odontoid morphology that we can know about the size and number and feasibility of and everything in gender, in age of the odontoid, and we can put double Herbert screw in one odontoid, like any small Asian population. We can put 2 odontoid screw. This is a report, the result. This is a retrospective cohort study. This is the first generation of the instrument that at that time, maybe 8 years ago. If the odontoid fracture, we repeat, if every patient will repeat the CT scan after surgery, will union like this. And I have a 3D-dimensional study of the Herbert screw fixation and like a finite element analysis. And this is a true biomechanic testing that fix maybe four type of procedures, and 1 screw, 1 Herbert screw, 2 Herbert screw, and conventional screw, something like this, and use a biomechanic testing. And this is the first generation. I use a biplanar fluoroscope and like a mini open, like a finger, maybe around level of C5, and go up with fingers. Go up and use a drill bit instead of use wire, because drill bit you can handle it and control the drill bit easier than a small wire. Up. Okay, this is wound closure. This is a second generation that I use the instrument. Okay, this is a second generation instrument. Apply the radiolucent retractor and long sleeve in and everything. This is a third generation. I make the titanium screw that suitable for odontoid fractures and double and single deal guide and some radiolucent retractor, and can attach to the operating table. This is a design, and this is a set. Thus we can put 2 or 1 uni and double Herbert screw. The screw is designed like this and already mechanic testing. And first, we test to the cadaver, that we have a lot of cadaver workshop. And we can use a radiolucent retractor like this and put the double, this is a double deal guide. And you can do yourself, no help, attach the retractor with the operating table and use this. put like this. Okay, this is a cadaver training to neurosurgeon and orthopedic surgeons. This is a real patient that is already passed the Thai FDA, and we can use with patients. This pass the wire like this. We design the drill bit that put the wire inside the drill bit and put in the same time. Video the step. How we apply the endoscope with odontoid fracture fixation. Okay, cadaver first, and mini open like this, and put like this, and we can see the soft tissue, pre-vertebral soft tissue, and it's very safe that it's long sleeve itself. It not need retractors. Okay, put the wire and put the screw past the wire. That's all. This is another cadavers. We do mini open like this and use the little fingers inside to make the tunnels, and put and gentle put the probe and sleep and put the scope in. And you can use a cautery to clear the soft tissue and stop bleeding, some bleeding. And you can also prepare the bone for entry point like a burr, and put the drill inside. Hand drill is safer. You can move motion like this. It's not drill. It's not circular. And you can see the wire inside. And put the screw. This screw is we have many diameters. There's a 4.5. Is a tip is a self drill and self tap. And put in. And you can see with endoscope, can see the screw all the way down. Okay, and inside the bone, and we check with the fluoroscope like this. And after remove the wire and gently move the camera back, and we see the bleeding all the way up. Okay, this is a real patient. The odontoid fracture and posterior displacement and angulations. Okay, we prepare the position like this with a double fluoroscope. Use a set. And first we prepare the entry point with cautery and put the KY in and put the screw in. Okay, you can see the screw all the way down to the bone. And the wound is like this, maybe 14 to 15 millimeters. You can put two screws inside. And when the patient is healing, is a happy for doctors. The motion is normal. The benefit of a full endoscopic application for odontoid is optical and illumination systems. We can see inside the patient neck, and can see the surrounding soft tissue that entrap the like a carotid sheath or esophagus or anything. And it long sleeve, like you not need the retractor anymore, and less medial soft tissue tension because it's small in diameters and smaller wound size. And disadvantage or recent limitation is a cost of technologies and equipment and limited case in some centers. In the future, I plan to attach with the O-arm navigator because of we have like a radiolucent detector that can attach to the operating table, and the bone is sensitive. And specific odontoid set we try to develop more and more, and maybe hand instrument and cement something. And in the future, biologic material or agent that we put to promote the bone healing is very good. Okay, thank you.
Very nice, very nice. Can I ask you one question? When you make an incision with your finger, how do you know you reach to the right area? Because you are going retropharyngeal.
Yeah.
Correct? Most of the time.
How you know what?
How do you go to the retropharyngeal space to reach to the C2 vertebral body?
Oh, okay. I do mini open. Before surgery, we use a KY outside the patient's skin and check the through lateral fluoroscope view and mark the incision. And it usually maybe C4 and C5 incision. When we make an incision like we do the ACDF, but smaller, and can use the finger in. If I feel the pre-vertebral space, maybe C5, for example, and go up. That's all.
Okay. Yeah, I understood that now. Thank you.
Thank you.
Thank you. Nice.
During the next speaker is, may I ask you something? Yeah, please, you can go. May I ask you something? Did you ever try the posterior fixation in endoscopy, the C1, C2 arms or something?
Never for C1, C2. I do transoral. Maybe tomorrow I will present. C1, 2, never, but only the compressions like a discectomy or laminectomy.
Thank you, sir. Thank you. Very nice. Dr. Ayush Sharma, he's outside station. Please come and chair. Dr. Sorekar. Yeah. Welcome, Dr. Ayush.
This lecture was actually supposed to be with the basic sciences in the morning, but for travel delays, which were beyond my control, this is being done now. I take this opportunity to thank Dr. Malcolm for being my mentor and for giving me the opportunity to be here with you today. So as percutaneous endoscopic lumbar discectomy is done, the line marking and the entry point, they form the crux of all the surgery that you aim to do. This talk is aimed primarily at the beginners. Yes. So this talk is framed primarily for the beginners and was therefore supposed to be done in the mornings. A prone patient, properly padded firm bolsters. We need to be talking to the patient all the time so that he is made comfortable, and a bolster beneath the knees, ankles to decrease aid the venous drainage and decrease the chance of DVT are important prerequisites. We can also use certain padded towels to correct the tilt of the patient and to stabilize the patient better as well. The setup is also a very important part for line marking before you start to do any such procedure. And you should be comfortable with the C-arm standing in between and able to swing freely in all the positions, that is the AP and the lateral position. Most of the orthopedic surgeons would be interlocking surgeons, and a proper profile view and using a Magels to just see the full moon as you would see to do an interlocking has really found to be useful in my hands. Since we can't use towel clips, they come in the way of your draping, and no skin bites or towel clips. So we prefer disposable drapes whenever available. Otherwise, even self-adhesive draping is good enough. You have to mark the midline the first, because line marking is an art. You have to mark the midline. The pedicles should always be equidistant from the midline, and rolling the guide wire gently here and there, it works really well to come to your desired position. The sine qua non that you have to follow is the Ferguson's view. The Ferguson's view is a tilted 15 degrees craniocaudal cephalad view, and it takes into account the inclination of the sacrum and the lordosis, and thereby it results in what is called a squaring of the end plates. So without squaring of the end plates, it is impossible to enter the disc at a proper level. If you look in the first radiograph here, you would see that it appears to be at the L5S1 level, but in the second view, upon taking the Ferguson's view, that is called, the guide wire appears to have shifted. So that is very important to be very particular about this view and be really sure that you are squaring off the end plates. We start with L5 and S1 and we progressively mark all the other levels up to L1. As we go progressively upwards, the inclination goes on decreasing, and thereby the inclination of the C-arm also would go on decreasing, but progressively you can very easily mark the views of up to L1 very easily in the AP view. Similarly, on the lateral view, you should be very sure of the profile of the view, and you would see that the markings of the L5 and S1, they converge very well at a particular level, and it is only the angle of inclination that changes when you wish to enter into either of these levels. The needle has markings for every 1 centimeter and as a single line, and 2 lines for 10 centimeters. We can easily gauge the distance from the midline. Routinely 9 to 11 centimeters is preferred, and in obese patients you can go up to 13, but really never beyond 13 centimeters. In our minds, we have a very perspective. We imagine a cone, and that we are trying to hit the center of that cone is a very important concept that I found. So you can enter into the disc space very easily. The needle is inserted with its bevel pointing below, as we all know. When the needle hits the bone, then you are at the inferior part of the SAP. The needle is rotated, and then you easily enter into the disc space. I thank you all for your very patient attention. Thank you all. Thank you very much.
And now, thank you very much. And now, Dr. Nuruzzaman Khan for selection of full endoscopic approach for lumbar spine decompression, a systematic review, and proposed algorithm. And then we ask to be prepared Dr. Nikhil Arabi. No, he's not. He's not there. He's not there. Okay. Okay. So after we will start the session 12. Dr. Akhil Tiwari.
Yeah. Akhil, can you upload your presentation? We'll start BSS session.
Welcome everyone. I thanks the organizing committee, especially Dr. Malcolm, to invite me in this great fest of endoscopic spine surgery. Minimally invasive spine surgery represents a broad spectrum of technique, with endoscope being the least invasive. Full endoscopic spine surgery is the ultra minimally invasive procedure, most effective surgical technique to work on a variety of spine. There are various endoscopic approaches with various names. To mitigate this discrepancy of naming of various types of endoscopic procedure, I have spine termed the working channel endoscopic procedure as full endoscopic surgery. Transforaminal approach is termed as TELD, and interlaminar approach termed as IELD. Among the different approaches of full endoscopic spine surgery for decompression of lumbar degenerative disc disease, here we shall discuss transforaminal approach and interlaminar approach, including the PSLD. In case of lumbar disc herniation in L1 to 5, transforaminal approach is an option for treating contained or low-grade migration, central, paracentral, foraminal or extraforaminal region. In narrow foramen needs foraminoplasty, calcified herniation dealt with osteotomy. There are several factors to choose approaches. There is different types of discs, the presence of osteophytes, level of disc height reduction, interlaminar space, and larger thecal sac. Different type of stenosis, and definitely radiation hazard is a important factors, because in transforaminal approach needs a huge radiation. And in patient factor, in transforaminal approach we do under local anesthesia, so patient factor is an important factor, and overall the surgeon's experience and instrumental support. TELD is an option for the treating contained or low-grade migration of disc from L1 to L5 region. The transforaminal approach to L5 to S1 is limited by the high iliac crest, hypertrophy of the facet and narrow foramen. Due to wide interlaminar window, interlaminar access is easier without need of any bony resection. Transiliac approach and foraminoplasty can overcome this limitation to do it through transforaminal approach. The narrow laminar window in L12 and L23 is more challenging for the interlaminar approach. Moreover, minimum retraction of thecal sac may lead to devastating consequence. So transforaminal surgery is comparatively safe. Angular scopes and flexible forceps has enabled sequestered disc removal in case of the spinal canal, in areas of the spinal canal that were previously hard to access through transforaminal, but possible in transpedicular or pedicle cutting technique, which my friend Bapok told. But it is comparatively easy through the interlaminar approach. However, interlaminar obtained good result for highly migrated disc herniation. Recurrent disc herniation after conventional open or interlaminar or UV or MED presents a clinical challenges due to scarring of soft tissue. In such cases treated with interlaminar, one can encounter significant scarred tissue and risk of nerve injury and durotomy. So revision surgery using transforaminal is likely primary discectomy, and recurrent disc herniation after transforaminal surgery can dealt again with the same approach. For foraminal and extraforaminal stenosis, choice of approach is transforaminal, but paraspinal endoscopic approach is another option. Lateral recess stenosis can be decompressed safely through both interlaminar and transforaminal approach, but the transforaminal needs longer operation time and more radiation exposure. Unilateral asymmetric lateral recess stenosis and concurrent discs can be dealt with transforaminal as well as interlaminar. There are a lot of papers are explaining what I am telling this long. So, although none of the approaches are contraindicated, mastering one technique can extend the indication of the same, but mastering multiple techniques can provide an option of easier selection and safe ways to manage the problem. In a nutshell, lumbar disc herniation in foraminal and extraforaminal area, it is better through transforaminal approach. In central and paracentral disc, if it is L5S1, it is easy in interlaminar approach. In case of 4-5 disc level, if it is paracentral, you can go in both the approach. But if it is central or bilateral paracentral problem or bisectoral symptoms, it is easy to go through transforaminal approach. But in case of upper levels, if it is soft tissue or soft disc, you can go transforaminal approach because this is very safe. But if it is calcified or hard disc, I will not remove the disc, rather posterior decompression by PSLD. In discitis, previous open surgery or previous IELD or UV or MED, I will go transforaminal approach. In canal stenosis, if it is central or lateral lacis stenosis, I will go posterior decompression by PSLD. If it is foraminal or extraforaminal stenosis, I will go through transforaminal approach. This is an example of transforaminal approach in L5S1 level. After entering the disc, removing the disc fragment, coming out from inside to out, then at the foramen half and half view, and there is still disc there. So I go for foraminoplasty. That is cutting the some part of the facet to view the annulus as well as the traversing root. So you can see the epidural fat is there, so it is completely decompressed. Another case of interlaminar approach, it is also L5S1 level. After reaching the space, just landing over the ligamentum flavum, making a hole in the lateral side of the space by the punch, then through the hole, cut some ligamentum flavum by Carrison punch at the lateral side of the space, that is in the lateral recess. Just open the lateral spaces. Very few amount of bone I have to remove. There is no need of any drill in L5S1 level. Now you can see the disc is removed from the axilla. This is removed over the top technique, not landing at the disc. After removing the disc from the axilla, then I will retract the root medially to land the my working sheet at the disc level to see any residual fragments. You can see there is no disc in the axilla. Now I am going laterally by retracting the root by hollow retractor, and you can see whole the area is completely decompressed. And this is a case of spinal canal stenosis at L4-5 level. After landing at the lower, after landing at the upper lamina, then drilling at the lower border of upper lamina, then drilling at the contralateral side of the upper lamina, then contralateral facet or lateral recess. The ligamentum flavum is detached. Now the ligamentum flavum is detached from the ipsilateral side. You can see
30 seconds, sir.
You can see the ipsilateral lower lamina. I take half minutes.
Okay.
Ipsilateral lower lamina. You can see the drilling at the ipsilateral lower lamina and the contralateral lower lamina. Actually, this technique is outside in technique of PSLD because we are removing the ligamentum flavum en bloc, and there is another technique of inside out, that is just enter first in the ligamentum flavum from one side, then remove the ligamentum flavum piecemeal, that is out inside out technique, and this is outside in technique. You can see removing the ligamentum flavum from the contralateral side. You can see the contralateral root, and this is the ipsilateral lateral recess. Yes, now the contralateral root you can see totally decompressed, and this is the ipsilateral root, it is totally decompressed. Although none of the approaches are contraindicated, mastering any one technique can extend the indication of the same, but mastering multiple techniques can provide an option of easier selection and safe way to manage the problem. Thank you.
Thank you very much, sir. It's a nice algorithm. We are shifting session 10 to session 14. We are continuing with session 11. Sorry for inconvenience. Session 11, BSS session endoscopic lumbar discectomy. Case presentation by Dr. Nikhil Tiwari. Be prepared, Dr. Ayush Sharma. Be prepared, Dr. Sambhav Shah. So you all three have 10 minutes for next upcoming sessions. Thank you very much.
Good afternoon, everyone. I am Dr. Akhil Tauri, and first of all, thank you to the organizers for a wonderful opportunity. I'll begin this session with a case presentation. So I had this 37 years old male who presented to me with low back pain, which was less than the left radicular pain. This episode was ongoing for the past 3 weeks. This was the second episode. So the patient did have one episode, which was 6 months prior. And at that time, it was managed conservatively. On examination, the patient was absolutely miserable. He was not even able to sit or stand. SLR and cross SLR were positive. And he did have a neurological involvement in the form of left EHL and gastrosoleus being grade 3/5. So we went ahead and got an MRI scan done. Now, this is the MRI picture at L5-S1 showing a left paracentral disc. And there was also an inferiorly migrated disc to the extent that the left S1 nerve was completely crushed. I got standing weight-bearing X-rays. So AP lateral flexion extension didn't show any instability with good disc height otherwise. So coming to the problem set, the patient had second episode of low back pain and radicular symptoms, neurological involvement. There was a disc extrusion along with a disc bulge at L5-S1 and more of a paracentral and inferiorly migrated disc. Considering the clinical examination as well as the imaging, we went ahead and offered surgery to the patient. The intervention was in the form of an interlaminar endoscopic discectomy. So I'll just go ahead and finish the case and then we can go ahead with the session. So we did a full endoscopy. Docking was slightly inferior because it was inferiorly migrated disc. This is the intraoperative video. So we have docked the disc, the medial, lateral, and the caudal areas have been marked, and we have gone ahead and taking out part of the flavum. So starting from medial, we have gone lateral. We can also see now the epidural fat. Maintaining good hemostasis throughout the surgery is extremely essential. And then we went ahead and completed that flavum excision laterally. Some bleeding is anticipated from the epidurals, and which can partly be taken care of by just manipulating the scope a little. So further dissection was done till the time we could remove that flavum. The problem was that the disc was so big that it was a part axillary and a part also extending lateral. And this is after the complete clearance of the flavum. We tried to mobilize the nerve. And we can see that the disc is just underneath that nerve. On putting the dura dissector, we tried to mobilize the nerve right now, and then we could see that the entire fragment just jumped out into the scope. We were able to get it in one mass. Now this is some intraoperative pictures, and also the versatility of the scope that we were able to direct it superiorly and also go for the exiting nerve. We were able to remove almost 3 centimeters of the disc fragment and through a 1 centimeter single incision. So that was my case. I'll go ahead and have Sambhav come for his talk. I'm sorry, I think it's Ayush's talk before.
Aishu Sharma.
Yeah, thank you everyone.
Presenting.
Thank you. Yeah, please go ahead. Yeah.
So, Dr. Ayush Sharma is presenting endoscopic spine surgery, how I started and where we are now. Meanwhile, I call upon as a chairperson Dr. Rohita sir and Dr. Nurjaman Khan. Please come upon the stage and chair this session of Dr. Ayush Sharma sir, and after that Dr. Sambhav Shah.
Okay, so thank you. It's a part of the Bombay Spine Society and initiative. We have a collaboration with this conference. And today, with this talk, I represent the Bombay Spine Society. So I will be talking about how endoscopy started and where are we now. So I'm Dr. Ayush Sharma. They have already introduced me. So if you look at the history of how it started, it goes all the way almost 50 years back when the endoscopic spine surgery began with as a percutaneous endoscopic discectomy. Cambion was the first to start, and they had the earliest attempt to do this surgery back in 1970. Later on, Cambion and colleagues introduced a method to remove the nucleus pulposus using a 5 mm working cannula with a flexible scope, and that was during 80s. Subsequently, authors reported improvement in percutaneous endoscopy and discectomy techniques. But this is the guy who really changed it. I think anyone who does endoscopy knows Anthony Young. He's the one who started Young's endoscopic spine system at that time, and which was based on the inside-out approach. We all know inside-out approach has its limitation, but this was the first true endoscopy approach, and this is the paper he wrote back in 1999. So then came the outside-in approach, which was first introduced by Hoagland in the transforaminal approach, allowing a wider range of transforaminal approaches, because now you can go in halfway in, halfway out, and you have a direct access to the epidural space, because that was missing earlier. Then people further added a drill to the, sorry, I don't know if it's playing, okay. So something got stuck here. Anyway, so sorry. Sorry, it's getting stuck actually. Yeah, so transforaminal approach become epidural approach, and that is how it was introduced in 2007. And then the transforaminal approach had, as we know, has its own anatomical limitation, because it is the anatomy of the foramen sort of determines how much you can approach. And that was that was the limitation of bony anatomy. So the use of the burrs sort of changed it. I think the videos are not playing, so it doesn't matter. But basically, what happens is, we know that the transforaminal approach has a problem because it is the canal anatomy which determines how much you can do. So later on, with the introduction of endoscopy burr, more and more work getting started done. The earliest endoscopy approaches had the limitation of surgical exposure, and that is when the Cambion introduced the so-called famous safe triangle, which sort of directed how much, which is the safe area to land in transforaminal approach, and how much disc can you do with this approach. Then came, this all was all first generation scope. And then came the second generation scope, which sort of developed with the, like the problem still existed because, with transformal approach, you cannot still go to L5S1, and still you had limitation when you are tackling something which required a lot of bony work. So then came the second generation approach, which started with the introduction of the interlaminar approach. The interlaminar approach was developed to solve the problems which we're facing with the transformer approach. Interlaminar approach, as we all know, and you have heard so many talks, further got divided in between the uniportal and the biportal system. And that is where the second generation scopes came in. The third generation scopes were the one when the more and more pathology related to the lumbar canal stenosis, which was still now not a problem when you are using the first and second generation scope, came. So third generation scopes were basically the stenoscope, where more and more bony work started getting done. One of the previous problem with all this was because you cannot, you cannot use the big burrs and the high speed burrs to do the bony canal. So newer innovation, I think you must have heard now more and more people are doing fusions with this. Both the interlaminar uniportal and biportal approach are being used to do more and more bony fusions. But still the problem with bony fusions today, even with all advances, is limited to the use of like allograft. Most of the times you don't get much autograft in these cases. And the second problem remains the use of small size cases, which does lead to certain problems when you use endoscopy as a tool of fusion. So these are the three generations I spoke till now. The first generation, which was mainly for discectomy, the second generation, which started with the interlaminar scope, and the third generation scopes, which were more advanced and which allowed you to do more and more bony work. What is the future perspective? If you see now, the world is moving towards using large and large sizes cases, even with endoscope, okay? And this, I was surprised to see, this is the footprint of the case they were using in Korea, and this is as good as my olive cages. Thanks to this guy, he showed me how you can put a 40 mm cage through an endoscopic approach. And you not only that, your cages are becoming big, but even your visualization is becoming better, and that is the future. As you can see here in one of the images, we are using a 4K scope. It's a 3D scope. We all are wearing glasses, and it does gives you a better depth perception. Now, what is next? I think endoscopy navigation can further change the way you do endoscopy. We do have some experience with it. So if you see, so if you go to the previous slide, this is a case where it's a young 32-year female, and she has a bony osteophyte growing in, and either my choices was to fuse her or do something different. We went through an endoscopic approach. I don't know if the video will play or get stuck. So basically, this was a navigated burring of the osteophyte, and were able to remove the drill. I hope this plays, I'm not sure, but this is how it looks like. What we do is, we not only navigate our scope, but we have a software which sort of merges the CT scan with the MRI. You know exactly where you are going with the drill, and it really changes the whole game of using endoscopy, because you have a very, very better visualization. You know what you are dealing with. And these are some of the cases, a hard calcified disc, which we have sort of done using these techniques. I don't think the videos are playing for whatever reason. So basically, you use the navigation to drill out those osteophytes, and then it is like any other technique. You just separate the dura from the disc, and you do your discectomy. But in cases like this, I think navigation is the key. It really changes the way endoscopy spine surgery is done. I'll just skip the videos because they are not playing. So just like your mobile phones, the endoscopic spine approach is evolving every day. Every day we are becoming better. And some of the advantages are coming because of better screen technology. As your screen are changing, now most of you have a HD. We are just about to get a 4K. Tomorrow we'll have a 4K Ultra. as the screens become better, your visualization become better, and your endoscopic spine surgery becomes better. Development in optics, especially the 3D, and maybe the virtuality in future will further lead to a lot of improvement in endoscopic spine surgery. Other technologies like navigation, robotics are the future when you combine them with endoscopy, and there is what we are going. So again, with this, I also like you to come next year. We are doing a minimally invasive Asia Pacific, where there will be a lot of talk on endoscopy, and which is next year. And as organizing secretary of that meeting, I'll invite all of you to come. It is a combined meeting of Minimally Invasive Spine Society of India, which is the biggest spine society, MIS society in India, Bombay Spine Society, which I am representing today, and ASMIS AP. So thank you so much. I have another one. Should I finish? Okay. So hopefully the other one is a video presentation. It should play, otherwise I cannot do that. So this was basically on endoscopic cervical discectomy. I've been asked to do a video demo. So this is a case. You can see there's an extruded disc. Not only there's extruded, it's quite, you cannot see? Just see this. Okay, I'll just see. यहाँ पे तो वीडियो यहाँ प्ले कर रहा है बट वो नहीं कर मिरर करना some of cities वो तो पीपीटी था अच्छा ठीक है okay I think let Sambhav do his talk. By the time I will transfer to something different. Okay, so yeah.
We can have the Sambhav's presentation. Yeah. And one honest advice to all speakers: with their laptops, they should see that the videos are playing. Even I go for a local meeting or an international meeting, in the meanwhile, in the lunch break and other things, I see that all my videos are working.
Okay, thank you, Dr. Malcolm and whole organizing team for calling Bombay Spine Society here to be a part of this lovely meeting. So I'm going to be talking about full endoscopic discectomy, how to recognize intraop challenges, what are going to be the difficulties, what can you anticipate, and what are the complications that may occur if you don't recognize these challenges. We are not going to discuss on how to deal with those complications, but we are going to discuss on how to try and avoid those complications and what challenges we can face. So, a lot of our seniors used to say, if you do not have a complication, it is because you have not operated enough. But I also feel that if you have a complication, it is also because you have not operated enough. So that is one thing with regards to endoscopic spine surgery, which is really important. You need to understand that your training is one of the most important things which can help you reduce the complication. So the challenge is training. So if you move from an open surgery to a tubular surgery, then whether you're doing a UB, Destandu, full endoscopy, whatever it is very important to train well, and that's the number one thing to avoid any kind of complications. However, before discussing the intraop, I think it's also very important because your preoperative assessment of the patient, your preoperative assessment of the MRI, the X-ray, even these can avoid any complications. Sometimes you will go the first few times you're doing a case by yourself. You may have done it with your bosses, you may have done it from where you've trained. But when you're doing it alone, and when there is no one to guide you or no one to tell you, okay, maybe your entry point is wrong, or you are docked on the facet, or you are at the lower lamina, etc. It is very important to know where exactly you want to go, what's your target. Because even the entry point will change. If you have a disc which is superiorly migrated, you may want to take a different entry point. If you have a disc which is inferiorly migrated, and if you go straight down in the interlaminar zone, you may get it, but a superiorly migrated, you will not get it. You will start searching, where is the disc, where is the disc? You will be lost and you don't know. So very important, read your MRI scan, see the X-ray, see the interlaminar window. Again, a lot of people ask me whether, I want to start uniportal interlaminar. So should I buy a burr? Okay, yes, burr is eventually important when you are going to increase your indications. But it's your preoperative X-ray and MRI reading which will guide you whether will you require a burr in that particular case. If it's a 35-year-old L5S1 big interlaminar window, 100%, you may not need a burr for that case. But if it's a L45, tighter interlaminar area, you go in, there is bole all around you, you will try and struggle in that small interlaminar window, you will not resect any medial part, you will try and retract the nerve forcefully, you are going to create complications for yourself. So plan the steps, target the disc, and it has to be a la carte approach. If they have said in transforaminal entry point is 7 centimeters from the midline, it does not work like that. Everyone's bodies are different, BMIs are different. You have to take an ala. Yes, you can understand the basic principles, but you cannot apply the same technique in every case. If you're looking for a flatter entry for a transforaminal versus a posterior lateral entry, it cannot be through the same incision, it has to be separate. So understand what your landmarks are, and that surgery is very easy. I think the most important thing, we all feel it's a 5 millimeter, 6 millimeter incision, but I think the most important thing is target. What is your end point? Where are you targeting the camera? Because if you target the endoscope in the right place, then I think the complication rates are minimal. But otherwise, you will just be lost, even though it is a very small area, you can completely get lost. So for an example, this is a patient with L5S1 disc, right-sided, compressing the nerve. Now, if I see just the SAG images and operate, I will easily miss that there is an inferiorly migrated fragment also, which is extruded out. So if you see in the axial cut, there is a fragment which is there. Now, if I just go on the disc level, remove this disc, and I don't go and check my axilla, and as you see here in this case, the disc is in the axilla of the nerve. It will be underneath the nerve. And if you don't check that, there is going to be a residual disc. Patient will have symptoms, and you will feel that you have failed. Now, say for an example, a huge superiorly migrated disc. Now, there are various options of doing this. So you need to plan. Do you want to do a laminotomy of L5 and go directly down? That is a possibility. Do you want to make a hole in the lamina and go down? That is a possibility. I believe endoscopic surgery, you want to do the least. You don't want to remove unnecessary structures which are actually important. Why should I remove a lamina if it is not coming in my way? Why should I remove the whole phlegm if it's not coming in my way? It's there for a reason. We have that in our body for a reason. And that's what I think endoscopic surgery is all about, to try and retain the natural anatomy. So now in this case, I planned that, okay, I want to go superiorly. So my entry point in the interlaminar zone, I will take it a bit lower. So I will go down. So if you see in the second lower X-ray, that I'm going down into the interlaminar area, and then I am tilting my scope to go superiorly to get that fragment. So here, I was able to do this without doing any laminotomy or any facet resection. And we'll show this video tomorrow when I'm discussing about migrated discs. Now, another case. This is a patient with the L5S1. She has a foraminal disc that is just underneath the facet. If I go interlaminar, I'll have to remove a lot of facet resection, etc. So now I know my planning. The iliac crest is low in this patient. So I know I will be able to target this transforaminally. But transforaminally, again, what are the problems or what things I have to recognize? So let me just go through these videos. So this was the first case of the interlaminar L5S1 with the scope. Now, most important, recognizing challenges is first understand your anatomy. One rule for endoscopic spine surgery is that don't go and remove anything. Use your cautery religiously, your RF religiously. Whatever you want to remove, first use your RF around it and then remove it. Don't remove a muscle. Now this, if you see this step, I can't see the tip. I've done this purposely to show in this video. I can't see the tip of that instrument. That is dangerous. I don't know where I'm cutting exactly. So you have to make sure that when you're even doing, you are still at the phlegm level, your tip should be visualized like this. The cutting tip should be visualized very well. And then you do further. A lot of people again question, can we use bipolar, the regular bipolar for doing this, or do we need RF? You need RF because the smallest vessels are magnified because of the endoscope. Now you see here, it's a huge vessel. I'm not going to use my cautery or bipolar, and if I have a RF, I know I can easily cauterize that vessel, move. Now, another step, nerve. Now, when you are doing that, make sure that the nerve is completely free. It is not stuck to any adhesions. The nerve is beautifully mobilizing, and then you do your rotatory maneuver. A lot of people say interlaminar endoscopy, a lot of neuropaxia post-op. It doesn't happen if you follow the steps correctly. Don't try and get excited if you see a disc below and just try and move the nerve. Use your cautery, use your pen field, try and dissect the nerve away from the disc, and then push it beyond. And then you will see everything. Again, another thing, sorry, I'm able to pause this. Another thing, always visualize your axilla. Okay, now if you see this case, this was again a patient with a big disc. I can see the disc is just coming out. This is one of the most exciting things when we see when the disc is just coming out into the endoscope. You will remove that piece of fragment and a huge piece coming out. You are so happy. You see the lateral border of the nerve. You see the medial border of the nerve. And we a lot of times forget to see the axilla. You have to see the axilla. Now, everyone will say, I've retired the nerve beautifully. I don't see any pieces. But when I'm on probing further, I'm still getting further pieces which are coming out. So you have to spend time. Don't try and say, the disc is out in 10 minutes, man. What a surgery I've done. That's not the way it's supposed to be. You're supposed to see the nerve from the shoulder to the axilla. Now, finish this. I'm removing some small fragments. And I felt that I think good job, Malcolm, sir. The disc is out. Yeah. So now I'm checking, still nothing. But I have not seen my axilla yet. Okay, this was a big disc. I'm looking forward. I'm going towards my axilla. Now see, I still see that the nerve is pushed laterally. It is not flat. If you see here, it is getting pushed laterally. So I want to explore the axilla. You always must see and see that. There was a fragment over there. So I got this. But see, there's still something over there. So it's very important to check your axilla, your shoulder. Always shoulder to axilla till the nerve is going out of the foramen. You should see this nerve in totality. So this is obviously the advantage of interlaminar. When you're doing a transforaminal, your indication is completely different. Okay, so for me, my transforaminal work is mainly for extraforaminal discs. Now you see, in this case, I'm still probing and there are just still fragments coming out. We always discuss what is the end point of these surgeries. Now, after removing this fragment again, and the nerve, the dura is still floating. We all say floating sign, this is floating. But now, see, from the shoulder, now I'm seeing the nerve, it is going underneath, and that's when I know, okay, I've seen all the borders of my nerve clearly. I can see the base beautifully, and I know that I'm okay. Now, last case, this was extraforaminal disc I showed you. Again, what problem? So number one, the exiting nerve root. Extraforaminal is one of the more difficult cases because in transforaminal, your endoscope is stuck inside the foramen. Even if you leave the endoscope, it will remain over there. But extraforaminal is still mobile. And to avoid in extraforaminal, you don't know where the exiting nerve is going to be. The disc is pushing it. So reading the MRI is important. Number two, what I do is I dock at the superior border of the inferior pedicle. So if you see here, on that side is the superior border of the S1 pedicle here. And then I'm moving up. And I can see that the nerve is on top. And there is a piece of disc which is there, which I'm going to retrieve. Now, even in this case, again, when I saw this, I was so happy. I looked at the time, surgery done, 10 minutes. Beautiful surgery, patient under local anesthesia. Yeah. But in this patient also, the minute I go up, you want to check the whole of axilla. And when I go up and I saw that there were another pieces underneath the nerve. So it's very important. So following the steps correctly, going anatomically, understanding where your anatomy is, not being in a hurry, recognizing preoperatively that these are the problems I will face. In this case, I knew the exiting nerve could be a problem. I have to dock at the pedicle. This overall makes your surgery much more easier. It helps you recognize the challenges preoperatively and intraoperatively, and that invariably prevents your complications. Thank you.
Thank you, Dr. Sambhav Shah. Very nice, elaborating challenges, how to tackle step by step. Right? Thank you very much.
USB निकाल दिया ना उसने.
Make it full screen. So this is a video. It will run for 7 seconds, so there won't be any wastage of time, I guess. So this is a patient, 28-year male, presented with a C6, C7 migrated disc. And if you see the disc, it is right below the C7 pedicle. It is significantly migrated. And we planned for endoscopic approach to this. And you know, those who do, this is the classical docking. Only challenge was, can you go so deep below the pedicle of C7 and get it? So from the very beginning, I'm using a 30-degree scope because you need to look quite significant down. So it's a C6, C7 gone below the C7 disc, C7 pedicle. So this is the cranial, this is the caudal, and this is the C7 lamina. And that is the classical foramectomy approach. You sort of go and start burring the V section. So this is the high-speed burr which you need to do when you are planning for a cervical foramectomy. And only thing I think is important is you need to plan which area, how much bone you want to remove and which area you want to target. So from the very beginning, I sort of targeted the lower part, the upper part of the C7, the V junction, which is like sort of goes into your lateral mass. So this is after the burring the part of the junction, and you can see still some. So most of the times we burr the upper cortex, and the lower cortex can be easily sort of removed with the ronger. So that is what you do. So you can see still some part of the bone is remaining, and the bone punch is used to complete the foramectomy. So this is where we are. And as always cervical spine is slightly challenging because you do get quite some amount of epidural bleeding in these cases, especially when you have a disc and it sort of have a lot of inflammation and fibrosis around it. So this is where we are. Sort of the foramectomy is done, but still because I wanted to direct more down, so I am sort of still burring very close to the C7 pedicle, because I need to go in an area which is the disc is migrated below the C7 pedicle. So C7 pedicle is quite big. Even if you drill a part of it, it should not be a problem. You're drilling maybe 5% or so. This is where the drill is. You're sort of drilling the superior part of the C7 pedicle, because that is where the disc has migrated, and that is the whole idea. You need to access the disc to sort of remove it. So this is exactly, you can see the bony C7 pedicle. And now once you have removed it, I got quite a bit of space between the dura and the pedicle. So this is, you just fiddle out with your RF, because that's what Sambhu was telling, that is the safest thing. But you can see the epidural plexus sort of bleeding, guiding you where you need to go. And that demarcates the safe zone between the bony anatomy and the dura. And once you sort of start removing the ligamentum, you get a fat pad, which is normal. The fat pad is always a warning sign that something important is there. A fat pad always protects something important. So you can see the lateral margin of the cord has been identified. And still, what the idea is to keep looking down. And imagine this is 30-degree scope which you are using. So you're always down. You're more down than you always think. And that is the beauty of, one of the beauty of endoscope. You can really work. And this here is the first part of the extruded disc, which is just below the dura. And it will just come out as you fiddle with the RF. So always the RF is the safe. It could be anything. It could be a disc. It could be a root. It could be any other important structure. So, RF radio frequency probe is your eye, is your ear when it comes to endoscopy. And that is one of the safest thing you can do. So this is the whole disc which is sitting just below the dura, just above the C7 pedicle. And you sort of, like anything, you just sort of start working on it. There's some fibrosis or something. So I'm just releasing it. But remember, quite a bit of the disc is still migrated down, which might be slightly more challenging to take care of. So we'll just remove this within a matter of seconds. And so this is like what you do. This is the part of the extruded part, which is just in front of us. So always you need to, as Sambhu was saying, making sure that you sort of protect anything which is important, and you go slow, you keep an eye on the dura. It should not move when you are taking out the disc. And this is the disc material, which is the first fragment sort of coming out. And you remove the first fragment. And as you remove the first fragment, never say never. You might have a second fragment which might be there. So you need to probe. If you see the white, you can still see some white structure just sort of peeping in. This is your second fragment which comes out. And as you see that, always go and probe more. As I said, never say never. Again, you see another sort of white structure just coming into a picture. And as we remove it, will be the third fragment which will come out. And this is the third fragment, which just I'm trying to grasp so that, most of the time while you grasp, you sort of leave half behind. And this is the third fragment. And still, I was not sure if everything has come out. So, you can still, I wanted to go much down below, just probing for see how down I can go with my flexibility. And that is where, you sort of move that fragment which is gone behind your pedicle. And you can see part of it is just, coming into picture. And then you can use all this curved probe, which most of us have, and you sort of bring it in your view so that you can remove it safely. And this is the fourth inferior migrated fragment which was there and which needs to be removed. And so we made sure that it is free and it is like safe to remove. And then you just remove the last fragment in this case. And once you have done that, again, it is important to make sure that still nothing is there. There could be a fifth fragment, but fortunately that was not the case in this one. And we made sure that the epidural space is free and everything was removed. And this is, you can see this is the margin, and you see the bone on the 3 o'clock, that is the pedicle which was partially drilled. And look at the angle which you have. You can really see quite deep and quite below because you're using an endoscope and you are using the 30-degree angle, and this is the end of the decompression in this case. And we, just for the sake of academic purposes, we also took a post-operative CT and a post-operative MRI. These are the removed fragments which were taken out in this case. And this is you can see the foramen window on the CT, which is just done on the pedicle. This is the post-operative MRI. You can see the migrated fragment here, and this is the post-operative MRI on the axial section. And patient did do very well because they are very, very happy patient for all those who do endoscopic foraminotomy. Thank you so much.
Very nice, Dr. Ayush Sharma. Before we ask questions, I invite session 10 chairperson Dr. Vinod Kumar, Dr. Pradeep Singh, Dr. Nikhil Arabati, and faculty Dr. Akaravit. Now, meanwhile they join on the dais, please continue with the question and answer session.
Any questions from the Malcolm, you want to answer? Now, Ayush ji, you talked about the developments. Transforaminal, then stenoscope, and now the fusion with 4K. Yeah. This is just a comment. I am using this endoscope since 22 years. Next 10 years, the fusion rates will be 2 more. And we will be going to the era where the open surgeries were done with the fusion and people were not accepting it. That is the fear in my mind. Because if these things are included in the Indian scenario, if these are included in the Indian yojanas and other things, government schemes, the number of surgeries are going to be increased. This is going to happen because nowadays, those hospitals who have yojanas, rather than operating 10 cases, now they are operating 20 cases. So the workload has increased, the infection rate has increased.
It's very interesting, sir, in the sense, if you look at it, endoscopy was started as a way to not fuse. Now
yes,
look at the surgeons,
that is the misuse.
And more are not only going for fusion, and the way the cages
so that's why I told you it is not minimally invasive, it is maximally invasive.
I will disagree. I absolutely disagree.
Malcolm, 1 minute. Let me finish. About the complications. Sambhav told that when the person is not operating, he has less complications.
when the person is operating more, he also has more complications because a person has some limit. This is what we have mentioned in our book also. When my boss used to operate 4 to 5 cases, the complication rate was quite low. When he started operating 8 to 9 cases, the workload increased. When I used to assist him 10 cases in a day, the wrong levels, everything has increased. Even the social issues of the surgeon are important. Nobody is mentioning, we have mentioned in our book, changing from one hospital to other, changing from the nurse, assisting nurse, in spite of the improvement, best improvements in the camera, the imagery, the instruments, and a single person. If you work more, complications are going to be high.
As far as fusion is concerned, one of our doctors, one of our colleagues mentioned something very beautiful. Before, when we had reherniation, we had no other option but fuse. Today, reherniation is not an option to fuse. Even if it is reherniation a third time or even if it's a fourth time. So frankly speaking, my incidences of fusion surgeries, I agree. Even I misused it a little bit initially in grade 1 listhesis degenerative. I used to do, now I don't. But overall, if I were to assess myself, from a person who would be doing maybe 100 endoscopic fusions a year, I've come down now to maybe 25 a year.
This is a natural history of fusion. Initially, they are more.
No, sir. The
When
number
you
of indications.
When you are elder,
no,
it comes down.
No, sir. The number of indications have come down. Because endoscopy allows us to do many things that we normally would not do. Let me give you an extraforaminal L5S1 disc. Most open surgeons would have gone for an endoscopic, would have gone for a fusion. Most of you, most who are open spine surgeons. I have not done a single such indication fusion for the last 5 years of my life. So if I were to go through the NAS list of indications for fusion, cut. What is left is very little now. So we have entered fusion, but we have brought down our fusion rates. So fusion has not increased because endoscopy increased. I would say it is the other way around. We have been the enemy of the fusion industry because our reasons for going for fusion has come down. That is what I'm trying to stress.
But what is going to happen, you are telling that no fusion now, but your youngsters are going to do it. And then when they will be elder like you, then they will tell that, look, there is no need of fusion. This is what has happened in the open surgery also, or open giants also.
So what I presented.
And one more thing. This is like Mahabharata. Everybody thinks that I am Pandav, the rest are Kaurav. I don't do any fusions.
So what I presented was straight away from the literature. It was unbiased, without any. So the first slide itself have the article. It's
Thank you, Dr.
Journal
Vedas,
of
sir.
Neurosurgery. You can read about it. We all will include fusion somewhere. How you do it is up to you. Do what works best in your hand. That is all. Thank you.
Yes. Thank you so much. It's a little bloodletting here and there. That's good for everyone. Please start with your talk.
One question to
One more question.
Dr. Shambhav Shah. I'm Dr. Sakib from Bangladesh. So in open surgeries, usually we, with extruded discs, we tend to poke the remaining discs and find a lot of fragments inside. So with the endoscope, what's your opinion on having the retained disc inside the?
So typically, if my preoperative MRI is showing me there is an extruded piece which has gone down, I will first go for that fragment. I will not go and check, but my disc level also is. So I will first go and retrieve that fragment. Once I see, for an example, the fragment has come out beautifully and the nerve is fine, I will try and just explore the annular tear from where the fragment has come out. Once I see the annular tear, yes, I do use a nerve hook and I'll poke for if there are any loose fragments over there also. Sometimes I even put the thinnest pituitary, but not deep inside, just superficially, to check if there are any extruded, any loose pieces still remaining, but I will not poke the disc inside. I will not go inside and try and keep on removing as much disc flaky material comes out. Never do that.
If you find annular fissuring or tear something, so you use RF there?
Yeah, I use RF but I don't know how much it helps, honestly. It is just that from years we've heard do an annuloplasty. So I just use the RF underneath the annulus, but it's not that the recurrent rates goes down because of that. But I do use it.
Thank you.
Thank you.
This morning, various types of the endoscopic spine surgery. How to do, when to do, what to apply, what not to apply. See, endoscopic spine surgery is motion preserving surgery, first thing. It's not about fusion. Wherever it indicated now, you can use as endofusion. So it's about indication, not about applying. And the debate was different. It's about open fusion versus endofusion. So whatever you want to see under open surgery, you can directly see with your eyes, like endoscopy, directly over the nerve root. So rate of the complications, rest of the other issues will come down. You can see a lot of things tomorrow, day after tomorrow, and another day after tomorrow. Please start.
Okay, so yep, I will talk about fusion. My name is Akarawit from Bangkok, Thailand, and my topic will be the transfacet approach in the lift. So actually, this is my concept. We create this technique in 2022 by me and one of my colleagues, Dr. Apirat. The concept is to shield all the structures. Traversing root by the medial wall of the facet vessel by the lateral wall of the facet, and the exiting root by the cage gliding system. So it, unlike the normal transfacet that you remove, like do the total facetectomy, we go create the tunnel through the facet to the disc and use the tunnel as a guard to push the roots away. And we can recreate this because after we drill the facet, we identify the joint line and we go lateral to the joint line and go along the way to the disc. And with the joint expansion, the nature of the joint itself, when we put the bigger cage, the joint will expand to accommodate your cage. So we have like so many interbody fusion technique, as you know, P-lift, T-lift, interlaminar, transfemoral, X-lift, O-lift, and we are going through the facet. So it's going to be the transfacet. With the normal endolift techniques, like a transfemoral approach, we are very aware of the exiting route, and also the cage insertion sleeve is pretty large. So in the Asian people, like or more Oriental, like in Southeast Asian, usually the cambium triangle is very small. So if we put the bigger sleeve in, it may damage the nerve roots at that point. So we are aware of the exiting routes for the transfemoral approach. And with the interlaminar approach, we need to drill the facet more. And we are aware of the traversing route. So what we're gonna do is go through the facets, create the tunnel. No need to see the traversing route, no need to see the exiting route, just go through the facet. I want to introduce the A area. A area is the most dorsal part of the facet, and it is the starting point for a drill. And we start at this point and going in. The advantage of this approach is we use less skin incision. So the normal endolift, you need like 4 percutaneous screw with a full endoscopic system, 4 percutaneous screw skin incisions, and 1 more skin incision for cage insertion. But with this method, we use the cranial incision of the percutaneous screw for doing the cage insertion. So yeah, less skin insertion. And easy and reproducible because we go through the joint. We don't see any vital structure, just only bone tunnel. So this is the A area. And we want to go identifying this point and then go through this point like this. So with the first under the endoscope, we see the first place, like the first point is the A area and all the soft tissue around. With a joint capsule, we remove the joint capsule and identify the bony structures, and then we start drilling until the second point. We see the joint line, facet joint line, and we drill the lateral to the joint line and sometimes medial to the joint line. And we go along the joint line until we're reaching the disc after we remove the SAP. So with this method, you can see like we have no exposure of the neural structures at all. So this is the video with the transfacet approach. Yep, I'll try to. Okay, so we try to identify the A area, and then we start drilling. This is the first thing you need to do, drill and see the bone. After you reach the bone, you're safe. And then you drill along until the joint line is visible. Yeah, we see the joint line at this point. And down there is going to be the SAP. You create a tunnel like this. Yeah, the SAP is down there because the cartilage of the facet is a curved shape. So when you remove the IAP, you still have a SAP down there. And then remove the SAP and you will identify the disc at the floor of the tunnel, like this. And after you identify the disc, this is a flavum and remove the flavum and you just find the disc here. And then you do the discectomy and insert the guiding rods in, and it will act like a guide to put the cage gliding system in. So I used the Harrison cage glider, but I think there are more better design than the cage gliding this system. So after I put the cage in, there are, yeah, you can see the flavums there. We don't see any nerve roots, and we can do direct decompression afterwards by removing the lateral part of the flavums and also the medial wall of the facet that we left. And after we remove that, we can decompress the lateral recess effectively. Yeah, you can see the traversing root at that point. Yep, here, this cage is here, and we see the quite a distance from the traversing root at this point. And with the second video, yep, we put the guiding rods in. We put the Harrison cage glider in. Actually, Dr. Harrison Kim himself using this cage gliding system to guard the traversing route, but I use it to do the cage insertion by retracting the end plate of the disc. So we can put a bigger cage. Oops. Okay. So, yep, like this. And we can use the normal end plate prep, like a disc shaver, like a curette to do the preps, and then we can insert the cage. So at first, I use the expandable cage, but currently I use a normal cage. We don't need the expandable because we can put the cage up to 13 millimeters without any problems. So probably 14 will be fine also, but in Thai patients, 13 is like very big already. So after put the cage in, we can do the further decompression, and we can see the cage here, and then we can visualize the traversing roots here. So it's pretty far. So yep, we can see identify the area going through this and going. Oops, sorry. Yep, see the joint line, drill until reaching the disc, and then do the discectomy, and then repeating the same process and put the cage in. We can see the traversing route after the decompression. So that's all. Thank you very much for your attention.
Thank you, Dr. Akarvik. You can ask. Meanwhile, I invite Dr. Ghausal Azam.
Dr. Akarvik, just one question. Do you see the entire exiting route?
Exiting route, actually.
Or you keep some part of the SAP and then put in your cage, then remove the rest of the SAP?
Okay, so I put the cage in before removing the medial wall. And after putting the cage in, we remove the medial wall of the facet. And at that time, we can, if we want to see all the part of the root, we can remove all the facets and also the phleboms, and we can expose all the traversing root.
I'm talking about the exiting route, not
the exiting route. Yes, we can visualize the exiting route after decompression.
After.
Okay, I have two questions. One, you said that you follow the joint line to create a tunnel.
Mm-hmm.
Now, in the MRIs which you showed me, majority of the facets were sagittally oriented.
Mm-hmm.
So you are getting the angle. But in facets which are, a lot of times they are coronary oriented. So in those situations, when the facet joint line is coronal, number one, do you still use the same technique? Because then, or like the same tunnel you go through, number one. Number two, how do you decide your angulation?
The angle.
Of what angle? Because I may burr, but I may land up going in, say, medially or laterally. So the exact angulation, how do you decide?
Actually, you can plan at the preoperative phase. And when you dock at the facet joint, you can identify the angulation by the C-arm. If you go through the disc or not. So if the direction of your burr is going towards the disc, and it should land at the posterior part of the disc.
No,
before.
but in AP, whether you're medial or lateral, whether am I going medially or am I going laterally or
okay.
am I going?
At AP, you don't. We want to land at the disc in AP, just medial to the medial pedicular line, not past the medial pedicular.
So you always take a X-ray and check before you start burring.
Yep. That's
and
right.
last, because you are burring, so your medial wall of the facet may be loose. So now when you're hammering a cage, like now when I ask my assistant to retract the nerve, I know how much he's retracting when I'm seeing the nerve, but you are not seeing the nerve here. So while hammering the cage, say I'm putting a big size, 13 size cage, it might tend to push the medial border of the facet more medially to retract the nerve.
Yes, that's right.
So in that, there is no control over how much that facet is going medially and, trying and going and hurting your nerve. Because when I'm retracting, I'm visualizing the nerve. So like before I put a cage, no, he's removing it later, but when you're putting the cage, at that time it might squeeze the nerve, right?
When I put the cage, due to the trajectory that I want the cage to be like more horizontal, so I try to drop the cage handle to the lateral to be more horizontal. At that point, I don't have any problem with pushing the medial wall.
You do not have a problem with the medial wall pushing in too much. So
sometimes it may broke, the medial wall broke.
Yes.
But it will float.
That makes your job easier if it breaks.
That's true.
But you don't want it to go and push the nerve away. So you've never had a bad post-op neuropraxia or radiculopathy because of retraction injury?
No.
It's never happened?
No.
Thank you.
Pleasure.
Thank you, Dr. Akarvik. Your laptop is there. So here made a path with the medial wall of facet and flavor keeping inside and making a track. Dr. Venter. Dr. Son is here.
Good afternoon, everyone. Yeah, so I'm going to be speaking about how we do fusions in South Africa, or in my practice. I've got some small nuances that I want to discuss. And I was glad that there was a discussion about amount of fusion cases as a endoscopist. So I went and looked at my number of cases over the last 4 years, and my statistics have changed quite interesting. So my open discectomies, they dropped off completely in 2021. I started doing a lot more micro discectomies and transforaminal discectomies. And then 2022, I was pretty much dominating on micro discectomy work. And 2023 came a huge change in my practice where biportal endoscopy started taking over. And we can have a look at that open TLIF graph. It's always been staying pretty much steady, but the UBE TLIF started lifting up there. And in 2024, we can see now I'm completely at the full endoscopy, and the TLIFs have dropped off. So that settles the debate, I think. But TLIFs do still form a very important part in our job. I break up my TLIFs into pretty much 7 steps, and I try and pass one step, then move on to the next step, and that's why it makes the procedure quite nice for me to prevent complications. Now, I thought I'd try and fixate on a few of these steps and how I do it differently. So the first thing is the osteotomy. This is my primary bone harvesting source for the autograft, and I do a modified Smith-Peterson type of osteotomy. I use a Sonopet, which is a harmonic bone scalpel, and it works beautifully. I basically just modified, I took off the suction off it, and it works beautifully to cut the bone, and I'm able to harvest within 15 minutes about 12 cc's of bone. I still use a fluoroscopy to just ensure that I don't cut into the superior pedicle or into the inferior pedicle when I do my cuts. I do 3 craniocaudal cuts and 1 lateral to medial cut. And I then use these bone pieces, I break them off and I take them out. And you'll have a look now, quite significant bone pieces that comes out. The reason why I cut them into 3 pieces is just to have them small enough to be able to come out, because it's quite sizable bone that you're harvesting. So that saves me a lot of time not having to go to the ASIS or to also not use BMPs or bone dust or any other form of bone. So just going to wait to show you how easily it comes out here. So just loosen them up and just lift up the bone piece, take a pituitary, and there you can see there's a nice osteotomy with good bone harvest there. And then I just take the SAP, that gives me access to the disc. Now, my cage and bone graft insertion, I also use a bit of a different technique. So it's not a PLIF, it's still a TLIF, but I've placed 2 cages, 2 expandable cages, titanium, from the same port. So I put my contralateral cage in first, and it's got a smooth edge of the cage, so it slides past the dura quite easily. And then I just use a punch which makes it flip, and it sits on the anterolateral aspect of the rim of the disc. So that's your strongest spot, and because it's got a nice large footprint with the 2 cages, you are equivalent to an A-lift cage just about. So I've done open-wise, I've done about 150, and then with the endoscopy, also about 70 levels, 80 levels of these cages, and I haven't had subsidence issues, which normally in the literature is the big issue with expandable titanium cages. Then the last nuance is when I do the screw insertion, I use this inflatable jack, which lifts the patient's from a flex position into an extended position. You can see the sacrum coming up into a more extended position, which gives me an indirect lordosis restoration. So at the end of my procedure, when I'm putting my screws, I'm able to lift that lordosis back up. So that's all good, but I thought I'd pause here and just talk about the big elephant in the room, the right-sided stuff. So what about prior left-sided surgery? This patient had a prior discectomy. She had failed surgery or failed conservative management after the surgery, ongoing back pain, ongoing leg pain. She's got this recurrent left-sided disc. I know Dr. Malcolm said he would go for another discectomy. The patient's a manual worker. She needed a permanent fix. So now, why do we limit ourselves to left-sided surgery? Do the fusion from the right-hand side. And I think we need to address this. We need to stop being afraid of doing surgery from the right-hand side and switching hands. I think we're all proficient surgeons. If you do enough of it, you'll become proficient with it. So this was the case. Drop the cage in here. Now, the main reason why I brought this, besides the right-handed side learning, I think there's great value in the adhesions that we encounter. So here you can see that dero on the other side is completely stuck down from the adhesions from the previous surgery. And what's the basic principles? You want to work from healthy tissue. That's why I worked from the right-hand side. Find your normal anatomy. That was, again, valuable, being able to open it and expose everything normal. Then bone is your friend. As you can see there, I'm trying to stick to bone. And then identify the neural elements. So this is a great product. And this is something that would benefit, I think, all of us. Mesna basically is a fibrinolytic that breaks down adhesions. So as you saw there, everything was going slow motion. It's actually because I stopped the infusion and I was putting this Mesna in. It's a clear fluid, so you can see through it. You infuse it, close off everything, and you wait 5 minutes. You can see the color change in there. And then you start flowing again normally. And then suddenly you'll see how the adhesion starts, just without forcing, it just starts coming. And suddenly you've got a workable plane. It's almost like the tissue just gives it in the natural planes that they were supposed to. So this has changed my revision surgery quite a bit in giving me more confidence in dissecting planes. So you'll see the tissue just, the longer you wait, the more pliable that tissue feels again. And it just peels away. This is probably about 10 minutes after having put that Mesna there. And that's right-sided fusion. So I think what's important here is embrace all your resources. So the bone scalpel, there's the cadence system, and the hydro pump. So I thought I had it all figured out. Unfortunately, I didn't. I've got a partner, and he's very clever. He's a big surgeon, so he loves this stuff. A-lift, O-lift, X-lift, and I'm trying to convince him go endoscopy, and he refuses. So I thought I'd bridge the gap. I'd come to him. So if you look at the sort of benefit graph here, there's a unmet step at the top there, and that's where hybrid surgery comes in, I think. So he said to me, bring me the evidence. I went and I looked. I could find one paper only. So this was 2021, OLIF with assisted biportal decompression posterior. So what is it useful for? You can do the ALIF, OLIF, and the XLIF techniques and use So we basically combining the best of both worlds. You can do deformity restoration from the front. You can do decompression, minimal invasive or endoscopically posterior, and have a patient that's happy. So
last minute.
L5S1, you've got the ALIF, oblique at 4-5, and 5S1, you can also use a sort of a oblique technique to get in for anterior, and then anything above L3-4 is XLIF. So that's the ALIF positioning, OLIF positioning, and XLIF positioning. So how do we do it first? We do the anterior part first, restore the anatomy. It's great for me because I've only got to do a half an operation. That's where we aim to achieve the fusion. Then do the posterior endoscopic decompression. But then importantly, I harvest bone when I do the decompression, and I do a bone graft posterior as well. So that's my sort of catch net. If Reggie's operation in the front fails, I'll give him a catch net for a fusion at the back. So this is just a quick show of the technique. So he uses these omnitract retractors to get in there. He finds his point there, he drops his cage, and he leaves me. Then at that point, I do the posterior decompression and bone harvesting and bone grafting, drop the screws, and that's the end result. Yeah, you can actually see the bone graft. This is 3 months after the fusion. So there's very good bone union at that area. These are the XLIF cases that we've done, the ALIF cases, and the OLIF cases that we've done. Just want to give thanks to my mentors and my teachers and my colleagues. Thank you.
Thank you, Dr. Shaun. Anybody want to ask few questions? So next is Dr. Alihan Dainek. Dr. Alihan, yes, is from Turkey. The transition from microsurgery to UB, endoscopic disc surgery in lumbar disc herniation.
Hello. My name is Alihan Dainek from Turkey. First of all, I would like to thank you to organization committee and Dr. Pestonji. I know you are tired. I'm going to be fast as soon as possible. And my topic is transition from the microsurgery to the UB endoscopic surgery. That doesn't mean kick off your microscope out of the OR. Keep it in the corner because at the beginning in your journey, you need it. And this is the mis-evolution, all you know. We start with the mini-open surgeries, later tubular system, and now we are trying to be good in endoscopic surgery. Microscopic surgery started with the Dr. Carnine, ENT surgery in 1924, and 1934, Mixter and Barr, they performed white laminectomy and discectomy via intradural exposure. And after 40 years later, Dr. Yashargil performed microdiscectomy. Microscope has some advantages. All of us is familiar these tools, and it has a high depth of surgical field. Illumination and magnification is good. It's ergonomic for the surgeon. Training and recording is possible, but on the other hand, it's cumbersome and expensive and possibility contamination and limited maneuverability. Now we use endoscopy in the wide open approach on indication, and it has a very high depth of surgical field and better illumination and magnification, but we use fluid medium surgery, and we have high maneuverability, you know. we can use not only 0-degree endoscope, but also 30 or 70 degrees endoscope. It's ergonomic. You can get recording, and also you can train everyone in the OR, not only your trainer, but also your nurse and also maybe anesthesiologist. And disadvantages is the expensive and needs some learning curve. These are the difference between the microscope and endoscope. And you are working very close to the working area with the endoscope. You are very close, and you can see everything very clear. And we have different visual angle scope, and now it's coming 3D endoscopic systems. And new BE surgery, we have advantages to use all the classical spinal surgical stuff and also arthroscopic stuff. It's still cheap. And we can use the cannula and the fluid irrigation as a retractor and working bimanually in the bilateral endoscopy. However, microscope is working environment is air, endoscope is water. Here is a two different surgery. This is the microdiscectomy. Maybe all of us perform it. And the other side is the endoscopic surgery. The difference is the fluid medium surgery versus air medium surgery. And the blood is paint all the tissue in the microsurgery. On the other hand, you can clearly see all the soft tissue and bone in their own color. And of course, theoretically, infection rate is decreased with the endoscopic discectomy. And the left side, we have a tubular retractor. Now we are pressurizing on the muscles, which is very important for the patient, for the people. So endoscopic system has some more advantages, and we are keeping going up. But some difficulties in beginners, and the speakers before me were talking about the triangulation is difficult at the beginning, but the orthopedic surgeon little bit very close to triangulation because they perform the arthroscopic surgery, but it's not big deal. Everybody can learn it. And the other point is portal placement is very important. It changes, depends on the surgical level and target specific pathology. So it's very important, appropriate portal placement. And creation of the working space is very important because there is no real joint space. You have to create your own working space. And another important, maybe scary problem with the protection of the neural tissue at the beginning, you have to be careful about the put your scope, oops, you can see that, you know, through the scope, radiofrequency, and surgical tools. Otherwise, you can damage the neural tissue. And the other problem is the red screen, bleeding. You can control the bleeding, continue control water inflow and outflow, bone wax, radiofrequency, and keeping blood pressure under the 100 millimeter mercury. And we talk about since morning the extended of the surgical time for multi-level pathology. At the beginning, you can stage your surgery. You don't have to complete your 3 or 4 level in one surgery. You can talk with the patient and you can perform first 2 level at the beginning, and then later you can complete all the surgical problems. And you have to know not only interlaminar but also extraforaminal approaches. You have to know all the tricks about the endoscopic surgery. And these are the complications all we talk about since morning, but you have to know the water-based complication. So prevent the complication and be happy with the, trying to be happy with the endoscopic surgery, you have to follow the endoscopic ladder of competence progression model. That means start with the easy surgery. If you are a right-hand surgeon, try to first left side interlaminar endoscopic discectomy, and later you can enlarge your indication. So this is the study from China that show us the learning curve almost for 54 or 60 cases still requiring to be mastered in UB surgery. On the other hand, the surgical failure rate decreased after the 90 case significantly. Thank you so much.
Thank you, sir. Any question? So I think the last speaker of this session is Dr. Deepak Srest. Is going to speak on UB for resection of ossified yellow ligament. So Dr. Deepak, please.
Good evening, everyone. First of all, I would like to thank the organizing committee, especially Dr. Malcolm, for inviting us. Since morning, we were talking a lot about the endoscopy in the disc pathology. Now it is the time to extend its use in the other conditions also. So I'll be talking about the UB for the ossified yellow ligament especially for the thoracic spine. Ossified yellow ligaments comes in varieties of pattern from lateral to the tuberous type, and this is one of the most common cause of the patients presenting with the thoracic myelopathy. The gold standard treatment for the thoracic myelopathy because of the OIL is the decompression of the spinal cord and its neural structures either by the laminectomy or by the resection of the yellow ligament or make it float. But there is lots of complications associated with that. For example, post-op neurological deficits can range up to 33%. The standard technique, as far as we know, is the standard open technique, where we remove the lamina as well as the ossified yellow ligament. But it has a very varieties of the perioperative morbidities, for example, dural tears, CSF leak, and since there is excess related damage to the muscles, and patients can present with the back pain or the instability later on. So nowadays, the options we have is endoscopic resection and the decompressions. It can be a uniportal or it can be a biportal. The distinct advantage of the biportal endoscopic for the resection of OIL is that you can have a independent movement of your both right hand and left hand, and you have a larger area of the visibility and the approach. This, as it's shown in this slide, the beautiful anatomical delineations of the structures can be seen with the endoscope for the OIL resection. And this has also been proven by the steep increase in the number of the literatures that has been published on the thoracic myelopathy because of the OIL. In the last 10 or 20 years, you can see there's a steep rise in the literatures related with this topic. The advantage of thoracic OIL is that you have as I said, the independent movement of right hand and left hand. At the same time, the excess related damage is minimal. For example, there's a less tissue injury to the muscles or the ligaments. And also you can resect the OIL with the minimal cord handling and the manipulations. And since there is a beautiful visualizations of all the structures, there is a possibility of complete resection of the OIL. Little bit about the techniques. The dominant hand should always handle the surgical instruments, and the non-dominant hand should handle the scope. Usually 2 skin incisions are made in the 3 centimeter apart, and the docking point is the inferior lamina of the superior vertebra. This is a small surgical video of 42 years female who presented with OIL at D11 to 11 with the thoracic myelopathy. And on top of that, she had also severe radicular pain in the D11 and D12 dermatome. This is a video. The bony work starts from the boring out of the inferior articular process, then the inferior border of the superior lamina, and you reach to the spinolaminar junction, and it come around the superior border of the inferior lamina and the superior articular process. This is a circumferentially manner. You bore out the maximum amount of the bone. Thanks to Dr. Pao, who taught us last time that you can use the diamond burrs in reverse order. It is safe, at the same time effective. You can see that I'm using the diamond bore in the reverse order. So it is very safe even around the dural structures or the neural tissues. Once you identify this is a boring of the superior border of the inferior lamina. With the CT scan, you have to first localize where you want to go the more resection. Usually the superior lamina covers the maximum part of the ossified LO ligament. So that's why the superior lamina has to be removed maximum as compared to the inferior lamina. So I have now completed almost all the bony work, and make sure that you have an adequate outflow channel so that your field of the area is clean, and at the same time they do not have a postoperative neurologic headache or the stiffness. Now I identified the ossified LO ligament. So keep on using the diamond bore, make it thin as far as possible, but do not make it free from all the borders, because if it is a floating, then you will not able to use the bore to thin it out, because you have to, otherwise you have to put the excessive pressure. Once it is thin out, you can use the micropen field or the hook to dissect out from the underlying neural structures and make sure that it is not adherent. Once you are confirmed that it is not adherent to the underlying structures or the dura, then you can slowly peel it off. There is always a temptation to remove in block. That is also okay. But as I said that, I always keep the lateral border of the LO ligament intact so that I can bore it out. So I remove in the piecemeal with the smallest 1 millimeter Carician rongers. As you see in this video, that I'm peeling it from the underlying structures, making sure that it is not adhered to the dura. And once that is confirmed, that is not adhered, then I remove either in the piecemeal or sometimes in total also. So you can switch the alternative probe or the pen field or the Caricians depending upon your convenience or the instruments which you have. So now this is the medial border I have identified. It is thin out. You can see that some cracks has appeared. So that is an indirect sign that now it is getting separated from the underlying structure. So this is the last piece on the lateral border, which is attached to the inferior articular process that I break at the last, so that that it does not float, and it allow me to put some resistance or use the Caricians to remove it out. So I'm now using the 1 millimeter Caricians and removing little by little. The bleeding from the bone has to be controlled either by the wax or RF, whatever you have. So this is a removal of the piece. The Corb RF is very, very handy to lift it up, at the same time hemostasis, and cut the underlying adhesions also. So I switch over the conventional RF as well as this hook RF alternatively for the dissection as well as the hemostasis also. So I'm removing the piece of the inferior articular process because this patient had a very typical of the radicular pain of the D11 and D12 nerve root. So this is almost after the resection, the removal of the inferior articular process, so that I can clearly visualize the nerve root. So once you can palpate and visualize the medial border of the pedicle, both superior and inferior to the nerve root, your dissection is complete. In this particular case, I have removed a little bit more bone so as to make the nerve root free. And to prevent the post-operative hematoma, I usually put the suction drain, and once you come out from you remove the scope, you can see that how beautifully the paraspinal muscles imposes to each other, and this is a pre-op and post-operative CT scan showing the complete resection of the ossified LO ligament. The few points of the cautions that you have to evaluate your pre-operative CT scans very carefully, so that you can identify the dural ossifications, for example, tram track sign, or the comma sign, or bridge sign, or the T2 ring signs. These all indicate probably there will be the dural ossification as well as ossified yellow ligament. In this particular case, you have to take extra precautions to prevent the dural injury, or you can make the ossified dura or the yellow ligament float. If it is adherent, you just thin out and make it float to prevent the dural or the neural structure injury. Small tears can be managed with the fibrin collagen patch in the sandwich technique. For example, you can put the taco seal. If it is large, of course, you have to repair under visions. I thank for kind attention. Thank you very much.
For our next session, that is on the metastatic spine tumors, I would invite Dr. Nandan Marathe to present his case.
Hello everyone, good evening. I'm Dr. Nandan Marathe. At the outset, I would like to thank the organizers for the opportunity to present our work. Today, I'm representing Bombay Spine Society, and we'll be talking in brief about management of metastatic spine tumors. So to start off, I'll be presenting a case. So this was a 77-year-old male patient. His primary cancer was renal cell tumor with mets to the spine. He presented to the clinic with new onset neck pain. VAS score was quite high. It was 8 out of 10. He was literally holding his head in his arms when he walked into clinic. Neurologically, he was neuro intact with no deficits. There were multiple comorbidities. He was diabetic, hypertensive. His frailty index was 3 out of 11. So this is what the CT scan showed. As you can appreciate, there was a lytic lesion in the odontoid. In terms of the SIN score, he was in the indeterminate category with a SIN score of 10. So with a presentation like this in an elderly gentleman, what are the treatment options that you have? Would you just treat it conservatively with oral medications, hard collar? Would you offer surgery? So to discuss this in detail, I invite the next speaker, Dr. Priyank Patel. He will be discussing about the algorithmic management of spinal meds, and I'll come back and discuss what we did with this case later. Thank you.
Thanks, Nandan. So I've been primarily a maximally invasive surgeon in a group of minimally invasive endoscopic surgeon. And I've been learning that like how in the degenerative conditions, everything has started moving from maximally invasive to minimally invasive and then of course endoscopic. I think even tumor is something where there's a lot of role of endoscopic surgery, and that's what I'm going to talk to you about. But मेरा हार्ड डिस्क खोलना है मेरा हार्ड डिस्क किधर है ये वाला जो लगाया ना मैंने उसको सिर्फ चालू करो हाँ निकाल देगा is a disc. नहीं मैंने डाल देख ये डालेगा ना इधर तो आना चाहिए किधर आई यूज मैक तो मुझे ये पहला वाला है कौन सा ये फर्स्ट वाला नहीं ये है ना दैट्स व्हाट या आई थिंक इट्स दिस या आई गॉट इट ये yeah so in order to evolve from being maximally invasive to minimally invasive, what is important is to understand the protocols and how do we approach a particular condition, and that is what we are going to bring through you as to if a patient comes to you with metastatic spine tumors, how exactly do you come across and decide the plan of the patient. And this is one condition where you're not just deciding what type of surgery or what surgery. Here you are starting the decision from, do we need surgery? Do we not need surgery? Are we talking about adjuvant therapy, new adjuvant therapy, and etc. etc. So the question remains is why spine mets? Well, 80% of tumors are going to metastasize to the spine. 20% is going to be symptomatic, and only 10% of them are going to be primary bone tumors. Now, this is old statistics. The thing is that as the the medical oncology and radiation oncology is getting better and better, we are now having much more symptomatic spine metastasis, which we have to deal with. So why do we really operate in spine mets? Well, it's either to establish the diagnosis or to manage the tumor pains or neurodeficit or instability or for a better quality of life. This is the reason why these are the indications for surgery in spinal metastasis. Has things changed? Well, the indications definitely have not changed. Expertise, yes, expertise has changed. But approach has definitely had a lot of changes over the past years. Now it's a spine surgeon who's actually an oncospine surgeon who takes the lead, and along with the oncophysician, oncosurgeon, radiologist, and radiation oncologist makes a particular plan. The plan is usually a multidisciplinary team meeting where the discussion is on the diagnosis, the staging, the plan of action, if you're going to do a curative or a palliative procedure, and that's based on the life expectancy and the fitness of the patient. Once we have all of these things, you can come to a conclusion and decide if the patient is going to require surgery, chemotherapy, or radiotherapy. The first step in the treatment of tumors is, of course, establishing a diagnosis. The diagnosis is not radiological, it's always tissue diagnosis. So it can be done preoperatively, which helps us to determine the type of the treatment that we are going to offer by the type of the tumor, the grade of the tumor, and if the tumor is sensitive to adjuvant therapy. But there are, of course, times where you don't have enough time to do a biopsy and all to get a diagnosis, and you have to go in for an emergency surgery. That time you can use intraoperative frozen section to come to a conclusion. But at the end of the day, you can use any of these techniques like a FNAC, bone biopsies, either CM guided, USG guided, CT guided, endoscopically. But at the end of the day, try to get tissue so you have some idea about what you're dealing with. Once we have the biopsy, and when you're getting the biopsy, try to get multiple core, the bony sections, the soft tissue sections, because you want to know, like there are different parts of tumors and you want to have a representative section from all of them. The second step is to plan. Well, when you're talking about the planning, at that time you want to know if you want to be conservative, you want to be palliative, or you want to be really, really aggressive. And there are a lot of scoring systems that have been developed over years. One of them is the Tokuhashi scoring system, which takes into account the general condition, the number of metastases in and outside the vertebrae, how much of the visceral tissues involved, and what is the type of primary tumor we are dealing with, and the neurological status. And based on this, you can kind of figure out if the patient has a favorable tumor type. Now, the meaning favorable tumor is basically for a surgeon, is the tumor something that you want to really go in and remove surgically? And if you are able to identify these favorable tumor types, then you would think about doing a really aggressive excisional surgery. Now, fine, you know that the patient is having a tumor which you can excise. The next question is the patient fit enough for doing it? Because metastatic tumors, the patients will have so many other conditions which we'll have to deal with. So there are some ECOG, Karnofsky indexes which are there, and based on these scorings, you can identify those patients who are fit patients to undergo a particular procedure, like a procedure for a tumor surgery. The next question then starts coming is that, okay, yeah, the patient is fit, we can do the surgery, but should we really do the surgery? How much is the surgery going to help? And there is where you want to also take into account the life expectancy of these patients. And there is something called as TOMITA scoring, which actually takes that part into consideration, telling us how aggressive do we do based upon the life expectancy. Now, here you'll have to use so many different things to, come to a particular plan. Now we have newer comprehensive scores to plan the same treatment, and primarily it works on NORMS decision framework. Basically, it takes into account the neurology, the oncological status, which means is it a radiosensitive or a radio-resistant tumor. It takes into account the mechanical stability and also the systemic disease where all it's involved. And based on it, it gives us an idea of do we do a systemic therapy, which is chemotherapy and other adjuvant therapies, or radiational therapy or surgery. And one of the best scoring system which actually incorporates all of this is called as a NSE score. It's standard, you can look it up, and once you have the patient in your hand, all you have to do is you have to calculate the neurology, see the stability, see how much is the epidural compression based on something called as the Bilski scale, and you will have some scoring over there. And based on the scoring, if the score is somewhere between 0 to 2, you don't touch the patient. If it is 3 to 4, it's in a gray zone where you have to take a decision based upon your experience. And if it is above 5, it's a clear-cut surgical case. Bilski scale is something that is important for us to know. Is later on you'll understand why this is important, but it basically grades the radiological appearance of metastasis, which includes if the patient is just having a body lesion, or does the patient have a epidural component causing pressure on the spinal cord. One other thing that is also important is a SIN scoring. SIN scoring is something that gives a doctor an idea about how unstable the lesion is. Now, why do we need to know Bilski scoring and SIN scoring? Is like how the entire world is moving from a maximally invasive approach to a minimally invasive approach. These scoring systems later on you'll realize helps us determine what kind of surgery and how much minimally invasive can we go to. So the third part, now, good old days, we used to identify a tumor who, which was a good tumor. So let's say it's an oligometastasis from the breast in a D6 vertebrae, and the patient is fit. So the old thinking was, yes, it's a oligometastatic tumor from the breast. It has a good long life expectancy because breast cancers are known to survive longer. So here the best thing would be the metastasis which is there, just get it out. And there is where the oblong spondylectomy came into picture. The concept is that you remove the entire tumor without getting into it. And for that, TOMITA, the WVB group, all of them work towards a lot of different techniques and have published, published scales or diagrams by which you can plot your tumor and see if you can remove it, and if you can remove it, by which approach. So the concept is that, let's say if the tumor is in the body, then you want to deliver the body without getting into it. So you need to have some tumor-free plane. And typically, if it's a content tumor, then you can kind of take a posterior cut and then you deliver the body from the back. And that's how you would have performed a oblong spondylectomy. Yes, it's a great surgery. Someone who has seen it or has experienced it, how it's as good as doing a very complex deformity. But the issue is that this is a very morbid procedure. There are a lot of complications. It cannot be done in a small sitting. you can have liters of blood loss, and then you have to deal with all these post-operative problems. For example, this is one lady who had a L5 vertebral body tumor. Now, it was an oligometastasis, it was a sarcoma. We did not know the life expectancy of the patient because it was an unusual spindle cell tumor, but it was oligometastatic tumor. And the patient was young, and like the best thing for the patient would have to remove the tumor as much as possible because this does not respond to anything other than that. Now, this was done years back when the other things were not into picture. So what we did is we went posteriorly, did a big, stabilized to about to below, dissected out the root, took out all the posterior elements, and then we went anterior, and after that we removed that entire body, replaced it with cage, and had a fantastic result. The entire tumor was out. We did not have any spillage, but I had to deal with deep vein thrombosis in the same patient for 6 months, and then post that the patient was able to live for 1 year and maybe 1.5 years after the primary surgery. The patient eventually passed away because of brain mets. The surgery was good. We were able to remove the tumor. Now it's cancer, so it can come back, it can metastasize, all of that is there. That's a different story altogether. But what I want to impress upon is the fact that of the 1.5 years that she had remaining, 6 months she was struggling with deep vein thrombosis and difficulty of mobilization because of that. So at the end of the day, we got to think that, how much have we really helped the patient? We've done good surgeries and all, but the morbidity is too much. There are several reports out there which tell about oblong spondylectomy, the safety, efficacy, feasibility. In fact, we also have one of the first Indian series which has been published. But the point then remains is we ourselves introspect and think that, do we really want to do this type of surgery? That is one question. Put that in your mind. Now, let's say if the tumor is not contained, it's already started spilling out. So then you start thinking about that anyways, oblong spondylectomy is not going to be possible because the patient has already spilled over. What to do here? Here you would want to think about the best local tumor control, like just a gross total excision followed by any adjuvant treatment, which could be open, minimally invasive, tubular, and now endoscopic. So a similar case came to us where we just did this. We just did a debulking and stabilized after our previous experience where a similar tumor we would have removed completely, but we had so many other comorbidities. Here we just did that, and in fact the quality of life of this patient was much better than the other patient's quality of life, although we did not end up removing the entire tumor.
Can we make it little?
Yes. So actually my other colleague is not there, so I'm taking both of the talks together. Yeah. So we did that, and then we realized that here we are doing less. We are not removing all the tumor. We are doing less, but the patient is mobile, and the comorbidities are lesser and lesser. And in fact, this patient, apart from spine, also had a megaprosthesis in the spine because we realized that the patient has got even a hip pathology. So then we realized that at least in tumor, there's a definitive role of minimally invasive treatments, because here you are not, there are so many other aspects that you have to deal with. And there is where all the newer generations, newer techniques are helping us do more and more by opening less and less. And this is where something new started coming up, because apart from this, there was a big group of patients who are those non-favorable tumors. Non-favorable tumors means tumors which cannot be completely removed or don't qualify for the true oblong spondylectomies. All right. And think about it, metastatic spine tumors, almost all of them come in this group. And here we have got so many other different treatment options that are available, which could be an aggressive intralesional excision. It could be palliative debulking. It can be just radiation. It can be clearance surgery with SBRT, or just vertebral body augmentation and percutaneous fixation. So these are all the different treatment options that are available for those tumors which are not favorable or not oligometastatic, which you can remove completely by doing a oblong spondylectomy. But for understanding and deciding, and really most of the patients that present to you will be in this group. They will be the non-favorable tumor types. So here you need to know a lot of other treatment options which are available, which are non-surgical. So you should know a little bit about chemotherapy, hormonal therapy, targeted therapy, checkpoint inhibitions, and different types of radiational therapy. And this, mind you, has really changed the way by which we deal with all these metastatic spine tumors. You have now moved from conventional external beam radiation to something called as stereotactic body radiation therapy, or SBRT or SRS. And then there are other types like proton beam, carbon ion, etc. Now, practically, SBRT is now available freely everywhere in India and almost all around the world. Carbon ion, proton beams are something which are not everywhere available. But the reason why I am telling you this is because this has completely changed the way we deal with metastatic spine tumors. Radiation is something that can kill everything. The problem with radiation is that radiation kills everything. So it kills the tumor also, and it kills the normal cells also. Now, if there is a tumor or a metastasis in the spine and you put radiation, there are very few tumors which can be dealt with conventional radiation, because tumors like renal cell carcinoma are something that cannot be burnt by the regular radiation. Why not? Is because when you give a regular radiation, what is going to happen is you are going to end up burning everything in its path. So you will have something called as radiation myelitis. To solve that problem, something started coming up which is called as stereotactic radiation therapy. Basically what happens is, in that, a high dose of radiation is given to a targeted element in your body from different sides, so that there is minimum collateral damage. This has suddenly changed the way we deal with spine tumors, is because now all we have to do is, whenever you have metastasis, you can burn that with the help of radiation. The only criteria for this is that the tumor should be away from the neural tissues. So this is where something called as clearance surgery, followed by burning of the tumor with radiation, has started coming up. The burning of tumor with radiation is called as SRS, or stereotactic radiation surgery. Why it's called as surgery is because you are using radiation to give surgical outcome. But sometimes what happens is, remember that Bilski score, you will have tumor which has spilled and it's pressing on the spinal cord. So before you take that patient up for SBRT, what you need to do is you need to clear that out from the cord. So this is where you can minimally open up that area and you can take out that soft tissue so that your cord is freed. And by what I saw all of you guys doing, this is something that can easily be achieved endoscopically. So big advantage is, without opening up the posterior part from the side or from the back, you can clear out the soft tissue. Now, once you clear out the soft tissue, the only thing that remains is the tumor in the body. When the tumor is there in the body, you can easily burn it with SRS or SBRT, basically single dose high fraction radiation or radiation 2-3 fraction, but it completely destroys the tumor. And when I say it completely destroys the tumor, it completely destroys each and every tumor. So with SBRT, there is nothing called as radio resistance anymore. So you have sarcoma, give SBRT, no problem. Criteria for doing that, you clear it out of the cord. Now, the only disadvantage of SBRT is, because you're going to hit the area with a high dose radiation, you're going to weaken the bone. And there is a possibility that the patient could end up developing fractures afterward. Remember, you're treating spinal metastasis. The patient is going to die. Your job is to make sure that the patient lives a pain-free walking period till the end of his life. Okay, so after doing surgery, if the patient develops a fracture, it beats the entire purpose. There is where sin scoring has coming in. So anytime a patient is undergoing a SBRT or a SRS procedure, you apply sin score over there, and if the sin score is positive, then you have to stabilize. So do a minimally invasive stabilization before the SRS, within 2 weeks, send the patient for radiation, and that's the end of your treatment. So these things that have evolved over time has suddenly made tumor surgery from being maximally invasive to a significant minimally invasive procedure, giving much more better quality of life. So that's basically how things have evolved over time. And cases like this, where there's a lot of metastasis, or patients who have minimal metastasis but are very high risk for surgeries, can be given a better quality of life, and maybe the last few months and years the patient will live pain free, happily and mobile. So these are few of our cases where again these patients were just stabilized, cleared, and then offered radiation instead of doing like a full-blown big surgery. Lot of exciting advances are there in the horizon. Lot of things are coming in into India. We are all excited as tumor surgeons, but remember, the future is minimally invasive stabilization, clearance surgery if needed, and radiosurgery, SRS, SBRT. That's what the entire world is moving for. And I feel that in the next 10 years, oblong spondylectomies might just disappear and will remain for very few primary bone tumors out there. Thank you for a patient hearing. And after this, I'll just ask Nandan to join in and again walk through his case. After this entire talk, let's figure out how to deal with that kind of a situation.
So thank you, Dr. Priyank. So this is the case that we were dealing with. There was a 77-year-old patient with a lytic lesion in C2 and a lot of neck pain. This is what we ended up doing for him, O-arm guided vertebroplasty. It fits well into the theme of this conference as well, that is minimally invasive solutions for spinal meds. So this patient did well. He was discharged on the next day. His pain scores significantly improved. At present, we have a 19-month follow-up for him, and he's doing okay so far. So to summarize, the classic surgical objectives for spinal meds were obtaining a tissue for diagnosis, decompressing the spinal cord, stabilizing the bony column. But as Dr. Priyank encapsulated, with the advent of SBRT, we can also offer separation surgery and be an adjunct to radiation. Few of the take-home messages that we want to discuss today are: for metastatic patients, you have to focus on quality of life so that their last few months are pain-free. As a surgeon, we want to believe that we are the captain of the ship. However, when it comes to spinal meds, you are just a part of a multimodal team, which includes oncologists and other people as well. Whenever you're planning big surgeries, you have to understand patients will be in the hospital for some time, and this will disrupt their systemic care plan, that is their radiation as well as chemotherapy cycles. So that is where minimally invasive surgery and separation surgery comes in, wherein you can offer treatment without disrupting their ongoing cancer care. Thank you everyone for a patient listening.
I never left.